Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
Good morning. We start this Saturday session, but it's quite an ambitious session because the topic, which used to be the forgotten valve, the tricuspid valve today is not forgotten at all. Actually, attracts a lot of attention, a lot of discussion, and a lot of interest. We're with a panel with excellent colleagues and friends, and we're looking forward to really have an hour of knowledge about the tricuspid valve. What we're going to have different compared to yesterday is that we're going to be a little bit strict, because yesterday the time was going, and at the end we're trying to manage to bring things together. So please, after we have 1, 2, 3, 4, 5 lecturers, so we'll try to keep the time a little bit. So we'll start with Dr. Kuzmas, who is going to give us an online lecture about the anatomy, nomenclature, and etiology of the tricuspid valve disease. Dr. Kuzmas was ready to attract your knowledge. Thank you.
Good morning to everybody. I'm going to share my presentation here. Okay, let's start. Firstly, I would like to thank Dr. Sparias and the organizing committee for this kind of invitation. I think Dr. Sparias is the expert of tricuspid transcatheter valve disease in Greek and European territory. So I'm going to start about the anatomy, nomenclature, and etiology of tricuspid valve disease. The tricuspid valve is the largest of the 4 valves, with an orifice area around 7 to 9 square centimeters, and its size changes at about 30% during cardiac cycle. It sits between the right artery and the right ventricle, preventing backflow during ventricular systole. It can be divided into 4 components: the leaflet, the papillary muscle, the chordal attachment, and the annulus. The anterior leaflet is the largest and most mobile. The posterior often scalloped shortest around the ring. The septal leaflet is least mobile, anchored to the septum, slightly lower than mitral insertion. The leaflets meet at commissures with important landmarks near the coronary sinus and aortic root, and the valve coaptation occurs just below the annulus with 5 to 10 millimeter overlap that allows some stretch without leaking. The papillary muscle and the chordae tendae, the tensor apparatus composed from the papillary muscle and the chordae tendineae. The papillary muscle will have the anterior, which is the largest, supports anterior and posterior leaflet. The posterior, the support the posterior septal leaflet, and the septal papillary muscle, which is variable. The chordae tendineae are fibrous cords that tether valve and leaflets to muscle or walls, while the septal chordae insert directly into the septum or with multiple small papillary muscles. These phenotypes can interfere with interventional procedures. The annulus is non-fibrous muscle structure with this-shaped 2 segments, C-shaped, and the free wall of right atrium and right ventricle and straight septal segments, contains muscular bands, minimum fibrous tissues. It's dynamic, its size changes about 30%, as already spoken, can delay in secondary TR. Important to know that the tricuspid annulus is not a robust fibrous ring. It's incomplete, especially in the segment corresponding to the right ventricle free wall. The annulus here, you can see an illustration about the anatomy, the normal, in the upper image, the normal tricuspid annulus in the short axis left and profile right view shows a saddle shape with 2 high points, anteroseptal and posterolateral, the yellow cycles, and 2 low points, the posteroseptal and anteroseptal, the blue cycles. The anteroposterior distance, the red line, is longer than the septolateral distance, the black line. Below, you can see a patient with functional regurgitation with a dilated annulus, which is now circular, more planar, with decreased high-low distance and increased septolateral diameter, the black line. So, in a fractional regurgitation, the annulus becomes more planar and dilated in the anteroposterior diameter. Some important adjacent structures, the non-coronary sinus of valve, risk of aortic perforation from transcatheter devices, the AV node and the bundle of teeth, risk of heart block. The heart rate coronary can be used to locate the location of the annulus, and superior and inferior vena cava serve as landing spots for devices during transcatheter heart procedures. Here you can see the coloration of tricuspid valve and the right coronary artery, the left coronary artery, the mitral valve, and the aortic annulus. The right coronary artery runs within the tissues of the anteroventricular junction, variable levels relative to the level of the leaflet annulus. Here we're going to talk about the Koch triangle. The septal part here of the tricuspid annulus marks the anterior border of the triangle of Koch, which is the anatomical landmark for the location of the anteroventricular node sitting at its apex right here. The posterior border of the triangle is marked by the tendon of Todaro, while the inferior border is the orifice of the coronary sinus. Here is an illustration of the correlation between the main tricuspid adjacent structure and the aortic valve. As you can see here, you can see the right coronary artery, the aortic valve, the arterioventricular node, and the coronary sinus. A classical slide about the tricuspid valve nomenclature classification and the incident of tricuspid morphologies. We talk about tricuspid valve, but mostly 54%. It's a 3-leaflet configuration, but we also have 2-leaflet configuration, 4-leaflet configuration, and 5-leaflet configuration in different types. We use a lot of imaging modalities to assess and diagnose the tricuspid valve disease. Here you can see some imaging modalities. We can see the utility of CT and MRI tricuspid valve intervention. Maybe sometimes the solution is only a 3D transthoracic echo, which provides an accurate assessment of the valve's anatomy from both ventricular and atrial perspectives. Finally, the fluoroscopy and moreover echofluorofusion can provide further information about the tricuspid valve anatomy during transcatheter intervention. In the second part of my presentation, we are going to talk about the etiology of tricuspid valve disease. The tricuspid valve disease includes a wide range of congenital and acquired causes and can manifest itself as tricuspid regurgitation, stenosis, or a combination. Usually results in and from systemic disease through hemodynamics, and early detection and treatment improves survival and quality of life. Primary tricuspid valve disease, less common, only 10%. It's about structural abnormality of the heart and can be categorized further into congenital, acquired, and usually manifest as tricuspid regurgitation. Here you can see some examples: congenital Epstein anomaly, tricuspid atresia, cleft valve, malformed valve with stenosis, infection, endocarditis with vegetations and leaflet destruction, inflammatory such as rheumatic disease with fibrosis, infiltrative carcinoid amyloidosis tumor with fibrosis, degenerative myxomatous degeneration with prolapse and organ rupture, and finally iatrogenic or traumatic from pacemaker, biopsy, or trauma. Here you can see some interesting image videos from different causes of primary tricuspid regurgitation. Here is a slide about the well-known carpet gate classification of leaflet mobility, about type 1, the normal leaflet motion, type 2, excess leaflet motion, type 3, restricted leaflet motion, and the classification of the different causes of the primary organic TR. Let's move on to the secondary tricuspid disease. More than 90% of tricuspid regurgitation secondary functional is a consequence of loading condition right chamber remodeling, results from major or ventricular pathology, needs many modalities to diagnose, and can be categorized further into lead-induced, left heart related, precapillary pulmonary hypertension related, right ventricular disease related, and atrial tricuspid regurgitation. Here you can see the key points about the difference between mechanism of the atrioventricular and device-related secondary TR. We can see atrial secondary TR that the annulus is significantly dilated and the leaflets are normal, while in ventricular secondary TR, the annulus is mildly dilated and the leaflets significant tethering. Here you can see a sum up, a table about the main differences about the leaflet tethering, the leaflet restriction, the right atrium and the tricuspid annulus dilatation, the right ventricular dilatation, and the right ventricular dysfunction, and the Carpenter and again classification of lymphomobility in the secondary fractional manner. About the type 1 is atrial and the type 3B is mostly ventricular. It's the no more forgotten valve, as already said. Survival is significantly worse in patients with moderate and severe tricuspid regurgitation, especially patients with chronic heart failure. Although it's only 0.4% treated, and we have a lot of options, transcatheter options for intervention according to differences in anatomy and physiology. And we can see here some pros and cons of transcatheter tricuspid valve replacement. We decrease regurgitation, procedural complexity, but we increase sustained results, but we also increase screening failure, AV blocks, RV failure, and vascular complication. And at this point, I would like to thank you.
Great, on time and very informative lecture, Dr. Kosmas. We cannot overemphasize the importance of anatomy. I was just talking with Dr. Kotoulas, and the only thing I could add is that before you start cardiac surgery, cardiology, if it would be possible to spend 2 months in a place that you learn really anatomy, if we all stop and think, it will be so helpful to know the anatomy in detail. And I think, personally, that it's missing from our training, good anatomy. And I enjoyed your lecture. Any questions, please? Thank you very much. On time, and we're going to proceed to... Please.
Congratulations for your presentation. We have to highlight the different kind of dilatation of the annulus. It's not the same with mitral valve. It's just for the free surface of the the right ventricle. So it is a different dilatation of the annulus. This is a critical point.
A small comment. Thank you for your comments. It's very important that we cardiologists need your experience, your expertise as cardiac surgeons in order to better understand the anatomy and the physiology of the tricuspid valve. It's a very complex valve, as I've already spoken, and I would like to thank you. I hope you enjoyed the presentation.
Okay, so the next colleague is Dr. Kromidas, talking to us about the best imaging modalities to visualize the tricuspid valve. Dr. Kromidas.
Dear colleagues, good morning. First of all, I want to thank the organizing committee for this kind invitation. There are no conflicts of interest. And the topic today is, which is the best imaging modality to visualize the tricuspid valve? What are the pros and the cons? So why is it important to visualize the tricuspid valve? It was said in the previous talk, actually the tricuspid pathology is quite common. It affects more than 1.6 million patients in the US, and it correlates with age. So in patients more than 75 years old, it's estimated to be, the prevalence is more than 4%, the patients that have moderate to severe TR. And also the mortality is substantially high, 15 to 5%, of course, depending on comorbidities. We can detect vegetations to diagnose in the context of endocarditis. We can estimate non-invasively the pulmonary arterial systolic pressure with echo. We can detect any masses like fibroelastoma on the tricuspid valve. We can assess the function of the right ventricle. We can diagnose carcinoid syndrome. We can visualize pacemaker leads, CRT leads, and the association with the cardiac structures. In the context of rheumatic heart disease, we know that tricuspid valve is commonly affected. And because of its anterior location, any trauma or any damage from biopsies is quite common as well. Other patients are exposed to radiation, so it's important also to visualize the tricuspid valve. In case of coronary artery disease, we know that there is an involvement of the right ventricle as well in RCA infarcts. And of course, in left-sided, significant left-sided heart disease, the tricuspid valve is also frequently affected. And as said before the previous talk, the anatomy is quite complex compared to the anatomy of the left-sided heart disease. So which are our imaging modalities? It was said before that 2D transthoracic echo, 3D transthoracic echo as well with biplane imaging, the transesophageal echo, very important, 2D and 3D, cardiac CT, cardiac MRI, and the intracardiac cardiography, 2D and 3D eyes. And let's start with the transthoracic echo. The advantages, it's widely available, it's non-invasive, the cost is low, so it makes it excellent for initial assessment. Of course, there are some downsides, and mainly it's the acoustic windows in obese patients, patients with severe lung disease. It's quite difficult to get proper images. Of course, when it's more difficult to assess the posterior structures of the tricuspid valve, and also we need to take multiple views in order to properly assess the valve. Here are some examples. As a first assessment, we can assess the mobility of the leaflets and to grade the severity of the tricuspid valve regurgitation, you can see with a 2D transthoracic echo. And proceeding to biplane and 3D echo, we can get real-time acquisition data and anatomical visualization, and we could get good quantitative assessment of the area and of the volumes. There are downsides as well. It needs some expertise. The learning curve is quite significant. Of course, the acoustic windows has also a limitation. It's of higher cost, and we need dedicated software and equipment, and of course, it's more time-consuming. Some examples. With 3D transthoracic echo, we can assess the anatomy of the tricuspid valve, and we can measure the 3D vena contractor, which gives us more detailed information about the severity of the tricuspid valve regurgitation. And proceeding to transesophageal echocardiography, of course, it's superior in terms of resolution compared to the transthoracic echo. It's excellent for pre-op interventions and planning, and for a dynamic assessment during transcatheter procedures. We have better visualization of prosthetic valves and of posterior structures, and we get real-time anatomical visualization. And of course, good quantitative assessment of area and volumes. But expertise is still needed. It's semi-invasive because we use sedation. It's of higher cost, and sometimes esophageal pathology may limit its use. Some examples of 2D transesophageal echo. We can see the good resolution of the images, and we can assess the severity of the tricuspid regurgitation and the etiology. We can measure the annulus. And with 3D, we get better imaging of the anatomy of the valves, as you can see. And we can measure the 3D vena contractor, which is a good estimation of the regurgitation, and also the tricuspid annulus with 3D TOE. Cardiac CT is very important. It has high spatial resolution, and we use dedicated software packages to perform advanced analysis. So it's excellent for pre-op planning and allular sizing in terms of structural intervention for the tricuspid valve. And it gives us detailed information of the venous system, of the diameter of the IVC, the femoral veins and the iliac veins, so detailed anatomy. Of course, there is radiation exposure for the patient, and there's always the risk for nephropathy, contrast-induced nephropathy, especially in kidney disease, chronic disease patients. And in terms of assessing the functional status of the valve, is of limited use still, even with 4D functional data. Some examples here, we can measure the tenting area, the tenting angle, the tenting height and computation head with cardiac CT. We can measure the annulus and get detailed information about the subvalvular anatomy and the papillary muscles. We can measure do some 3D measurements of the tricuspid annulus, especially revolving rings procedures. And we can also project virtual implantation of prosthetic valves in tricuspid valve. Cardiac MRI is the gold standard for right ventricular function and it's very good for assessment of tricuspid regurgitation. It's non-invasive and there is no radiation, and it's excellent for tissue characterization for fibrosis or masses. Of course, the temporal resolution is worse, so we can have limited visualization, direct visualization of the leaflets. It's of higher cost, it's time-consuming, and of course, the patient should be MRI compatible. So they use phase contrast images and 4D flow to assess the severity of the tricuspid regurgitation. Mainly, we use the MRI in order to get a good estimation of the volumes of the right ventricle and also of the function of the right ventricle in order to assess the etiology and the function of the right ventricle. And finally, the intracardiac echocardiography, which is now used more and more. It gives us real-time imaging during procedures, during tricuspid valve structural procedures. It has excellent near-field resolution and high frequency and frame rate, and better than 2D TOE. But it is invasive. Again, a learning curve is needed. It's of higher cost, and it's operator dependent. But it may be helpful, as you can see, especially in patients that have been operated for they had a previous surgery, and there is quite significant acoustic shadowing of the prosthesis. It's more difficult to assess with TOE sometimes. The septal leaflet you can see is prolapsing, but ICE was helpful in this case. And also with MPR imaging, we can get detailed information as well about the tricuspid valve, so it's helpful. So in conclusion, no one size fits all. I would say that best overall first line for initial assessment in transthoracic echo 2D or 3D. The best detailed assessment was given from 3D transesophageal echocardiogram. The best for RV function and tricuspid valve regurgitation is considered to be CMR. Structural planning, cardiac CT. And of course, the choice depends on patient characteristics, clinical questions, and available resources. And quite commonly, multimodality imaging is often needed for complex cases. Thank you very much for your attention.
Congratulations, excellent talk. I just want to add something to the volumes we measure in MRI. We can do, even though it's time-consuming, we can do this with 3D transthoracic, so we can have a clue about the volumes and the ejection fraction of the right ventricle, especially now that we also measure the RVPA coupling. We know, or the uncoupling is an adverse prognosticator for outcomes in transcatheter therapies.
Yes,
Congratulations.
and there's a good correlation of 3D with MRI.
Given the fact that the pacemaker wires sometimes are the cause of the problem, would you suggest after any implementation of a pacemaker not to finish the case before having a recent and again an echo to make sure that we can correct it before the patient goes to the floor?
Yeah, I think it's a good question. Yes, it's good to have a last view before the operation, because sometimes the first view doesn't meet the last view. Sometimes we have, so echo is quite easy to get. We get real-time acquisition data, and yes, it is safer for the patient to see that everything is normal. You can go home now. Yeah.
it's nice to become a routine because the patient is there. You put at that time you can correct things, and it's really awful
Just
to have
avoid
the
any
patient
complications,
having
yeah.
finished the pacemaker and having a 3+ regurgitation.
Yeah, sure.
Thank you very much, and we'll proceed to the next, keeping the time on time.
Okay, I'm very pleased to welcome our next guest speaker, Dr. Sawaya from the American University of Beirut. And he's going to deliver us a speech about the residual TR after transcatheter repair, clinical implication. Dr.
Hi, guys.
Sawaya.
You hear me? Yes. Can you guys hear me?
We hear you, but we can't see you.
All right. And now you see the presentation, or?
Okay, here we are.
All right. Thank you for having me. So we're going to touch upon a very important topic, which, you know, when we are doing all these clip cases, is a lot of time we leave with residual TR. These can be very difficult cases, and sometimes we cannot abolish the TR, and we need to know what is the clinical implication of leaving these residual TR. So if you look at the prevalence among the 3 major trials, if you look at the Triluminate trial, you see that at baseline you had 97% had severe to massive torrential tricuspid regurgitation. 52% of the cases ended up with trace and mild, around 38% with moderate, and 10% remained severe, massive, or torrential. For the Pascal trial, around the same thing, 42% with mild, 13% with none, 32% with moderate, and 11% with severe, and some left with massive TR as well. And in the BRIGHT registry, also you can see that there was significant, around 50% had more than moderate residual TR. So we see this is not a perfect procedure, and probably patient selection, case selection is extremely important. And if you look at also different registry, and if we want to look at 2+ and 3+, it goes anywhere from 10 to 20%. And the only one who had no major residual TR was a TriScent 2 trial, because this is a tricuspid replacement. So in replacement, you can go down to 0 TR, but that's not the case. For example, in Triluminate, the tricuspid FR registry, the Pascal registry, the BRIGHT, and the EuroTR. So that's very important to see that we leave these patients with significant TR and no less than 10 to 20%. And how does it impact survival? So in this trial from Stolz and European Heart Journal of Heart Failure, he followed the patient who had residual less than 2 and residual TR more than 3. And if you look at 30 days, 50% of the people with significant residual TR had a 50% 2-year survival versus 74% for the people with residual TR less than 2%. So this is the first signal that you can affect mortality if you leave a lot of TR. Okay, there's a lot of confounding factor, but leaving the table with more than 3+ TR is not good for the patient. And that's from the mortality standpoint. What about symptoms? And if you look at the change, this is the change in New York Class Association. And if we go from no TR reduction to more than 3-grade reduction, the change in New York Heart Class Association was gone from 40 to 63%. So people feel better when you decrease more their TR. So that's impact on heart failure symptoms. And if we look at the quality on life and functional capacity, also it's very important. This is a trial from Soraja, from Minneapolis group. And if you look at the quality of improvement, if you have more than 2-grade reduction, the quality of life improves, versus if you live with severe TR or no change, the quality of life worsens. And this goes as well also for the 6-minute walk test. And if you have a significant TR reduction, more than 2 grades, you have a 25-point change in your 6-minute walk test. So also very important to know that. And not only this, we look at symptoms, we also look at RV remodeling. If you look at the RV unloading, which is the reduction in your RV end diastolic volume, if you leave with the residual more than 3+, you have actually an increase in volume of 4%. And if you leave with residual less than 1, 18% reduction in your end diastolic volume. And this goes the same for the right ventricular end systolic volume, which also, if you leave with residual, your end systolic volume will leave. So the function and the volume of the RV is very poor. And if we want to ask, what do we predict by the residual TR? So you have multiple studies, but usually the worse the TR at the beginning, it will predict residual TR. If we have a big gap size, we're going to have residual TR. The leaflet anatomy, we have 4 or 5 leaflets, like a previous speaker showed. This showed that it's going to be more difficult to close. Jet location, if it's in the posteroseptal, it's more difficult than your enteroseptal. If you have a huge RV, a huge RA, sometimes it makes it more difficult. Having a pacemaker lead is always challenging in these cases. The lead TR is always the most challenging. Of course, imaging quality. If you don't have a good TE imaging, sometimes rely on ICE, because if you don't have good imaging, you cannot do a proper grasping. Also, if you have very dense chordae, especially in the commissures, this makes sometimes the cases more difficult. And also, if the annulus is extremely dilated, that's never a good case for a tear. You probably need replacement. And there's one score called the GLIDE score that predicts some of these TR reductions. So if you look at the septolateral gap, if it's more than 6 millimeter in the posteroseptal, it's usually not great. If you have multiple jets, not only in enteroseptal, which usually has the high success, makes it that you add more points. If the imaging quality is poor, it adds another point. If you have very dense chordae, that adds another point. And of course, the shape of the annulus. And then you look at the GLIDE score. If the GLIDE score is very high, that's probably not a good patient to tackle. So in conclusion, we need to try to leave the lowest TR possible, because residual TR impacts mortality, it impacts symptoms, it impacts quality of life, impacts RV remodeling. And I feel the future is going to be, if we have a good enteroseptal leaflet and the jet is in the enteroseptal, this is probably a good TR case. But for all the others, it's probably going to be a replacement device with a low pacemaker rate. Thank you.
Dr. Saguaya, thank you very much for your excellent talk. I have just a couple of questions. First of all is, if you realize during the procedure that you have a 3+ TR, how do you deal with this? And second, what is the percentage of these patients with residual TR that are referred for surgery?
Yeah, I mean, usually you can't do anything acutely. You try to spend as much possible time to get the low TR, but sometimes it's not possible. Sometimes you create deformation in these valves, so you can't really correct it. And you have two options after. You can either, I've had cases where residual was high, either you refer to surgery, but the majority of these patients, are rejected, they're sick, they come late, and they don't want to do tricuspid valve replacement. The other thing you can add after is a tric valve. So I've done like failed tricuspid triclip, and then you end up putting the tric valve where you put an SVC valve, IVC valve, just to decrease the risk of right-sided heart failure symptoms. But I mean, I never took off the patient table, directly sent him to surgery. You need to reassess him and decide.
Professor, let us get a little bit from your experience. You add a ring, you see the valve, and you are not happy. First of all, I want to emphasize that it's wrong that we're a little bit more lenient to the tricuspid compared to the mitral. 1+, 2+, it's okay. It's nice that you show that it's not okay. The only thing that's okay in these two valves is the 0, even trace. The more, it's harmful to the patient. But let's suppose you try this repair, and at the end you are not that happy. would you entertain an edge-to-edge stitch, or do you use any different techniques to complete the repair except the ring?
No, honestly, if you end up putting clips, we don't, I'm not a surgeon, I'm an interventionist, so I don't do the surgery. The other thing you can do is annular reduction, but all these devices, they're really complex and they're falling, we're not using them anymore. Or now the next step is using tricuspid replacement. But definitely, if the repair is not good, you have to send them to surgery. If your TriClip is not a good, or the Pascal device, you have to send them to surgery eventually. Like you said, the data is the data. Residual TR is not good, and we're very lenient in leaving these moderate plus, and we're happy. But at the end of the day, the patient is not doing well on the long run.
Thank you very much. We'll proceed. Thank you very much. We'll proceed to the next speaker. I hope everything in Beirut is well these days, because we've been in the news, Beirut and Lebanon. Are you okay and happy these days?
Yes, we're much better. 2 better days. Things changed tremendously over the last 2 months.
Good, because it's not only the tricuspid. Peace and being nice in your country is also important, in addition to the tricuspid regurgitation.
Thank you so much. Thank you.
Okay, thank you very much for being with us. We're going to present the next speaker, Professor Costache from Romania. We're coming closer to Balkans, and we're looking forward to have your experience about the annuloplasty for tricuspid regurgitation.
First of all, I would like to thank Dr. Spargias and the organizing committee for their kind invitation. It's always a pleasure and a privilege to be here in beautiful Athens, the capital of Europe for me, and of the birthplace of European civilization. So I'm a cardiac surgeon in Sanador Hospital in Bucharest, which is the largest private center and private hospital in Romania. And I have a privilege to work with Dr. Spargias. We started a few years ago when we did together the first transcatheter mitral patients in the country with the Pascal system, and ever since our practice is evolving. Talking about tricuspid regurgitation, as our previous colleague pointed out this morning, the majority of cases are secondary cases, between 75 to 85%. So any heart condition developing, resulting in pulmonary hypertension, will complicate with secondary tricuspid regurgitation, and also we have less frequent primary causes, and like endocarditis, Epstein, and iatrogenic. So let's look from a historical point of view of the surgical procedure that were performed in order to correct tricuspid regurgitation. And we had the De Vega, first of all, which was like a suturing technique starting from the anterior and finishing to the posterior, and doing a purse string in order to reduce tricuspid regurgitation in the young days of surgery. There are still surgeons doing it, and the K technique, which consists of transforming the valve in a tricuspid, in a bicuspid valve, and typical the classic annuloplasty procedure which consists in placing a ring. So that's a recent paper published last year on tricuspid repair, looking on an old cohort of patients where there were still patients with the Vega and K compared to flexible and semi-rigid rings. So the conclusion is obvious. Ridging annuloplasty yields better functional and hemodynamic outcomes than suture technique. And that's another study, an old study published in Circulation many years ago, showing the same thing, and also that this is important in terms of survival. And I think that will resume the conclusion against suturing technique. 15 years outcome on more than 600,000 valvular patient analysis done in the United States. So their conclusion is that suturing technique should be banned. Ring annuloplasty is far more superior, and this is due to the complex anatomy of the tricuspid ring. In terms of treatment, our philosophy is, I think we shouldn't perform full sternotomies anymore in these patients. Our approach is endoscopic by 6 centimeters third space intercostal approach, full endoscopic approach. We are the only center in the country performing this operation with the percutaneous cardiopulmonary bypass. And we have more than 1,000, our team has more than 1,000 minimally invasive valve procedure, and we are a center of excellence in training for minimally invasive heart surgery. So I will show you some of our cases. So first of all, we will talk about secondary tricuspid regurgitation, how we correct it. So typical patient, 67 years old female with mitral stenosis and tricuspid insufficiency. This is the preoperative echo, and this is our standard approach, third space, so not fourth space, third space is not patient. We open the pericardium, we will arrest the heart, and this is after doing the mitral procedure, we focus on the tricuspid, and you see this is why endoscopic techniques are far more superior than we have a much better view on the tricuspid or any valve than in full sternotomy cases. So we are pretty aggressive with the stitches placement, so we go pretty low on the septal leaflet, and we don't use patches. And this is a result, no regurgitation, and a beautiful 3D echo where you can see the valve and the tricuspid, the mitral valve and the tricuspid ring. What about, so secondary is straightforward, easy to treat in an endoscopic technique. So let's talk about primary cases. So it's a very common scenario, unfortunately. So in this gentleman that we recently treated him, so I put a TAVI on him in February, but he still had severe tricuspid regurgitation and due to pacemaker lead. So he had a massive and he was not doing well, and that's a preoperative echo on this gentleman. Because he was very frail, I looked with Dr. Spargus and it was impossible to do clipping in him due to this configuration and due to the absence of septal leaflet. And when I did the endoscopy in him, this is why we had an absent septal leaflet. Actually, the septal leaflet was good, but the chordae were sucked and were pulled inside the papillary muscle by the lead. So I had to detach the septal leaflet from the chordae, and there were no more chordae anymore because they were fibrotic and very short and into the papillary muscle. So we decided to put chordae. After the water test, I was not very happy. You see there is still a small leak after the water test. So I did an edge-to-edge repair, like that's our standard approach. When the chordae are not perfect, we are adding a leaflet technique. And with an excellent result on echo, and right now we have a 2-month follow-up for this gentleman. What about this edge-to-edge repair? It looks, that's a study from 2021 in Cardiothoracic Surgery, and to-end technique combined with annuloplasty is safe and provides a nice clinical outcome, which is solid on the long run. Also, one of our cases, 75 years old, with primary tricuspid regurgitation, and probably it was due to rheumatic disease, because you can see on the echo the leaflets are very short. There is practically no coaptation, huge gap. So even if the lady was frail, we did an endoscopic technique on her. It's a straightforward procedure, around 2 hours. And after placing the stitches we used in this, for this lady, that's my favorite band. It's a 3D band from Corsim ex Livanova Sorin group, with a very nice result on transesophageal echo and a good clinical result for this lady. So our center is also the only center in Romania who are doing the cone procedure. So the cone, that's a different procedure, different league. You can't do it endoscopically. That's the only case when we are going to perform a full sternotomy for a patient with tricuspid, who needs tricuspid surgery. So you see typical cone. The valve is implanted very low in the right ventricle. That's a beautiful image here. So impossible to do endoscopic repair here. So we have to do full sternotomy, and that's the result, nice result. And it was a young lady, and she's doing very fine. And that's the 3D echo. What is the outcome of isolated tricuspid valve surgery? I chose to present this paper because it is a paper that shows that it can be performed with zero mortality when it is done in experienced hand. So I fully agree with our colleague from the United States. Cardiac surgery is evolving, but far from that. Ladies and gentlemen, these are my conclusions. All tricuspid valvular lesions can be treated safely with video-assisted mini thoracotomy in a short procedure by experienced team. Surgical technique in operable patients are the only one providing a perfect long-term solution for patients with tricuspid valve disease. And I think currently surgeons should master both endoscopic and transcatheter technique. Thank you so much.
Congratulations, Professor Kostas. We enjoyed an excellent presentation. I see that you entertain the edge-to-edge repair if you're not happy with the ring. But I didn't understand probably well. When you said that if you're not happy by water test, or you come off bypass and see exactly what's going on?
So because we've did many cases, I've placed the chordae first. Okay. But the chordae, so chordae are easily to measure in mitral cases, but are less evident to measure in tricuspid. So usually when we do a water test, and I'm not happy with the chordae, I will put an edge to edge. It's no point in going out looking on ESO, because I'm sure it takes like 2 minutes to put an edge to edge.
Did you ever have any case of the tricuspid valve becoming stenotic, or any limitations to the edge-to-edge?
No, if you...
To the average valve, it's not detrimental. You can put edge-to-edge without causing any stenosis.
Well, no, because we have also the proof are all these transcatheter tricuspid technique, which rely mainly on 99% of edge-to-edge technique, and they rarely become stenotic. So also in surgery, we are very aggressive with the rings, and we tend to put small rings in cases like this, and they rarely become stenotic. Not in my experience. Possibly it may happen if you I don't know, if you put too many stitches or you take too much bites, but if you do a normal edge-to-edge and you do the good balance of it, and you have also cords. Cords are helpful because it takes the pressure from the leaflet. I think it's important.
Any questions?
Dr. Kostas, I enjoyed very much your presentation, and it seems that you're very experienced in endoscopic approach. So during your endoscopic approach, do you use double cavity cannulation or a single from femoral?
Well, actually, when I started in 2008, did my first cases, it was standard to do two-caval approach, even for mitrals. But I think, so right now we're doing two-caval approach only for congenital cases where we have big ASDs and we have to correct like pulmonary veins coming from. So it's no need in mitral or mitral plus tricuspid, in tricuspid cases, to do a bicaval approach. We have this nice wrap cannula from Livanova. Some operators, I never had the courage, don't snare it anymore. So you just have to put one cannula, even in big patients. Romanians tend to be big, overweight. We have
do you get any error in the system?
We never have error in the system. So one cannula, you put vacuum assist, it will collapse around the cava. And I put, personally, my advice is to put purse strings, 2 purse strings. But there are some colleagues who don't, but I think it's
Thank you.
Thank you very much, Professor.
I have
You have a question? Please, one question from...
question. Congratulations.
Thank you.
I have 2 questions. The first question is one of the reasons of residual TR is the lead of the wire, the lead wire. How do you manage it during the tricuspid plasty? And the second is when you do the edge-to-edge technique repair, what kind of stitch do you use?
So, excellent question, because there are papers and studies saying that when you are in this situation and you have damage due to a pacemaker lead, you have to remove the lead and put an epicardial stitch and do your repair, whatever you want to do. So I think it's a little bit abusive right now when we have good electrophysiologists. And so I leave the lead into place. I do my correction with ring, with edge to edge, with course. I will use in this, my ring will be a semi-rigid ring because you can put it around the lid as opposed to the band which comes with a circular frame and you will collapse the ring when you stitch it down. And regarding the stitch I'm using for the edge to edge, I always use a 4-0 or a 5-0 Prolink depending to the frailty of the leaflet with patch.
Just to give you an idea, to use a PTFE 4.0 and not to tie it, but just to put a core knot. If you do it, I think my idea is better, is stronger than the Prolin.
So it is indeed, and I'm a big fan of core knot. Also, I'm a personal friend of Jude Sauer, the inventor of core knot. So we did a lot of studies together, and we are part of their research team. And we are working on the micro knot, who is going to be used on the papillary muscles for mitral repair. The advice from the inventor of core knot is never to put a core knot on a leaflet. This is why he designed the system to put it whenever you want to do a mitral repair, to put it on the papillary muscle, then on the leaflet, because it can tear the leaflet.
Thank you very much, Professor. We're going to proceed to the next speaker. Dr. Kotoulas asked me intensively to present Fotis Mitropoulos. I don't know if it's positive or negative on what he has to say, so please proceed.
Fotis is a good friend of mine, and it is the last but not the least speaker here. And of course, he is one of the pioneers, Greek surgeons, cardiac surgeons in endoscopic cardiac surgery. So we know about the Romanian reality. Let's learn about the Greek one. Fotis.
Dear Christoforos, thank you very much for your kind words. Ladies and gentlemen, dear organizing committee, thank you very much for the kind invitation. Tricuspid regurgitation is a growing problem that affects quite significant portion of the population. If we look at the general population, it's up to 65% if we assess any form of tricuspid severity. As we get older, this number is constantly increasing, and in the age group of 75 and above, it's essentially pretty similar to that of the aortic stenosis. The tricuspid valve disease has been more frequently diagnosed because of the impact of the intracardiac devices implantation and the increasing prevalence of atrial fibrillation. We know all these things, so I'm going to try to go as fast as possible. One of the most common things, as you already saw, is the problem that we have with the pacing leads. This led to the development of a research consortium as to how we define the tricuspid regurgitation, the trial endpoints, and how we manage. I strongly recommend this paper by Han that was published in JACC, and sums up all the current knowledge and all the knowledge gaps that we have as far as the tricuspid valve, what we know and where we go. The European and American guidelines are depicted here. If we look at the difference, the American ones, class 1 for severe TR at the time of left-sided surgery. The European is a little bit more, I think, concise. Severe symptomatic TS or asymptomatic at the time of left-sided valve surgery, severe TR at the time of left-sided valve surgery, symptomatic severe TR without severe RV dysfunction, severe secondary TR at the time of surgery. This is the treatment algorithm if you have without concomitant left-side valve surgery and with. The current classification, I think, is a little bit more helpful than the original one and than the anatomic one. And I think it's very important that we talk and we use this language since this novel classification examines primary TR, secondary TR, atrial secondary, ventricular secondary, and CID. The TRI-score has revolutionized the way we talk and think about intervening for the tricuspid valve, and I think it's much better of a system. The more points you have, you see how the prognosis and the mortality changes. Risk factors: age greater than 70 years of age, class 3 or 4, right-sided heart failure, daily dose of furosemide greater than 125 milligrams at GFR less than 30, bilirubin, low EF, moderate to severe RV dysfunction. You can see the graph as how the mortality increases the more parameters you have. Papers have shown that the early surgery is associated with improved long-term survival. In one of these studies, and over the course of the years, the mortality of doing surgery for the tricuspid valve has significantly changed. Cardiologists sometimes say surgery for tricuspid valve has a mortality rate of close to 50%. That was decades ago, not anymore. Another study from a single US tertiary center, if you proceed with timely tricuspid valve surgery, the mortality is very low, and it does have impact on the survival. Video-assisted tricuspid valve surgery, first report 99. One more data on the endoscopic cases. This is a recent paper. What do we know about how we operate on these patients? Traditional sternotomy, minimal invasive, endoscopic. Those are all the studies that have been published. As you can see on the mortality rate, is not that bad anymore, with the exception of this study. It's single digit, 5, 7, 4, 4.6. So compared to what sometimes you read in the cardiology literature, it's not the same. For sure, the minimal invasive approach has had a quite significant impact on the mortality and the morbidity, and it looks like that the endoscopic might change things even better. We don't have any prospective randomized trial that has compared all these techniques. And for the most part is center-directed studies. One of the, you just heard, one of the well-known surgical centers that does a lot of minimal invasive endoscopic tricuspid surgery with how good results they have. In our program, over the past over 3 years, we have been employed with the endoscopic approach for all cardiac cases. At this point, we are over 380 cases. We had 2 conversions to sternotomy, 6 deaths. The older patient was 93 years old. The younger, we have been doing over the course of the time, smaller and smaller children. We're up to 12 kilos. This is our experience. 59 mitral repairs, 22 mitral replacements, 97 aortic, 11 cardiac tumors, 20 double valves, 11 tricuspid cases, 21 redos, and 138 congenital cases. Especially for the isolated tricuspid, out of those 11 cases, 9 were done beating. In 2 cases with intracardiac shunts, the cross-clamp tie was short. The ICU stay is relatively good for this kind of patient population, as well as the hospital stay. Decreased rate of transfusion, no mortality, 1 pacemaker implantation, 3 pleural effusions, and 1 leaflet seal. We use the periareolar approach on the right, and 2 accessory trocars for the stitches and the suction. This is one example of these cases. Can we play the video, please? Significant TID, significant TR secondary to CID. Next slide, please. Questo. This is the postoperative echo with trivial TR. This is the image 1 week postoperatively. And in conclusion, the endoscopic tricuspid valve repair is a demanding procedure but highly rewarding. It certainly requires a learning curve, and its length depends on personal adaptability of each surgeon to this relatively new technique. A high level of communication and group training is required for all the team members, including surgeons, anesthetists, perfusion, and nurses. It has to be mentioned that most of the criticism to minimal invasive has been overcome over the time due to the satisfactory results. The originally prolonged surgical times have been shown to significantly reduced, and morbidity and mortality is significantly reduced when combining the proper timing for surgical intervention with minimal invasive and especially endoscopic techniques. Thank you.
Thank you for this. So it is not a forgotten valve anymore.
It's never been for us. It's never been for us.
No.
I have a question. Congratulations on the talk, on the results. We know that edge-to-edge therapy is a class 2B indication in the European guidelines and not in the American guidelines. Do you have cases where you actually operate on secondary functional TRs when patients are very symptomatic?
Yes. Yes, we do. And having done these cases from traditional sternotomy to mini thoracotomy and endoscopic, I can tell you that the recovery period and the way that the patients go after surgery is dramatically better. So yes.
Any questions? If not, thank you very much, Dr. Mitropoulos, dear Fotis. We're on time, Dr. Sparias, and we're proud for this, and we're going to proceed to the next conference. Thank you very much for your early presentation in this early Saturday morning.
Morning. Let's start the next session, please. There's a change on the program. Firstly, I have to say thank you for this kind invitation to the organizers and Professor to Dr. Sparias. The changes are, first speaker will be Professor Vavouranakis. The case is with Pascal, case-based discussion. Professor Vavouranakis.
Thank you very much. First of all, I would like also to congratulate the organizing committee, Dr. Sparias, Dr. Patakos, for this continuation in providing education to all of us through this meeting. And I'm going to start to give a little background and then go to the case. So the tricuspid regurgitation challenges are here. We know that the mortality increases and the outcomes with medical therapy are not as good as we expected. Well, I think we start to realize that actually, and according to the data that I see here on some publications, the heart failure with reduced EF and atrial fibrillation might be better than having preserved EF. We see here the data and we see that actually it's getting worse with the tricuspid in this situation. Also, the atrial function related to regurgitation does not have a good prognosis, maybe some also difficulties treating that percutaneously. Usually, so we have to recognize the prevalence of TR, which is very high, and also that it is an independent predictor of worse outcome. It's an heterogeneous entity, and with the preserved EF and the atrial the regurgitation tricuspid, things are actually not as very promising as we know. There's a different categorical classification of whether it's ventricular, atrial, or device-induced regurgitation or primary TR. And tricuspid valve has some unique characteristics: dense chordae, thin and variable leaflets, and the annulus is dilating towards like a D-shape or forming valve. And we have some good modalities to look at the valve when we're trying to correct it percutaneously. Of course, fluoroscopic is the most used, as we see here, and we see how it looks on the fluoro. The most important, although, tool is the transesophageal echo. There are several steps when you do the procedure, and definitely when you have a good anatomy, your chances, previous speakers actually pointed up very well, you have more possibilities to have a good results. Small septal lateral gap, less than 7 millimeter, anteroseptal gap, confined prolapse, and trileaflet morphology. We wish to have these patients, Dr. Sparias, but they don't usually come like this. And so what we need to do with the tricuspid H2H repair, we need to have an optimal imaging. We have some tips and tricks that we need to follow, how to avoid the single leaflet device attachment, evaluate for a second device, and of course the 3D might be helpful. The three views that we need to do is, as we see here, during the procedure. Here we see the transcatheter, we see the septal leaflet on the right, we see the lateral, anterior, which is the posterior. There are two posterior leaflets. The transgastric view, as we see here, is very helpful to define the anatomy and also guide the procedure. We do the transgastric also to be able to do the grasping, as you see here. And now we have this fusion type of imaging, which we don't have it, but in our practice, in our institution at least, but this is something that might be helpful during the procedure. When you cannot do the procedure, some tips, of course, you can do opposite of Trendelenburg. You can put a pillow on the right shoulder, try to get better imaging. And definitely you want to avoid the side bites because this is an unstable, I would say, isolation of the leaflets. And the better you see, of course, like here, on the right side, the better chances are that you're going to capture, and you can verify this. Here you can see that your leaflet, the anterior, is not engaged well. This is better engaged. And when you're done with one clip, you have to reevaluate things, see if there is a residual leak, and if you have to use it a second clip. The Pascal has some unique characteristics, which I prefer for the tricuspid valve. There is relatively atraumatic grasping with the Pascal device. You have the ability by moving with the nitinol the system not to put a lot of tension. Second, you have the ability, despite the dense chordae which lies beneath the tricuspid valve, to elongate the device, and in that case, like we see here, to avoid being stuck down the valve, which is a very, I would say, discomfort situation. You have the independent grasping, which of course a lot of devices have it, and this is something that helps you to optimize your results, and this is very important. As we see here, this is not a theoretical concept, because on this experimental in animal studies, in the cadaver animal studies, we see that if you do a control with 2 bites, 2 times putting the Pascal on the tricuspid versus or the mitral versus 15 clasps, still you do not go above the threshold that you see here, the dotted line, which is the threshold for determining that you have a damage performed into the surface of the valve, on the leaflets. So we have any now, let's say we have any clinical data to support this use? Yes, we do have. We have the PACE registry and the TriClasp registry, both registries, excellent results. The PACE registry is anyone who is coming, in a European study, in a European registry, was involved. We have about more than 1,000 patients with high risk. We have severe TR, the severe TR 96%, complex anatomy as we see here on the right. And despite this, we have a very good result in reduction in the severity and a reduction in New York Heart Association. Of course, as you see, they are not 100%, they are not 95%, because there are limitations, as we'll see. The more experience we have, here it looks like from that study, the finding that if you do more than 21 cases, if you have done actually more than 21 cases, then the chances that you get the better results are more than if you have less experience. So in conclusion, it's a good modality and a technique to try to reduce the tricuspid regurgitation. It reconfirmed with the TriClasp study also, again using the Pascal, population more than 300 patients against registry, good result. Reduction, as you see here, it's not, again, 90%, but at least we have a significant, as you see on the Greek, reduction up to 1 year follow-up, and this is mild to moderate to 87%. And this actually is resulting in less hospitalizations and combined heart failure and hospitalizations, better results, and improvements in functional and quality of life, as we know from the other trials that have been published. The class 2 TR, this is a randomized trial comparing to Pascal versus optimal medical therapy, and we have a population which is sick population, as we see here, and we have the ability to implant the device with a relatively short, but not, I would say, minimal period of the procedure, 148 minutes. And we have very small numbers of SCLDA, 5.8%. But overall, there is an improvement in the reduction of the TR and also in the quality of life. And also there is an independent index, RV function, that seems to be improved, like the RV of stroke volume, the dimensions. So we have documentation that we have, and we can use this device to provide better outcome in our patients. Not ideal, but better outcome for sure. And less hospitalization also. This is a case that I'm going to present, very complicated, I would say. It's not just a tri-clip or a Pascal device that we put in a tricuspid valve. It's a case where we have a patient with multivalvular disease, difficult patient, 83 years old, with a previous UVA, some difficulty aspiration pneumonia from time to time. He came with heart failure, pulmonary edema, and I see here a lot of, like you see here, diabetes, chronic kidney disease, and all these other comorbidities. We did the baseline evaluation, that was a long time ago, and we see that there is some TR, 2 to 3 plus, but also there is this degenerative type on both actually sides of the heart, involvement on the mitral, on the bottom right, you see here it's everywhere. So the patient was of course refused by all the surgeons, 80 so much years old with a stroke. So we decided to proceed with first with the mitral, see the results, see what happens to the TR, hopefully to get less and not to have to do anything on this patient more than what with the mitral. The first procedure, as expected, was more than one case, one clip, that's a mitral clip actually. And the final results, which explain this, here was the initial, here was this smoke, was relatively good, we were satisfied with, and then 6 months later, he comes back with, again, everything opening, as we see here, and there's a leak both on between the two devices and also in the medial side. So, of course, again, 6 months after, the decision was to try to fix it. Obviously, there was some tear or whatever happened on the leaflet. This is a degenerative valve. This can happen, and due to high risk, again, we have to try to put a clip where we started, try to put the medial, the device where we expected to, you can see actually the mobility of the device that led to the significant mitral regurgitation. And we put the device in the medial, and then a few minutes later, we put the device. Again, the tissue was very fragile. We do have, again, more than the immediate initial result. So that the question was at the time what to do. There's a fragile tissue. So we decided, although it was very hard and difficult, to go with, in order to stabilize this device, to go and put another between actually the two. And actually, this is the procedure. You can see the mobility, at least, you know, by putting that device, we stabilize this and this in a very mobile valve. And yes, we managed at the end to have a good result. So this is the result of the mitral. And we thought, okay, we have finished with the patient. Hopefully, he's not going to come back. But after 1 year, he came back with edema on the lower extremities and right heart failure, actually. So we decided, the family decided, actually, and insisted to proceed. So we proceed now with thinking all these advantages of the Pascal. We proceed with the Pascal device, an ACE device, and I actually pointed out the benefits of the Pascal in this situation of the tricuspid valve. So we put the first Pascal, as we see here, and the second Pascal was the device here, and we have, as we see here, the procedure. And this is the final result for the tricuspid with a very, I would say, satisfactory. And looking also, let's see, okay, and this is the final result. So in conclusion, we report a successful case of redo both tricuspid, mitral, but also needed the tricuspid. And I think this is a very uncomfortable, but at the same time, the only solution situation in several patients that they have entered this high-risk age and a lot of comorbidities. So this is the end. Thank you very much.
Thank you very much, Professor Vavronakis, for your excellent talk and your case. How many clips finally?
1, 2, 3, 4, 5, 6. Different clips, although they are not the same.
Very good results, you know. And,
XT and D, Pascal.
Congratulations, you know, for your efforts for this.
He's doing well. He's actually back in his home. Oh no, he's not very, you know, walking around the city, but he's surviving well.
Would you consider to do a atrial fibrillation ablation as well in this patient?
For the atrial fibrillation?
Yes.
I mean, at that time, you know, with this severe MR and the functional and the anatomical changes on the atrium, it would be something that would be unfavorable anyway to do the...
Exactly. Dr. Spargias, any comments?
Well, it's an excellent result. I think this case demonstrates all the difficulties that we have to face in this cases that many times are very complex, like this one. So that was like a Barlow's mitral valve.
Yeah, Barlow.
And you had a very good initial result, but there is remodeling of the leaflets. So in the follow-up, we see that, especially the first 6 months, because after 6 months you have a good scarring.
Tissue, yes.
Yeah. So, yes, Dr. Patagos. So you had the relapse, and you tried with another device, as everybody would do immediately. You had the SLDA, and then the other option would be to go between. You had a very acceptable result, and this shows how you should persevere in these cases and not give up. Try to get a very good result on the table and not be disappointed if something goes wrong. Keep trying to get the patient stable off the table. And then for the tricuspid valve, as you said, Pascal makes easier, and you also had a very good result. So sometimes we do procedures together, and some others we wait for the tricuspid valve in the hope that it will get better after a few months. Obviously, and in this case, because the mitral valve procedure was so complex with multiple devices, even if I wanted to do the tricuspid on the same day, it would be a very long day, so I would leave it later on. From your experience, how many of the cases you've done a mitral procedure, and they also have a significant or at least moderate TR, they come back with better, with the reduction of the TR regurgitation?
Kostas, if it is, you know very well, if it's a functional, it will improve. It's a functional. If you have a severe MR, the valve does not look bad on the tricuspid, the leaflets are okay, but there is some, regurgitation, moderate, not torrential or something like this. And actually, we had some cases, like 3 or 4 cases where we do the mitral, and it improved significantly, so recently actually. So, and that's what the guidelines do it, but I think as an experienced operation, you have a feeling which one to expect to improve. And the other thing is, like we said, the tricuspid is a forgiving, even if you have a little moderate MR or, you can wait and then decide. So I don't feel like an urgency to do it because something might get better. The other thing is sometimes those patients, like this patient, the most problem was not the procedure, which was, of course, like you said, time-consuming, disappointing. It is that afterwards, when he went up on the unit, at least for 1 day, and then on the floor, he started to develop because of the stroke, aspiration pneumonia. So we have like a prolonged hospitalization with fever. You didn't know what would, So this is, I think, it's better not to mix several procedures together. That's my impression.
Thank you, Professor Vavronakis, for the excellent presentations. I would like to ask you, from your experience, how often is it to see more than 3 leaflets in the tricuspid valve, and if it does affect your plan for the procedure? And the second is there any value of pulmonary hypertension, systolic pressure of pulmonary artery, a cutoff that you must avoid to implant a TriClip?
Well, classically, if you are up to 70s, I mean, this is a problem here because you have severe pulmonary vascular resistance. It's going to improve unless you do your mitral, recheck with the right heart catheterization and see that everything has improved. So you have to document if you go on the high. And Triluminate also have an exclusion with 70, if I remember well, 65 to 70%. So I think you should do the mitral, reevaluate the patient, and decide whether you actually you should do or you can't do the procedure. So more than 3 plus procedure as from the beginning?
No, I mean, how often is it to find more than 3 leaflets of tricuspid valve?
Oh, you do. Especially on the posterior costas, I don't know, maybe, quite often we see P1, P2 leaflets. Yes, it's not very rare. But you decide which one to go, of course.
So the most usually P1 and P2?
P1, P2 are those that there are usually 2. I don't see, and occasionally the lateral, okay, you can see, septal is septal, it's usually, the problem is you have to have a good septal, like Costas, I think they have this case where actually it was, the septal was good, but it was tethered around the one they presented.
Dr. Patagos.
Another brief question, just to see how generous is our government to cardiac surgery and cardiology. We repeatedly ask for 1,000 addition to our budget for a cardiac surgery
Well, the clips are provided to the extra one without any cost. What is cost?
Just how much this costs?
No,
I don't care who pays those. What is the budget? What is the cost?
the cost is for what we pay, not what the company has spent. The cost is one clip. But the guiding catheters are charged. For example, if you used 4 guiding catheters, it will be extremely high. But in this case, for the clip, you use the same catheter. You don't use another one. So I don't know how much total is like, I don't know how much we'll charge for the clip one, but whatever you charge for one clip will be charged for the second clip, for the third.
It's per procedure. It's not per clip. It's per procedure. It's approximately the same with TAVI.
Same TAVI, yeah, it's not different. Yeah, it's not an issue of cost if you put 2 or 3 or 4 clips. Clearly this. If you put 2 or 3 TAVIs, it is a problem, because then you pay for the new device again. That's a different. No, it's provided.
Okay, no other questions. All right, let's move to the program. Thank you very much, Professor Vavouranakis. And now we can go, and it's Dr. Didangelos. It's online. Pre-procedural optimization and defining procedural success. Dr. Didangelos. Yes, we can see you.
Good morning. Can you see my presentation? Yes, is it okay? So, dear colleagues, good morning. I'd like to thank the organizing committee and Dr. Sparius for this kind invitation to take part in this great course every year. So now we'll see some guidance on how we can optimize our procedure and how procedural success is defined. We've seen that before. TR is now classified as a secondary due to ventricular or atrial causes, primary and due to pacemaker leads. The bad thing is that as the severity of the TR increases, then this vicious cycle of secondary TR gets worse and worse with RV dilatation, annulus dilatation, and an increase in the coaptation defect of the leaflets. There are 2 devices for tricuspid transcatheter edge-to-edge repair, the TriClip and the Pascal, as we've seen before. And now let's see what we have to do in order to optimize our procedure. First of all, tricuspid TR is a team play. We have to be part of a heart team to make a decision about the suitability for the TTR, to evaluate the patient, to plan the procedure, and make all the decisions according to the intervention. And this team has to involve many specialists, as we see here: cardiac surgeons, interventional cardiologists, heart failure specialists, cardiac imaging, electrophysiologists, anesthesiologists, and all the staff of the cath lab, in order to have an optimized result. The first and most important part of this process is, of course, to rigorously select our patients. And ideal candidates for TTR are patients with symptomatic tricuspid regurgitation, who have persistent symptoms and are at high risk for surgical tricuspid valve repair or replacement. Of course, the stage of the disease must be taken into account, because there are studies showing that according to the stage of the disease the patients are, then the results may be different. And usually we have to intervene in an earlier phase. And of course, as we've seen in that excellent case by Professor Vavouranakis, we have to take into account all coexisting valvular pathologies. According to the latest TEC guidelines for valvular heart disease, now TTR is indicated for symptomatic secondary severe tricuspid regurgitation in inoperable patients. The second step is to carefully select our imaging process, and this has a pivotal role in all this planning. Of course, we will all have a transthoracic echocardiogram as an initial imaging modality to evaluate the severity of the TR, the etiology, and all the other valves. And then we usually have to go on with a transesophageal one to have a better look at the valve, and very frequently 3D transesophageal echo, especially for the tricuspid valve. And we will also have to proceed with a CT scan in some of the cases. Another very important part is to optimize the patient's clinical condition before the procedure. So we should admit them at least 24 hours before the procedure in order to optimize their medical treatment. We have to be sure that they are on optimal guideline-directed medical treatment for their heart failure, and we should particularly emphasize on optimizing their diuretic therapy in order to achieve an evolemic state before the procedure. So we have to manage fluid volume overload, and we should have in mind that this may take some months to be achieved. But this will improve the quality of the echocardiographic visualization, and it will help reduce the coaptation gap between the leaflets in order to have a better result when we will try to put the device. There are cases in the literature where patients had to take diuretics even at home via peripherally inserted central venous catheters in order to achieve this F-volemic state and this optimization of the diuretics. And as was also described in that case before, we have to take into account all the coexisting comorbidities in order to improve the patient's overall status. We have to evaluate the frailty, to optimize the heart rate, to take into account any concomitant atrial fibrillation, to deal with any concomitant coronary artery disease, to check about pulmonary hypertension, and see if we were able to manage that before the procedure. Maybe we have to administer inotropes to support the right ventricle. We have to evaluate the risk of chronic kidney disease or an acute kidney disease. We have to manage the antithrombotics and evaluate the patient's risk of bleeding. And we have to evaluate the risk of any conduction system disturbances and be able to deal with that with pacemaker leadless or with leadless pacemakers. During the procedure now, there are some techniques that seem to enhance leaflet capture and the overall reduction in the TR. So we can manipulate the table and tilt it towards the patient's feet, like this is we can see in that image, in order to reduce the RV preload and minimize the coaptation gap. And moreover, we have to have some assist from our anesthesiologist in order to make adjustments to the patient's ventilation. So it looks that if we perform a ventilator-assisted Valsalva maneuver or applying PEEP with a ventilator, this acutely reduces the RV preload and improves the leaflet coaptation. And this will facilitate, of course, a successful clip deployment. Moreover, we can ask from our anesthesiologist to reduce the tidal volume to 200 to 300 mL and increase the respiratory rate in order to have the same result, to reduce the tricuspid valve respiratory variation and facilitate the clip deployment. And let's see now for the second part how we'll define our procedural success. There are several factors that influence and will give us a good result. And this can be divided into anatomical, device-specific, operator-dependent, and of course there are some very challenging scenarios. Anatomical factors involve mainly the size of the coaptation gap, the morphology of the leaflets, and the location and characteristics of the regardant jet. I will not get into details. There are some scores like the GLIDE score, which we can use to evaluate these factors. And of course, as more factors of these are involved, the worse the result will be. There are also some device-specific characteristics with the TriClip or the Pascal device. For the TriClip, there are many devices. The Pascal has the central spacer that may help us reduce the defect area between the grasps, and we can use them according to a selected case. Of course, operator experience plays a pivotal role, and as much procedures as an operator performs, this will lead to better technical outcomes, of course, and the reduction in the complications. Regarding the challenging scenarios, when we've got pacemaker leads or when the echocardiographic visualization is not good, then this will not help us to achieve an optimal result. Regarding the definition of the procedural success, this definition has evolved over time, and initially it was focused on technical aspects of the procedure, but nowadays the clinical improvements and the patient-centered outcomes are involved. And the latest definition and the international accepted definition is this one, coming from the TVARC group. It divides the success endpoints in two main categories: the intra-procedural technical success that is looked immediately after the procedure, and the clinical success measured at 30 days and beyond. This intra-procedural success involves all these parameters, of course, not to have mortality or stroke, to be able to deliver our device, to deliver no more clips than the ones that we have planned before the procedure, of course, to achieve very good results for the valve with no tricuspid stenosis and mild or moderate TR, and not to have forward flow obstruction or pulmonary embolism, and of course, no need for surgery or intervention in the first 24 hours. Regarding clinical success, that is assessed at 30 days and 1 year, we have also all these parameters that are involved in the intra-procedural success, and also these clinical ones that must be present in 1 year. So we shouldn't have any hospitalizations or interventions for the underlying condition, of course, for the TR, and an improvement in patients' symptoms and in patients' quality of life. Of course, all these avoiding bleeding, any other cardiac structural complications, acute kidney injury, myocardial infarctions, and any valve related complications. So regarding the pre-procedural optimization for TTR, this involves a heart team approach. We have to select our patients carefully. We have to implement a multimodality imaging and, of course, optimize the medical treatment of our patients before the procedure. Regarding procedural success, this can be divided into intra-procedural, that is technical, and evaluated immediately in the first 24 hours after the procedure, and clinical, that takes into account clinical parameters, except the technical ones, and has to be evaluated at 30 days and at 1 year. Thank you very much.
Thank you very much, Dr. Didangelos, for your excellent presentation. May I ask you something? During this pre-procedural optimization, at what stage, and if you are going to use the right cath, and if the results of that are going to change, you know, you're going to use any drugs to reduce the PVR if it's increased, or the systolic pulmonary arterial pressure, whatever?
Exactly. As I said, when there are multivalvular disease process and when you see a pulmonary hypertension from your echo evaluation, then you have to take into account the right heart cath in order to define the cause of the pulmonary hypertension, if it is post-capillary or pre-capillary and all that, because in case you have a pre-capillary hypertension, of course, this is not an indication to go on. We have to give medication. If it is a post-capillary one, then you have to optimize and maybe intervene for the left-sided valves first and reduce the pulmonary pressures and the PVR and all that, and then go on for the tricuspid procedure. So yes, right heart cath can be taken into account in several situations.
Okay. Any comments from Dr. Spargias? Any questions? Dr. Tsoukas?
Thank you for your excellent presentation. Just a comment. I think it's very important, and you mentioned it many times, that we must achieve the optimal medical treatment before to decide how we'll go. Last month, we have in our hospital one patient with acute pulmonary edema, severe aortic stenosis, mild MR, and severe TR. The first decision of the heart team was to continue with TAVI and maybe a TR and tricuspid valve clip. 1 month after the medical treatment, optimal medical treatment, the TR was mild. So we decided that the patient continued only with TAVI, and we avoid an operation or a procedure on the tricuspid valve. Thank you.
Well, thank you. Yes, it's an excellent result of how the other valves can interfere with the tricuspid valve. Thank you very much.
Okay. Thank you very much, Dr. Didangelos. No questions here. Dr. Tsoukas.
Okay, thank you. And we'll continue with Dr. Kostas Papadopoulos from Thessaloniki, who is one of my friends. He's an expert, and we're ready to listen to you for the presentation about selection of patient for tricuspid valve TER. Welcome, Kostas.
Good morning, everyone. Dr. Spargias, congratulations about the meeting. I'm sorry I can't be with you because today I also have some workshops here in a meeting in Thessaloniki. Maybe next year we can plan it. I took the challenge to talk about tricuspid valve, and let me share my screen. Okay, can you see my screen?
Yes, go ahead, Kostas.
Okay, so in the next 10 minutes, 12, we will discuss about the patient selection for transcatheter edge-to-edge repair for tricuspid valve. So we will focus on the anatomic criteria, but we listened to very nice presentations before about tricuspid regurgitation. It is a very common disease. It can affect the prognosis of the patient. It can lead to biventricular failure. We know that severe TR, especially if it is functional ventricular, has a poor prognosis of these patients, and we should take into account the presence of tricuspid regurgitation in our patients. When we evaluate this valve, we need to use all the available modalities, not only echo. Echo, of course, has the first priority, because it can give us evaluation of the severity of TR, the anatomy of the leaflets, the annulus size, the size and the function of the right ventricle, and the size of the right atrium. But if we want to evaluate the right ventricle better for the function and the size, and for tissue characterization, we need to use the cardiac MRI as well. Cardiac CT is mainly used for patients that we will have planning for transcatheter tricuspid valve replacement. Transesophageal echo is not the best choice for tricuspid valve because we have thin leaflets. We cannot align our probe with the fast view of the tricuspid valve, and we know that tricuspid valve is an anterior structure. It's the distance from the esophagus is big, and that's why most consensus documents suggest to use the 3D transthoracic echo because it is superior to demonstrate the anatomy and the variations of this valve. We can achieve images like that where we can see the septal anterior and posterior leaflets very easily. And we can also appreciate all the variations that we have recognized recently with the 3D echo. We know that the tricuspid valve doesn't have only 3 leaflets. We might have 2, 3, 4, or even 5 leaflets. And 86% of the patients that will come to our echo lab will have either the normal 3 leaflets tricuspid valve or the variation with the 2 posterior leaflets, the P1 and P2, which is the 3B variation. This is the most common variation. Here you can see a huge gap of this valve with 4 leaflets and anterior septal and posterior 1, posterior 2. And with 3D echo, we can recognize other variations like this one with A1 and A2 leaflets, or this patient with septal 1 and septal 2. It's very easy with the 3D transthoracic echo. Classification of TR is also very important. We know that we have ventricular or atrial functional TR, but we also have organic primary TR cases due to prolapse, due to rheumatic disease or carcinoid, and we also have a specific subgroup of patients with implantable electronic devices. We might have patients with prolapse like this one, where you can see that we have septal leaflet prolapse, very nicely demonstrated with 3D echo. But more than 90% of the cases have ventricular or atrial functional TR. It is very important to differentiate which is atrial, which is ventricular, because this will affect the prognosis and the adverse events of our patients. And there are some echo parameters that can help us differentiate what is ventricular TR, what is atrial functional TR, mainly the tethering, the size of the cavities, the tending area, the tending height of the leaflets. These are very important parameters to differentiate which is ventricular, which is atrial functional. For cardiac implantable electronic devices, we need to know the reasons why we can have TR at the end of the procedure. And according to this consensus document, we need to perform a routine transthoracic echo at the end of every implantation, because if we have a new TR that was not present before, then we have to consider of what was wrong in the implantation of this device. For severity evaluation, TR is more difficult than MR because we have a big valve, we have a valve that is an environment with low pressures, we have lots of variability of severity according to the respiratory cycle, and we need to use all the available tools from PISA method, from anatomy assessment, for inferior vena cava, the hepatic veins, of course, advanced methods like TOE with transgastric views for the location of the TR, the anatomy according to the transthoracic 3D echo, and vena contracta area are also very important. It is a multidisciplinary assessment and approach with different tools to evaluate the severity of TR. And of course, we know that severe is not enough as a term for this big valve. We have to use also massive and torrential with PISA method and vena contracta area, because we have found with transcatheter treatment that if we reduce the torrential TR to just severe, then these patients also have the clinical improvement. And that's why we have included this new classification into our clinical practice, but it's not yet into the guidelines. RV function is also very important. The standard 2D parameters are not enough to evaluate the right ventricle, like TAPSE and tissue Doppler imaging. We have to use the strain imaging as well in myocardial work. We have normal values that correlate very well with the CMR for RV function. And of course, 3D ejection fraction and volumes is the most accurate method to reach the volumes of cardiac MRI and have a nice estimation of the RV function and size. And we need to include all these parameters into our clinical practice. Apart from these, also RVPA coupling is very important, is an index of TAPSE towards PASP, the most commonly used, or we can also use the GLS. Okay, you can see me, sorry, I had a problem with my camera. Can you still see my presentation? RVPA coupling taps it towards PASP. The ratio is very important with a cutoff value of 0.4. If we have a high index, then these patients will have better outcomes after edge-to-edge repair. And there are some new methods that can include also the 3D echo to check the RVPA coupling. In my opinion, and according to these studies, we should measure this index every time we have a patient that goes for screening for transcatheter treatment. Transcatheter treatment has an indication of 2B at the current guidelines. Most patients should go for surgery, but the problem is that all these patients go very late for operation with already right heart failure, and that's where we have a very high mortality. For transcatheter treatment, we need to assess risk scores with this tri-valve score that includes atrial fibrillation, GFR, gamma GT, right heart failure, and LV ejection fraction, has a better sensitivity, specificity in comparison to STS score or Euroscore for detecting better outcomes and hospitalization in our patients after edge-to-edge repair. And all our patients should be symptomatic with optimal medical treatment with diuretics, volume overloaded, and we need to check the anatomy of the valve. We need to check the right ventricle. We need to check the pulmonary hypertension and organ damage, of course, for liver or the kidneys. We have a lot of devices available at the moment for implantation of or treatment, and we have an overlap of the indications for anatomic criteria for these patients. But we need at baseline, as we said before, to check the TR severity, the TR mechanism, the anatomy, the RV dimensions and function, pulmonary pressures, and the presence of left-sided valvular heart disease or LV function. Edge-to-edge repair is the most common method, again, like mitral valve. We know that it is effective, it is a safe method, it can improve the quality of life of the patient, it can lead to less hospitalizations and better survival. And we know from different trials that quality of life is the main result of this treatment, and we can have some survival increase in our patients as well. We have a sustained TR reduction after edge-to-edge repair and over the time. And we know that if we achieve at the end of the operation less than moderate of TR, then these patients have better prognosis and less hospitalizations. When we screen patients for edge-to-edge repair, there are some conditions that should go immediately to rejection of the patients, like rheumatic tricuspid valve disease, like patients with carcinoid and fibrotic leaflets with huge gaps, or patients with active endocarditis and vegetations. These patients should be rejected from edge-to-edge repair because it will be challenging and it will develop complications or high gradients or a suboptimal result at the end. But when we have routine cases that are screened for edge-to-edge repair, we need to check which leaflets are involved, if we have a good length of the leaflets, what is the gap between the leaflets, if we have a huge tethering, if we have leads, the location of TR, and horizontal right ventricle is also important, and if we have a good imaging quality. Most of the clips are implanted between anteroseptal leaflets according to Triluminate study, and we can also go and clip the anteroseptal or posteroseptal leaflets as well and create a triple orifice tricuspid valve according to the jet location, of course, and the experience of the operator. The gap, the coaptation gap of the leaflets is very important. There is a cutoff of 7 millimeters according to some papers that says that if we have a gap of more than 7 and a non-central, non-anteroseptal jet location, we might have a success rate of the procedure of 0%. So we have to avoid patients with huge gaps, and we have to avoid patients with non-central or anteroseptal jet. On the other hand, if we have central jet or anteroseptal jet and a small coaptation, we can have a success rate of more than 90%. And the length of the leaflets is also very important. This ratio of leaflet to annulus index shows that if we combine the gap of the leaflets and this index, and we have a high index, which means high length of the leaflets in combination with low gap, then we can succeed an operation with low residual TR rates. If we have leads, but they are in the commissures in a good position, then we don't care because we have a good outcome. But if we have impinging of a leaflet or we have perforation, then this patient might be rejected from edge-to-edge repair. So overall, these are the parameters that will characterize a patient as green, yellow, or orange, red. And we shouldn't reject the patient from this method, but we should call it as a challenging case. We have this GLIDE score. It was recently published, which includes the gap, the jet location, the imaging quality, the chordal structure density, and the unfast TR jet morphology. If we use this GLIDE score, we can predict which patient will have success at the end of the procedure. And of course, as I said before, we shouldn't reject easily a patient from edge-to-edge repair because we can also repair complex cases with massive or torrential TR, with huge gaps, with more than 3 leaflets or devices into our way. But we should also know our limits. This patient was rejected from edge-to-edge repair because of huge gap. You can see that the gap between the leaflets is 14 millimeters. We have a huge right ventricle with a reduced ejection fraction and a wrong position of an apical position of this lead of the device that developed torrential TR with triangular signal here, hepatic vein systolic reversal, and an inferior vena cava of 47 millimeters, huge RV with reduced ejection fraction. So we should know our limits and not treat all patients. So in concluding, we know that TR affects the prognosis of the patients. It is challenging to evaluate the severity and the anatomy of this valve. We need at least 3D echocardiography for the anatomy and the variations, and we might need cardiac MRI for the RV function and tissue characterization. And when we screen patients for TEER, we should include anatomic criteria, clinical criteria, and RV function into our assessment. And of course, we must be realistic. We will reduce hospitalizations, we will improve the quality of life of the patient, but not necessarily the survival. Thank you very much for your attention.
Thank you, Kostas, for your excellent presentation. It is clear that we must evaluate the RV volumes and RV function, ejection fraction before every procedure. Do you think that even with new softwares for 3D evaluation, transthoracic, I mean, of RV volumes and RV ejection fraction is accurate, or we must continue with an MRI?
Panos, thank you for your question. According to all papers that were published for 3D echo, ejection fraction correlates very well with CMR, with a variability of around 3 to 5% of ejection fraction, which is very low, you know better. But we still underestimate the volumes. So about function, I think we can be accurate with the 3D method. But for volumes, we still need the CMR. I don't know if from Dr. Sparias or Dr. Niños, teams that have great experience in TR, if it is in their common practice to go for CMR in these patients. But I think with 3D echo, we can have an accurate assessment of the patients.
Okay, I agree with you. I try many times to measure the volumes of RV with 3D echo from transthoracic views, and I have different values in the same patients.
Imaging quality plays an important role. If you have a good baseline imaging quality, you can count on your images. But if the patient has poor acoustic windows, then CMR is important.
Yes, the important is that you must have best images. Okay, any comment? Dr. Sparias.
Kostas, hi, thank you for the presentation. I think the invasive echocardiographer so far had to give us an idea from the screening if that case will be feasible, easy, or difficult. But I see that now things become more complicated for you guys because with the advent of TTVR, the possibility to replace the valve transcatheterally with a VOC, now you also have to decide when you do the screening if this patient is better suited for TEER or for a VOC. And so your role becomes more significant, and this is a question also to Professor Ageli and to Vlasis, who may be online. Who will be the one to decide for a patient that is not very good candidate for TEER, which way to go? So this is just food for thought for also the next presentation. So it's not only easy or difficult case for TEER or unfeasible, but if you're not sure, you have to decide which way to go, and this decision will be very important because it will be irreversible in most cases.
Okay, thank you.
Congratulations for your presentation. May I ask you, atrial versus ventricular secondary TR, the difference is all in the prognosis, or you might have to plan a different procedure, as the size of the annulus might be different between the two of them?
Of course, the prognosis is totally different between atrial and ventricular, as it is in mitral valve. For planning the procedure, I think the anatomic criteria that we presented before are enough for deciding if the patient is suitable for TEER. So if we don't have a gap, if we don't have leaflets, if we don't have, for example, a location that comes from posteroseptal, then we don't have issues for edge-to-edge repair. And I'm not sure if we have very flattened leaflets, if this makes the grasping difficult for the interventionists. And this is something that the interventionists should answer. But in my opinion, if the anatomic criteria are met, we don't have issues for atrial functional TR.
Thank you, Kostas. We have to move on. So our next speaker is Professor Angeli, who is going to talk us about peri-procedural imaging, finally. Professor Angeli, thank you.
Good morning. Thank you for this kind invitation. So, no conflict of interest. We have realized that the right-sided valves are often neglected. Guidelines are less definitive, and the significance can be underappreciated on imaging also, and management is complicated and dependent on mechanism. So we have already discussed the new appreciation of complex anatomy of a tricuspid valve, according to the Rebecca Hahn. And we know that the 50% of patients with tricuspid regurgitation have 3 leaflets, and the rest of them have 2, 4, or 5 leaflets. So a little bit more anatomical data. We have already discussed that a tricuspid valve annular has a saddle shape and has a more than 20% change in area during cardiac cycle. And we have already realized that the tricuspid valve annulus is a virtual annulus. It's not a fibrous one and has a smooth transition from atrium to ventricle. Tricuspid etiology, more frequent, secondary TR 80 to 85%, primary TR 10%, and 5 to 10% pacemaker lead interference. And we know that tricuspid regurgitation is associated with increased mortality dependent on pulmonary pressures and right heart failure. And we have already realized that at least moderate TR is independently associated with increased mortality, not only in hospitalized patients, but all comers patients. So we have better understanding the anatomy and pathophysiology of tricuspid regurgitation. And this is an old slide demonstrates the historical thinking of tricuspid annulus. And we know that annular diameter of 70 millimeters measured interoperatively from the anterior septal commissure to the anterior posterior commissure correlates to the diameter of transthoracic echocardiography from an apical four-chamber view, and we measured as 40 millimeters. We have discussed for the different tricuspid secondary tricuspid regurgitation, and we realized that ventricular secondary tricuspid regurgitation, all these patients have less annular enlargement and theoretically better leaflet coverage, but more RV lengthening and eccentricity compared to the atrial functional TR. And a single 2D diameter cannot fully describe tricuspid annulus geometry. We need a 3D echo just to demonstrate all the anatomical data of tricuspid annulus. And we have already demonstrated that ventricular tricuspid regurgitation and atrial functional regurgitation have not only different clinical and morphological characteristics, but also different echocardiographic characteristics. Tethering is more severe in patients with ventricular functional tricuspid regurgitation compared to atrial, and we see that the tenting height, tenting area, tenting volume are higher compared to patients with atrial functional regurgitation. And it's very important to present that end-systolic right atrium to right ventricle area ratio is less than 1.5 in patients with ventricular function tricuspid regurgitation compared to atrial function. There is a correlation, a good correlation between tricuspid annulus area and right heart chambers. Annulus area, as demonstrated by 3D, was more closely correlated to right atrium volume than the right ventricular volume. And right atrium maximum volume was the most important predictor of tricuspid annulus size, accounting for 58% of tricuspid annulus area variance. Regarding atrial functional tricuspid regurgitation, it's very important to present that the larger RA area and RA to RV area ratio were independent risk factors for significant atrial functional regurgitation. This slide has already presented functional as atrial or ventricular tricuspid regurgitation, device-related regurgitation, and 2 to 5% organic primary regurgitation. The previous slide demonstrated the phenotype, or the different phenotypes of tricuspid valve regurgitation, but this slide demonstrates the phenoclusters of patients with severe tricuspid regurgitation, incorporated many other parameters, are renal, hepatic function, LV function, and many other laboratory and clinical parameters. And we realized that all of these clusters have similar 5-year composite death and major events. Let's move to some important topographic landmarks of tricuspid valve commuters and leaflets. And when we depict the tricuspid valve, we have to depict the coronary sinus and the anterior muscle. Different phenotypes of a tricuspid valve with 3, 2, 4, or 5 leaflets, and the tricuspid annulus anatomy. Using transesophageal echocardiography, we can depict the anatomy of the tricuspid valve at the mid-esophageal, deep esophageal, and tricuspid views. Tricuspid view is very useful view. It gives the tricuspid valve a short axis, and we do the procedure, TEER procedure, using just only transesophageal, deep transesophageal views. These are the different anatomical data when we prepare a patient and when we assess the eligibility of for tricuspid TEER procedure. Coaptation gap less than 7 millimeter, anteroseptal jet, the leaflet morphology, and the right ventricular function are good right ventricular function are favorable echocardiographic data, and favorable data were larger coaptation gap and anteroposterior jet. Not only anatomical factors, but also center experience involved in the decision to perform TEER procedure. I would skip this. It's very important to evaluate the post-TEER procedure residual TR. We have to use all the advanced echo techniques and also CMR, but we have many difficulties in evaluation of residual TR, because vena contracta adding multiple jets has not validated. Abnormal shape of proximal flow may result in pizza radius, in overestimation of pizza radius, and we try to use 3D in order to evaluate the residual tricuspid valvular regurgitation. Rebecca Hahn suggested that the core imaging laboratories provide a standardized and homogenized evaluation, reducing variability and ensuring consistency across sites. Let's present a case, 83 years old woman with a huge V wave, atrial fibrillation, and you see before the procedure, TEER procedure, that this shape of LV, bilateral dilatation, particularly RA, and as RV wave 8 centimeter. You see that we categorized as massive tricuspid regurgitation with vena contracta with 17, pizza radius 12, systolic hepatic vein reversal, PASP 15. The patient presented pseudoconstriction pattern due to loss of pericardium reserve. And this is transophageal views. You see the massive tricuspid regurgitation. And according to right and left heart cardiac catheterization before the procedure, the patient had not severe pulmonary hypertension, pseudoconstriction pattern of a deep plateau, and again V wave of severe tricuspid regurgitation. And we proceed to the TEER technique with one device implantation at the septal and anterior leaflet. And this is the pre and post-procedure evaluation. You see that the residual moderate TR, RV positive remodeling, you see the difference, PASP of 30 millimeter of mercury, and no pseudoconstriction pattern. Another case with detachment, single detachment of a device, and the second clip was implanted with mild residual. So, dear Chairman, ladies and gentlemen, we think that we have to evaluate the patients using all the imaging modalities before the TEER procedure, just to have the the excellent results. And we all know the true illuminate TR results of 2 years that demonstrates that quality control improved, and the patients have less hospitalization. But furthermore, the promise of AI must be tempered by the known biases of these methods, particularly for imaging modalities such as echocardiography, for diseases such as DR, specifically in which arrhythmias, respiratory phasic variability or image quality must be particularly problematic, but AI may help to identify phenogroups with different clinical risk profiles, and furthermore, computation remodeling, it may significantly improve our ability to understand tricuspid valve biomechanics and to predict the results of a planned intervention, and adding the right ventricle into computation models of TR will allow prediction of the short and long-term effects of tricuspid intervention on RV function. Thank you for your attention.
Thank you, Professor Angeli, for the presentation. What is your screening method nowadays? Are you the one who decides if a patient is a good candidate for TEER in the tricuspid valve? Is it a heart team approach?
I think it's a heart team approach, and we discuss in every case. We're going to decide which procedure we have to select. According to the previous question, I think that we proceed to the EVOQUE implantation in patients with good right ventricular function. We need to have good right ventricular function with a good right ventricular reserve function. And it's not necessary for the TEER procedure.
I was intrigued by your last two slides about AI involvement in the diagnosis and treatment of tricuspid regurgitation. Would you like to add anything more on
no, I have. I just find a publication, and I think that we had to proceed to phenocluster of these patients because we have to evaluate not only the cardiovascular imaging data, but we have to incorporate also clinical, laboratory, and renal and liver function data, just to see which phenocluster of TR patients have a good prognosis or not.
Too many things for the human brain, so probably AI will be very helpful there. Like Thanos said earlier, tricuspid valve is so elusive valve, so you can have severe TR one day, and then after a few days with some medical interventions, it may be completely different. Preload, afterload, loading conditions, so many things that come into play. And so difficult also to predict the outcome, not only the anatomical, but also the clinical outcome after our intervention. So definitely I think there will be a lot of space in the AI field and the computational models you mentioned to help us in the future.
Yeah. Thank you.
I don't know if there are any comments from Professor Kilic.
Thank you. Professor Ageli, congratulations for the nice presentation. In one slide of Professor Ageli, there was an answer of the question that which patients are suitable for transcatheter edge-to-edge therapy and which patients are suitable for transcatheter valve replacement. Especially the right ventricular function, TAPSE, the others are important, but could you open that slide maybe again? So what's your opinion again, the same question that Professor Sparger asked twice. It's very important for us that which patients are suitable for TEER and which patients are suitable for transcatheter tricuspid valve replacement.
Okay.
In one slide, it's very, you summarize it, the back.
Yeah, we have presented several times the favorable and not favorable anatomical data. And the center experience also plays a crucial role. And of course, the precise evaluation of RV function This is my opinion.
Okay, thank you very much, Professor Ageli. Let's move on now, and we must call Dr. Niños from Salonika. Case with tri-clip. Dr. Niños.
Good morning from Thessaloniki. It's a great pleasure to participate, and I'm really sorry I couldn't make it to Athens. To this legendary Congress. Really, THV has been pivotal for transcatheter heart valve therapies, and thank you, Kostas Spargias, for making that happen. So it's a great pleasure to present the TriClip case. Following on the previous discussion, it's very important that we're now discussing about the tricuspid valve. We all recognize that this is not just a valve disease, it's a syndrome. It affects pretty much every organ in the body, and as we recently had a working group on that, and one of the colleagues said, just walk around in the hospital and do an echo on any female patient above the age of 75, and you will see a lot of TR there. And this is true. Most of the triluminate data comes from female patients with atrial fibrillation, like this one I'm going to show you. So this is an 85-year-old female patient with severe TR, of course, significantly symptomatic, had 3 hospitalizations over the previous year due to decompensated heart failure, mainly right heart failure, but also associated with dyspnea, against the background, of course, of atrial fibrillation, hyperlipidemia, and some renal disease. So as we evaluated the patient, we performed coronary angiography, and that showed no evidence of coronary disease. And the right heart is interesting. There's moderate pulmonary hypertension, as you normally see in these patients. There's some degree of elevated wedge pressure, but still the mean is below 20, which is a typical triluminate patient. Transpulmonary gradient is not huge. And you have elevated right-sided filling pressure. So the mean is 13, the V wave is 24, almost as high as the wedge pressure, but still a preserved cardiac output and not elevated pulmonary vascular resistance. Euroscore is 4.7%, but really I don't know what Euroscore 2 means for this population. So this is the TEE, and I have a couple of shows. So this is an atrial MR. You can see the leaflets being horizontal with some central jet, very big left atrium, no thrombus, small LV with preserved ejection fraction. And this is the money. So this is tricuspid valve, dilated annulus. And you can see on the right, there is some tending of the septal leaflet, mainly in the anteroseptal region and in the central part. But when it comes, you can see on the left, the posteroseptal area is pretty much okay. And this is the 3D MPR view from the mid-esophageal. You can see a lot of TR. And on the tricuspid interrogation, you can pretty much see on the MPR on the top right, the short axis view, the equivalent of transgastric. So it's a truly tri-leaflet valve. That's a good thing. And you can see also the quality of the leaflets on the bottom right images. We were not able to get a decent transgastric view on this patient, and that can be a problem because transgastric is mandatory for these cases. However, if you can get a good mid or low esophageal view and you can reconstruct an MPR, you pretty much have your transgastric view there. And you can see some additional views on that. So this is the amount of tricuspid regurgitation. It's definitely severe. You can say it's massive. I don't know if it's torrential, but definitely it's a lot of TR there. And this is the procedure. So percutaneous access, puncture on the right groin. This is the guide catheter that goes in the middle of the right atrium. Then the tricuspid, it's a tricuspid TSGC, tricuspid delivery system that will come out. It's pretty automatic now to get straddling position. So the tri-clip, or you can see on the top right, the fluoro, to get into the straddling position under echo monitoring on the top left. We can see some hemodynamic measurements on the bottom left. And once we reach this straddling position, so we've exposed the tri-clip out of the guide catheter, we can flex down to the tricuspid valve, which is very, very fast. So this is a process that doesn't take more than a few seconds really to just flex down towards the tricuspid annulus And once we get into position, then we can set ourselves into the right ventricular inflow and outflow view. The main thing is to avoid hitting any object, such as the aortic annulus or the septum, and then get positioned above the tricuspid annulus in the region of interest above the collar, and get your trajectory right. By that, I mean have a nice trajectory on the left view. You can see on the echo. You can be in the middle of the valve above the region of interest, but also have a nice trajectory on the right side. So you can see on the right side that the path of the clip is parallel to the septum. So there's no hugging, there's no septal tilt, which usually biases the device and gives us a bad trajectory. Once we get into that position, then we just open the clip arms. You will see in a minute. By opening the clip arms, we will be able to get our perpendicularity right. And then, of course, we will get the grippers. We will see what the grippers are looking like. So I'm just going to accelerate that a little bit. So this is opening the arms. You can see on the fluoro, you will see in the echo in a minute. Once we see the arms open, then we will be able to move the grippers. We test our trajectory, and then we independently move the grippers. And you can see that it was the septal gripper on the right there. And then we quickly changed to NPR for this patient. Normally, we would go down to the transgastric views, assess the short axis, and check our perpendicularity right. But here we did that automatically in the NPR view. We dived down towards the tricuspid valve. So now we are below the leaflets, and we're actually going to grasp the leaflets on the NPR view. So you can see on the top left, the lateral leaflet, the anterior leaflet is already on the arms, and the grippers are down. And then we will just move down to the ventricle, rotate septally, and then we will come up trying to get the septal leaflet flat on top of the arm. Sometimes we test it, so we get it up and then we move down, and then we will go up again like with this move, and we're happy now that the septal leaflet is there. Grippers are dropped. We just cancel the septal rotation, then we lock and close. We close slowly by looking at the echo and recording it. We want to make sure that the leaflets stay in there in the arms when we close. And this is how we did. And it's time to evaluate both on the long axis view, short axis view, but also in the transgastric and fast view, which is now coming from the NPR. So you can see on the top right here, for example, that the anterior leaflet is actually nicely tethered and pulled by the clip, and also the septal leaflet is in position. So by using the NPR, actually, you're able to have a very, very quick assessment of the insertion of the clip and be happy with the leaflet insertion and the stability of the leaflets. This takes a couple of minutes. We also combine that with collar assessment. You can see that the anterior part of the jet is gone, but there is also a central towards posterior part of the jet. We also use some 2D to look at the leaflet insertion. And once we're happy with all this, then we will deploy the clip. And this is the clip deployment by having a fluoro and echo monitoring. We just pull the suture line, which is the lock line. And then I'll just accelerate that a little bit. This is deployment of the clip here. You will see removing the pin and the gripper line in a second. So pin comes back, gripper line comes back, and then the handle comes back, and the clip is stable, is deployed, and you can see on the echo, it's a nice position. Then the plan is to get another clip in the more central rotation. This is even easier compared to the first one because you already have the fluoro marker of the first clip, so you know how to orientate your second device. Nevertheless, you have to check on the echo, make sure you don't touch on sensitive structures, but flexing down and getting your trajectory is actually even easier now because you have a reference point on the fluoro. And we pretty much follow the same steps. You can see now that we're above the clip in a more central position on the fluoro. That means we're coming a little bit lower compared to the first clip, similar to the mitral clip. And once we get into the position, we go to our MPR view. Here we tested the independent grip movement. It was septal again. We're above the valve. We have checked our trajectory. We have checked our rotation and perpendicularity. And now we're going to move down to the tricuspid valve in a second to move and check, try to grasp the valve in a more posterior location. Here is the perpendicularity view. You can see that on the top right on the MPR. So we pretty much follow the same perpendicularity that the first clip had, but we just rotate a little bit clockwise to be absolutely sure perpendicular to the coaptation surface of the anterior and the septal leaflet. And now we're gonna move in, we check the trajectory again. We're gonna close the clip in a minute. And we go in slowly with the clip closed. Very carefully, close to the first one. As you can see, we're very close, but still quite far away. Just below the leaflets, we open and we're in a grasping position already. And we're going to continue grasping on the MPR view. So you can see the clip comes back. Already the anterior leaflet is there. We could even go for simultaneous grasping in this particular situation, but sometimes it's worth doing an independent grasping to be absolutely sure that we check things. So the anterior leaflet is already there, and now we're going to move to the septal part, make sure we get enough leaflet in. We always take care not to rotate the clip, so we check the fluoro to check the rotation. Now the septal is in, and we're going to close. That septal gripper is down, and then we're closing very, very slowly. And you can see that the clips are parallel to each other. They're not tilted against each other. A little bit rotated to respect the line of coaptation, but they also have the same height on fluoroscopy. And now we're checking the outcome, and you can see now that the most posterior part of the tricuspid regurgitation is also eliminated. There's only mild residual tricuspid regurgitation, which is a good thing. Of course, we're going to check our leaflet insertion in 2D and MPR view. And then this is deployment of both clips. I just accelerated for the interest of time. You can see how the two clips are now released, deployed, parallel to each other, and moving a little bit independent to each other. So probably they have different scallops of the anterior leaflet and they have some independent movement, but nevertheless, they are moving together very nicely. And this is the final result that you saw on the left side. And this is now removal of the guide catheter using the figure of 8. So no closure devices, no need for angiography, just figure of 8 to do your hemostasis. This is the result. Some mild residual tricuspid regurgitation. The clips are stable in position. This is what the tricuspid regurgitation looked before and after. It's worth going back. Sometimes we're trying to get the best result, like 0 TR. That's almost impossible for TR procedure. Not sure if it's necessary. Triluminate, put the bar to moderate or less. This is definitely less than moderate. Of course, you know, I'm always open to your opinion about it, but definitely there's a lot of improvement. And it's worth also looking at the pressure tracings. So on the left, you can see the pre-pressure. There was a V wave to 23 with a mean of 10. This V wave was actually truncated completely. It went down to 8 with a mean pressure, RA pressure of 5. So that hemodynamic response is also very encouraging and shows that we've done a good job for this patient. So thank you very much for your attention. And of course, I'm open to discussion and comments and happy to answer.
Thank you very much, Dr. Ignos, for your excellent presentation and congratulations for your work. May I ask you, the device selection has to do with the operator experience, or there are any anatomical findings that might tell you that to choose the one or the other?
That's a very good question. Operator experience is first, cost is second. I'm very sorry to say that, but I want to give a realistic answer. Availability is a third. If I wanted to go down to the anatomy of things, I can say that Pascal is a little bit more forgiving. You have the elongation feature that you go down, if you get entangled in the cords, you can elongate and you can get out. You can also invert and get out with a clip, but the clip has got the grippers, which are alongside the gripper arm, not at the edge. So you can get easier entangled in the cords, and they are dense cords. That's why we take extra care when we move down to the tricuspid valve, not to go too deep, and that comes with experience. You saw that we just shallow under the leaflets. On the other hand, if you really want an annuloplasty effect, and I think that's quite important, and of course it's anecdotal, it's pure personal experience, but we've seen this paradigm in the mitral space as well, especially in this atrial population or in some extreme tethering in the ventricular FTRs. Clip is very powerful. It can do that. So it can pull the leaflets, it can pull the annulus. We've seen some really impressive annuloplasty effects on the clip, more pronounced perhaps than the Pascal. But to be honest with you, both devices are very, very effective. And actually, if you look at the trials, both Triluminate, BeRite, and PACE registry there are non-randomized comparison, of course, but they give similar reductions, like a moderate or less in around 80 to 85% of this population. So I think that's a good sign.
Thank you. Dr. Spargias?
Vlasis, congratulations. Excellent demonstration of a TEER procedure. My take-home message from this case will be screening a case that will be easy case in terms that it's anteroseptal, the color. But then during the procedure, you have to make a lot of decisions, like where exactly you put your first device. If you put it very deeply in the interseptal commissure, you may not have a great effect in color reduction. So you have to decide how deep. If you put it very close to the center and you need a second device, it might become really difficult because you won't have any anterior leaflet left to grasp. So in your case, I think you selected a very good position in the interseptal. It was not very deep, but it was not in the center of the valve. You had a great effect with your first device. And then your second device, you had to go really close to the first device to be on that short part of the anterior leaflet left outside of the first device and to get this great result. So my take-home message will be that if you have anteroseptal pathology and color, then this is a very good case for clipping, but it's not only that. You have to decide exactly how and where you have to position the first clip, and then see if you need a second. So if you need a second, you have to, let's say, take measures from before to position the second. And the other thing is that you have to go for the best possible result, but sometimes you have to accept some residual TR in your case, like you said, and congratulations again for this case. The last thing I want to say is that sometimes the cordae is a very important part of the screening that we tend to neglect. And when you go to the procedure and you have some cordae to an area, that creates problems. So, for example, in your case, if you had a cordae in the anterior leaflet in the position of your second clip, it will be impossible. So it's a combination of things, and the GLIDE score is very good because it takes into account all these small details, and it gives you an idea of how successful you're going to be.
Thank you, Kostas.
Are there any questions? No. Just before we close with Dr. Ignos, I must tell you that we're going to have another more live-in-a-box case just now, presented by Dr. Chrysocheris. So don't leave from the room. So thank you very much, Dr. Ignos, for your presentations, and we must move with Dr. Chrysocheris.
So good morning, everyone. And after this very nice presentation by Vlasis, we'll go on to a case of tricuspid valve repair. Actually, this is not my presentation. Είναι η άλλη παρουσίαση. Είναι αυτή για το επόμενο session. An edge-to-edge repair with Pascal device for the tricuspid valve. Okay, so our patient is a 73-year-old male with a background of coronary artery disease. Many years ago, he had an extensive inferior wall myocardial infarction, and his most recent angiogram shows that he had the mid-RCA CTO and patent stents in the LAD. He also has a history of atrial fibrillation, diabetes, hyperthyroidism on treatment. And his symptoms primarily are that of dyspnea on exertion, NYHA functional class 3 to 4, congestive heart failure, volume overload. He's on guideline-directed medical therapy. And on his echocardiogram, we'll see shortly that he has severe massive ventricular functional tricuspid regurgitation of a tri-leaflet valve with an ERO of 0.61 square centimeters. We will see that it has TR along the coaptation line, maximally at the center and posterior septal, with a systolic flow reversal in the hepatic veins. The right ventricle was dilated with some impairment of RV function. The left ventricular ejection fraction was about 45-50% with an old inferior infarction. Here we see a transthoracic and transesophageal imaging of the severity of the tricuspid regurgitation. We see the right ventricle with impaired contractility, tethering of the leaflets in the right ventricle, and dilatation of the right side, hepatic vein flow reversal, and a coaptation gap at the center of at least 7 millimeters. This is a 3D image of the tricuspid valve from mid-esophageal view position. We see that there is a significant coaptation gap that runs along the center and posterior septal part of the valve. I'm not sure if the pointer can highlight. Actually, the septal is up here, anterior is down here, and posterior is there. When we add color to this, we see that the color comes from the center and posterior septal areas. The next view to understand things is the transgastric view, where we see that we have a tri-leaflet valve, and we see that there is a significant coaptation gap at the center, and slight at the anterior septal area here, and more so posterior septal. And if we add color to this, we see that we have color in a significant part of the valve. We have color coming anterior septal here, center, and posterior septal along the coaptation zone. So a challenging case indeed, and here this sort of side-by-side view. In terms of feasibility, we thought this was in the intermediate in terms of feasibility because of the coaptation gap, because of the extent of the regurgitant jets. And in terms of the glide score, we assessed to be about 4, so an intermediate case for success. And with our procedure plan to be to put 2 devices, one device anterior septal close to the center, and a second device posterior septal in that area. And with this planning, we go ahead to decision of the what device to use. We opted to use the Pascal ACE, which is a device that we commonly use for the tricuspid cases. And this is the view of the case itself. It took us a while to all this introduction, but it was important to highlight that we need to go in these cases in a planned way. We just don't go in to treat tricuspid regurgitation blindly. We will have to have a plan for a successful result. So here we have the introduction of the guide sheath into the right atrium, and here we have the first device. With our goal was to first go into an anteroseptal position, being the traditional way of doing things, going anteroseptal first, And here with multiplanar reconstructions, we have an assessment of our position and trajectories and our perpendicularity to the coaptation zone that we intend to go to. Here we also check the clasps, which one is the septal, which one is the lateral one. It's very important, as mentioned before, to have a good coaxiality to the valve plane and to be perpendicular to the coaptation zone that we're interested in. So we need to go more anteroseptal in terms of our position. So we advanced with the device closed. We will advance into the right ventricle. And once we're below the leaflets, we will open the device. The beauty of multiplanar reconstruction is that you have all views at the same time, and you can quickly go to the 3D view and the short axis view to assess your clocking. This is the traditional transgastric view that we go to assess septal and anterior clocking. And here is our sequence of grasping in the grasping first the lateral leaflet and then the septal leaflet. So here is our position in the anteroseptal commissure with our first device. We're fairly deep in the septal commissure, and we're not really doing much to change the color of this valve. So with that, we change our strategy at this point because our goal is always to get a good result with the initial device. If we don't get a good result, then we have to change our strategy. And because of the fact that there was a lot of color at the center and posterior of the valve, we changed our strategy to go with this device, more central posterior septal. So this is what we are doing at this point now. We changed completely our strategy, moving on to the center of the valve, and with our goal to grasp septal posterior first. As we couldn't really move this first device in a different position, we said, let's go for the posterior septal first, and then we'll go see what happens. So here we have, again, the same sequence of events. We assess our clocking on a transgastric view to be 3-9 configuration for this septal posterior part here. And here we go for independent clasping of leaflets again. First the lateral leaflet, the posterior leaflet, and then once we have that, we will move on to grasp the septal leaflet. Again, we assess our position, our clocking, very importantly, and now that we are verified our clocking is correct, we go for the septal leaflet independently. And we have a good leaflet capture there. Slowly closing the device. Assessing color, that we have a reduction of color as planned, as anticipated. And here we see in short axis that we have a good bringing together the septal and lateral leaflet in the intended area that we want it to go. We need to assess, however, how much leaflet we have inside. So in this sense, we can open the device, keeping the clasps down, and assess whether the leaflets go all the way to the apex of the of the device or not. So here we open the device and we assess, that we needed to optimize the septal leaflet. And this is what we're doing here. And we also optimize the lateral leaflet as well. And closing again the device. Again, our position is septal posterior near the center of the valve. We assess the leaflet insertion with multiplanar reconstruction. Sometimes it's not always easy to see. So with MPR, we confirm that we have enough septal leaflet inside and lateral leaflet as well. And with this, we went ahead to deploy this device as a first device in the center to septal posterior area of the valve. We do have significant color coming more anteriorly as we anticipated. And with that, we'll proceed with the second device. We see that we don't have any gradients. Gradient was less than 1. This is a nice 3D view that shows where we are now positioned in the septal posterior area. And we're going to put a second device in this anterior septal area as well. Showing the residual color at this point. So the second device comes in. This is a bicaval view in 3D, orienting now towards the valve. And again, biplane imaging for our position and trajectories. This one will move more in the interseptal area of the valve. Again, with MPR, we try to position our device as accurately as possible. We'll cross the device with the device closed into the right ventricle. And now we go again with independent clasping of the leaflets. We'll go first we'll check our orientation in our transgastric view. It's a typical 2-8 orientation in that area. And here we have clasping of the lateral leaflet. Yes.
Codi.
Correct.
In the lower part, and that's why I think that area, although it looks okay, if you notice this codi, this is a hint that you may have a problem to get the septal leaflet rightly and easily.
Yeah, that actually showed very well and didn't point it out in the transgastric short axis images that we had before. I can go back to that. And this is our final result, essentially, with the two devices. We know that we're going to have some regurgitation from the central part of the valve, which is very difficult to grasp in that area. There was a big coaptation gap. But overall, a moderate, mild to moderate residual TR. This is release of the second device here. And after release of the device, we will see the final result. Yeah. Now they're released. This is the 3D appearance of the two devices. With some residual color at between the devices, small residual color from the posterior septal area, mean gradient was 2 millimeters of mercury. A very nice result and a very difficult anatomical substrate. And with that, just to summarize, this is the first device, how we clasp independently both leaflets in the posterior septal area. And then this is the second device, again, clasping independently both leaflets. This is the final result in 3D. And patient did very well, was discharged home on 3 days post. At the one month visit, the patient was doing fairly well. with, these are the images that we had at that point. And with that, I'd like to thank you for your attention.
Thank you, Dr. Chrysohelis, for your work and for your nice presentation. I don't know if there are any questions, any from the moderators. We have, I mean, not time. It's already past the break as well.
If possible, can we put the PowerPoint back on the screen for 1 second? Just want to show what Dr. Spargis was commenting about in this transgastric view, that we have these cords attached to the septal leaflet that we know that we can't really go in this area here because the septal leaflet is a bit restricted. So we have to go in this part that doesn't have so much cords there. So this is when we see these cords holding onto the septal leaflet, we know that this area is difficult to grasp in a sense. So thank you for that, yes.
So basically, this case was a little unconventional. The approach, it was a difficult case. It was, I would say, orange. You see color from everywhere. You see a large gap. And you see the cordae in the septal leaflet in the lower part. So usually when we go for two devices, we prefer the first device to go in the anteroseptal deeply and then come more to the center of the valve, like Vlas's case in earlier. But in this case, we didn't really have an effect with the first device in the anteroseptal. And generally, our approach as a team is that we don't leave a device if we don't have a good reduction of the color. There's no point to leave a device just to leave it. Because then if you have a problem with the second device, you are left with no effect on the color. So we always go to have an effect on the regurgitation before we release the device. That's why we selected to go on the other side, which is a little unconventional, first more central, make sure that we reduce the color, and even if we failed with the second device, we would have some moderate reduction, and then we moved in the anteroseptal area to also add a reduction there.
Okay, I must thank once more Dr. Chrysohelis and all the speakers and the moderators, and then also the organizing committee. And then I think we must move to the next session. Okay, thank you very much.
We are now moving from transcatheter H2H therapies to do transcatheter tricuspid valve replacement session. In this session, we will be with Peter Danias and Dr. Kramidas and Vlasisinios from Thessaloniki, the moderator. So I think it will be a very interesting session. In the first session, we discussed about the transcatheter H2H therapies, and there are two main questions. One question is which patients are suitable for transcatheter H2H therapy and which patients are much more suitable for transcatheter tricuspid valve replacement. And the second one is which valves can be suitable for the specific anatomy. Now we will discuss all these points all together. So Peter, maybe you can announce our speakers.
Thank you, Dr. Kilic. Our first speaker will be Dr. Praz from Bern, from the University of Bern, and he's a world-renowned expert on mitral and tricuspid interventions. So Dr. Praz will discuss the patient selection for TTVR. Dr. Praz, the floor is yours.
Thank you very much. Good morning, everybody. Thank you very much for the introduction and also, for the pleasure to be with you in Athens, even if not in person. I hope you can see my slides in Athens. Yes. Perfect. So I will start with patient selection for transcatheter tricuspid valve replacement. As already mentioned, a very interesting topic here, my conflict of interest. So I just wanted to introduce a little bit the topic. What are we actually talking about with transcatheter tricuspid valve replacement? We are talking about a very new field actually with, as you can see, already several devices, but most of these devices are actually now still in studies and have been implanted under compassionate use condition for some of them in very few patients. So we don't have so much experience except maybe for one device that has received CE mark and has also been approved in the US very recently, about 1 year ago, the EVOQUE tricuspid transcatheter valve replacement system that is also used in Athens for the treatment of patients that are high risk for surgery and also on medical treatment. So a very interesting field with a lot of research going into it and a lot of interest from the company, from the patient, and also from the treating physician. And this replacement, just to put it into context, you have heard in the previous session about edge-to-edge repair, but there are other part or other device that are part of the tricuspid toolkit. Leaflet approximation with the TriClip and Pascal, but also the CardioBand device that is not available right now, but has been actually commercially available during the last years for annuloplasty of the tricuspid valve. And finally, there is also the option to implant valve into the caval vein, an heterotopic valve replacement with a trick valve, also a device with CE mark. So a lot of different options. What do we know about tricuspid transcatheter valve replacement? So we have already some information from a randomized controlled trial comparing the implantation of the EVOQUE valve from a transfemoral access to optimal medical treatment. And you can see that has been shown in this study published in the New England Journal of Medicine that this therapy has a tremendous effect on quality of life in terms of KCCQ improvement, in terms of functionality as well, with NYHA class improvement and 6-minute walking distance that is related to the reduction of tricuspid regurgitation. At 1 year, which is a short follow-up, there was no effect on hard endpoints, a combined endpoint of death and heart failure hospitalization. What we have seen also in this study, and what is very interesting, is that this therapy is associated with some complication. That is less the case with edge-to-edge repair, as you have discussed, a very safe therapy. It's other with replacement, and we have to pay a price, obviously, for abolishing completely tricuspid regurgitation in almost 98% of the patients. in terms of some complication. The rate are decreasing, but you can see here that there are clearly a risk of bleeding in this patient because they need very strong anticoagulation for some of them and to avoid the risk of valve thrombosis. And there is a second risk that is very important, which is the risk of arrhythmia and new pacemaker implantation. That was the case in about 1/4 of the patient without previous pacemaker in this study at 1 year. So a price to be paid for a very effective therapy in reducing tricuspid regurgitation. So which parameters are important for the selection of patient for this therapy, for replacement? I think the first thing we need to look at is the clinical presentation of the patient. And you can see that tricuspid regurgitation is affecting a lot of different organ systems, and that this end organ damage is also associated with an increasing heart failure syndromes and severity, advancement of the disease. So we need to understand how advanced is the patient in terms of secondary organ damage and heart failure. Then we imperatively need to understand what is the etiology of tricuspid regurgitation, because this has consequences on the risk in particular of right ventricular failure. And we need to understand, is the tricuspid regurgitation due to a mainly atrial dilatation, atrial secondary tricuspid regurgitation, which appear in patients with atrial fibrillation mainly, or HFpEF, heart failure with preserved ejection fraction. And the other part is the ventricular secondary tricuspid regurgitation that is mainly driven by a dilatation of the right ventricle and a damage of the right ventricle. And this patient obviously have a higher risk of right ventricular failure after abolishment of tricuspid regurgitation. So every time you look at a patient and consider edge-to-edge or replacement, look or try to think about the etiology of tricuspid regurgitation. And this apply, of course, also for patients having a lead-related tricuspid regurgitation that is more difficult to treat with edge-to-edge repair. We then need to look very carefully at the anatomy, because the anatomy of the valve, it doesn't matter so much what it is called or how much leaflet, but what is important is to know how complex is its anatomy in terms of the number of leaflets, in terms of the presence of indentation, in terms of the jet localization, because this will be one of the very important predictors of the success of edge-to-edge repair. And finally, the same applies for the coaptation gap. If the coaptation gap is too big, we know this now, between 7 and 8 millimeter, then edge-to-edge repair will be less effective, and we also reflect or translate into less symptomatic improvement of the patient. And finally, and that's something we do in every outpatient, we need to understand what are the hemodynamic, what is the hemodynamic effect of tricuspid regurgitation, and what are also the pulmonary pressure. You see an example where the right ventricular pressure, systolic pressure, and the right atrial pressure, we wave are actually exactly the same. That's a ventricularization of the right atrium. And in that situation, you will expect a very big coaptation gap in a patient that is probably not suitable or not easy treatable with edge-to-edge repair. The next point is right ventricular function, and there we need to improve a lot. We are not able to quantify in an appropriate way right now the complexity of right ventricular function, and this, of course, has consequences in terms of, I would say, the unpredictability of right ventricular dysfunction after replacement. We need to look into new parameters, strain or cardiac MRI, to have this parameter in our clinical practice. Then when we do a sum of everything, then we are left with these different options, including replacement. And we have tried, together with Jörg Hausleiter in the JACC publication, to summarize a little bit what are the important criteria for the success of edge-to-edge repair. And if the expectation or the result expected is not optimal in terms of TR reduction, which should be at least moderate to mild, then it may be of advantage to go and consider tricuspid valve replacement instead of edge-to-edge repair. A direct comparison, you see here, something I have already mentioned, and I that I summarize here, with a higher risk of some specific complication after replacement, major bleeding, the risk of new pacemaker implantation, the risk of valve thrombosis, of course, which is not the case with transcatheter valve repair, and finally also the risk of afterload mismatch, quite a rare complication, but that needs to be prevented. And that's what we tried here to show, that these challenges and these complications need actually to be prevented by the preparation of the patient, but also by the follow-up, meaning that if you have conduction disturbances, you will need to be prepared during the procedure to pace, and you will need to have a very close follow-up of the patient to detect any relevant conduction disturbances. And the same apply for the anatomy, with the preparation of the patient and diuretic treatment for optimal sizing of the valve, and then implantation with continuation then of diuretic therapy after the implantation. So all these challenges or complications can be prevented. The patient can be prepared in order to try to minimize. But there are still some red flags for replacement that we have also shown in this graph in the same JACC publication. You can see that we need to be very careful when implanting a valve in patients with ICD lead, in patients with severely impaired right ventricular function, in patients who are at high bleeding risk or intolerant to oral anticoagulation. It is a contraindication for the implantation of a valve. And finally, in patients also with severe organ damage. But this is something also we can discuss. Maybe some very advanced patients can still benefit from the implantation of a valve. We have, together with Kostas Spargias and the team in Athens and other experience center in Europe, we have put together 176 patients. The first time I showed this data. And you can see that in terms of pacemaker, we need to be careful there, because on one side, we can have also pacemaker implantation and conduction disturbances a long time after the implantation of the valve. You see the number in days, and you can see here that some of the patients got a pacemaker after 10 or even later after the implantation. So we need to be very careful on this, and the prediction of this, it's not very surprising, but it's shown for the first time, are actually the previous conduction disturbances, and we could not define which one is the worst one, but the presence of previous conduction disturbances is a strong predictor of pacemaker implantation. So we need to look at the EKG of the patient before considering him for replacement. And finally, you can see here that what I mentioned, quite a good improvement in terms of biological parameter in patients with renal failure and in patients with liver dysfunction, which is very encouraging actually, because these patients undergoing treatment with replacement are advanced, but improve after reduction of tricuspid regurgitation. And finally, right ventricular dysfunction, a very important parameter. You see that it is one of the strongest predictor of clinical failure, meaning a composite of a complication during the procedure and the hospitalization, and that the patient with right ventricular function, that were very few in this study because of the good selection that has been done in this experience center, but the right ventricular dysfunction was the main predictor of complication. So patient selection is based, I tried to show this, on anatomical and clinical criteria. TR reduction is much better compared to edge-to-edge repair, but the price is a higher complication rate that needs to be prepared and minimized with patient preparation and follow-up. Reduce right ventricular function and conduction disturbances at baseline are predictors of adverse events, and a very careful perioperative management is absolutely essential. Thank you very much for your attention.
Thank you, Fabian, for the excellent presentation. I think the most important take-home message is the perioperative management of these patients. So we understood that determining perioperative risk and the liver functions and renal functions, and also the echo is very, very important before transcatheter valve replacement. So I want to ask to Dr. Kromidas that what do you think about the function of the right ventricle, should we evaluate all these patients by right heart catheterization, or echo is only sufficient? What's your opinion? Or cardiac MR maybe? Peter, you can make comment on
Yes. First of all, congratulations for Professor Price for the excellent presentation. You pointed out that the patient that actually get the most benefit is the patient that have the most TR. But commonly these patients have, it's more possible to have reduced RV function, as Professor Kilic pointed out. So it's crucial, not only in terms of prognosis, but of adverse events, to evaluate the RV function properly and thoroughly before planning the procedure. And I was going to ask you whether you perform routinely CMR in every patient in order to properly assess the RV function. Would you rely on the 3D echo, which correlates well with CMR, but we may overestimate when we have significant TR the function? Would you routinely do a CMR or right height catheter, as Professor Tillitz said, for the estimation of the pulmonary pressure? And whether you encountered any cases where you thought that the RV function was good, but after implanting the valve, a severe RV dysfunction was unmasked and the patient had acute right failure. Thank you.
So, excellent question and remark. So, of course not. We do not perform a CMR in all patients. That's, that would be not possible, I think. Because many of these patients, 1/3 have pacemaker, they have CRT, they are so it's the availability of CMR for the routine use in this patient is very difficult, and obviously because of the artifact of all the device you have in this patient, you will have difficulties to really quantify all what you want to do. So we need to have a method that is doable and clearly and can be used in all patients, and clearly this is echo. But we need to be better in using parameters that are more comprehensive of the right ventricular function. And that is not TAPSE or DTI. We need to come away from just looking at the longitudinal right ventricular function. And as you mentioned, right ventricular ejection fraction, and possibly also volumes and right ventricular ejection fraction, effective right ventricular ejection fraction, taking into account the regurgitant volume, is probably the way to go in the future. And that's exactly what you say. The problem is that if we rely only on longitudinal parameter, we will have surprise, and we have surprise. We have patients where we think or we expect that they will fail after valve implantation, they would not have any hemodynamic consequence of the valve implantation and have a benefit of it. And we have some patients, and I had exactly this experience you mentioned once, where we were absolutely not expecting anything. It was even a patient with primary TR because of a Barlow, and just after valve implantation, the patient had really an hemodynamic instability that we were absolutely not prepared for. So, we are just visually, we are not good at looking and understanding what the right ventricular is doing, and we need to have better parameters. But this should be echo. We need to search to do more research on echo, because that's the most available method.
Peter, you want to make some comments?
On the right ventricular, right catheterization, that is also extremely important. Yeah. If you do your measurement and you see an elevated right ventricular and diastolic pressure, then you can be sure that your patient has a relevant dysfunction. So it's an additional parameter that is, for me, very useful to look a little bit at the situation of the right ventricle.
Yes, I think it's one of the most important pre-diagnostic tool to differentiate the right ventricular function and ventricular functional tricuspid regurgitation, especially for the high pulmonary artery pressures. So, Peter, do you want to make some comment, especially about patients without ICD? Can we focus on cardiac MR in these patients?
Sure. Before doing that, I would also want to congratulate. This was an excellent presentation and really very thorough. I think we have to understand also that the right ventricle is a moving target, and its function and the degree of tricuspid regurgitation also depends on a lot of functional parameters like the blood pressure of the patient, the volume overload, the volume condition. And this is also changing. It's very important to understand this and realize that our measurements are also dependent on the conditions that those are taken. Certainly when somebody goes in the CMR suite, they're a lot more stressed out than when they have an echocardiogram, and so the pressure is different, and so the degree of tricuspid regurgitation that we measure may be different from what is on baseline. Nowadays, the implantation of MR-compatible devices is, pretty much the standard. So I think the issue of artifacts or not being able to perform the CMR is less of an issue. We can get accurate measurements. There's both gated approaches and non-gated approaches, real-time approaches that we can use to measure right ventricular size and function. And having said that, assessing and measuring right ventricular function is always a challenge, because calculating where the base is or being precise about where the pulmonary valve is very difficult. The valve moves in and out as we take our pictures, and so that is always a consideration. Since these are the most difficult patients to treat and usually with not great outcomes, as we saw, I think it would be very important to try to get as much data as possible before doing the procedure. So I would advocate for doing, obviously, echo on everybody, trying to get CMRs on most people, particularly the sickest ones, and also trying to get the cardiac catheterization, hemodynamics as well as possible before doing the procedures. Thank you.
Thank you. And one important diagnostic tool, especially the CT for the selection of the valve, I think, for the transcatheter tricuspid valve. And now we will move on especially to echocardiography and CT. Dr. Praz, if you stay online, we will be happy to discuss maybe. Yes, okay, now we are moving to another speaker. So, Dr. Kromidas, can you announce it?
It's a great pleasure to announce Dr. Chrysocheris, who's going to talk us about pre-plan imaging pre- and post-procedure with echocardiography. Dr. Chrysocheris is Associate Director of Transcatheter Heart Valve Department in Hygeia Hospital. Dr. Chrysocheris.
Thank you very much. So after this very beautiful presentation by Dr. Praz, we'll move on to echocardiographic imaging before and during transcatheter valve replacement on the tricuspid side. So we all know that the problem of tricuspid regurgitation that is often undertreated, and it impacts many of our patients in a significant way. And many of our patients come in symptomatic and with a great host of symptoms and problems. Now that we have the CE mark approved Evoque valve for transcatheter valve replacement, that offers a promise to solve this major problem for many of our patients. As we all know, the Evoque valve is a self-expanding valve made of nitinol with bovine pericardial leaflets, 28 French delivery system from the transfemoral transvenous approach, and it comes in 4 sizes, from 44 up to 56 millimeters. We saw very well before that the importance of assessing the tricuspid valve carefully for its anatomic characteristics, and up to now the only available modality we had was edge-to-edge repair. So we needed to understand which patients are favorable for edge-to-edge repair, intermediate or unfavorable from an anatomical perspective. And we know that for many of our patients with presented for edge-to-edge repair, they are deemed to be unsuitable mainly because of large anatomical reasons, large annulus size, RA and basal RV dilatation, significant tethering of the leaflets, and major coaptation gaps. And we know also that in clinical practice, many of our patients that we do edge-to-edge repair are sort of intermediate anatomies that we know that may not fare very well and to have optimal result, but we have to do them to get at least a reduction of the tricuspid regurgitation and alleviate the symptoms. In the area of tricuspid valve replacement now, we have to be more careful in our patient selection, and we have to go into this by considering that if a patient is not primed anatomically suitable for edge-to-edge repair, then a suboptimal result with edge-to-edge repair may close the way for the therapeutic option of transcatheter valve replacement. So we have to consider that very carefully nowadays. Now, evoke valve can be applied in multiple types of, all phenotypes of tricuspid regurgitation, the ventricular functional phenotype, the atrial functional, the primary tricuspid regurgitation, and very importantly also the pacemaker-induced tricuspid regurgitation. It's very important, as highlighted before, to understand very well the function of the right ventricle. We should use all available modalities. The TAPSI, RVSDDI are the basic ones, but not they don't tell the whole story. We have to go with free wall strain of the right ventricle, fractional area change, and very importantly, right ventricular ejection fraction measured by 3D echocardiography. And with that, we can have an idea whether our patient is mild, moderate, or severe RV dysfunction. So here's an example of the available modalities we have to use beforehand to understand as much as possible the functionality of the right ventricle. In terms of our screening echocardiogram for our patients, we apply the same tools that we applied in all our patients with tricuspid regurgitation, primarily transesophageal echocardiography with biplane imaging from a mid or low esophageal position. It gives us a very nice understanding of the tricuspid valve, the coaptation gaps. We can scan the valve from anterior to posterior and have a very good idea where the coaptation jets are and what the underlying anatomy of the leaflets is. Also, the transgastric views are very, very important because they give us a very nice understanding of the number of valve leaflets, the distribution of the cords, the presence and location of the coaptation gaps, and it's just a wealth of information with this single view that we have to always do in these patients to understand what's going on. Very importantly, especially in the area of valve replacement, is the use of multiplanar reconstructions from a 3D data sets. 3D data sets can be obtained from mid-esophageal, low esophageal positions or transgastric positions. Very important that we can do that from all positions. And with that, we can, using the landmark of the aortic valve, understand our location and what is septal, what is anterior, what is posterior, and very importantly, have an idea where the coaptation gaps are, and so on. More importantly is the use of multiplanar reconstruction in our procedural guidance, where we take a 3D image data set and we analyze it into a commissural, long axis, and short axis, all in one image, all in one frame image, all available options to see and understand our position, our trajectories, and all that we need to understand. So again, we are able to say what is posterior, what is anterior based on this commissural view, what is septal, what is lateral on this view, and in the short axis transgastric view, which is clocked at 5 o'clock with the aortic valve at 5 o'clock, we have septal, anterior, and posterior. So with that, it's very important to use that because especially for orthotopic valve replacement, we use that heavily. In terms of annular sizing considerations for the evoke valve, primarily the choice of valve will be done by CT, with the echocardiogram, however, giving us an initial idea about the perimeter of the annulus of the tricuspid valve and whether a patient may be eligible or not. Here's an example of a patient with a torrential tricuspid regurgitation with a rheumatic tricuspid valve. And the CT perimeter-derived numbers gave us that this patient would be suitable for a 56 millimeter valve. Again, on screening as well as on the day of the procedure, we have to reassess the annulus area because if that has changed because of the patient being over-diuresed, then the choice of valve prosthesis that we've chosen may be different. The first step of the transcatheter tricuspid valve replacement is to get a stiff wire at the RV apex, and we want to get it behind the anterior papillary muscle to as close to the apex as possible because that will be our rail on which the implant delivery system will come up upon. Once we have the wire at the RV apex, then the next step is to advance the delivery system into the tricuspid valve, as we can see here. By doing our multi-plan reconstructions, we can assess our position and trajectory, which is very important. We have the possibility of doing changes in our septal to lateral position with our secondary knob on the delivery system. With that, we have to have it optimized as possible. Once we have this position optimized, then the next question comes up is how deep are we in the right ventricle with the end of the capsule of the device. Sometimes that is not always easy to see. Sometimes fusion can help us understand our depth of how deep we are below the valve. Here the imaging was not very optimal. The next thing we can try and help us out is do a little bit of a capsule retraction to create this capsule gap. At the end of this of the delivery system, we have this retraction of the capsule, just enough to create a small gap that we can see. And here we could actually visualize this gap. This is transthoracic imaging to visualize the gap and understand how deep we are in the below the tricuspid valve annulus plane. This is a pacemaker wire that goes into the coronary sinus. The next point at this point is because we have to do a timeout at this point, because once we open the capsule further, it's a point of no return. We have to deploy the valve. So at this point, we have to understand our depth that is adequate, that we need to understand our position is central to the leaflet coaptation, our trajectories are coaxial, and we have enough good imaging to proceed. And once we proceed, the next step would be to do a further retraction of the capsule and exposure of the 9 anchors of this of the valve. Shortly thereafter, we go to the anchors more exposed at about 90 degrees. So at this point, it's very important again to understand our depth below the tricuspid valve annulus and the tricuspid valve leaflets. And with that, we have to go back on our NPR, and we try to do a spinning where we rotate the planes in this right lower image, and we look at the corresponding image above, and we look at the position of the leaflets over each and every anchor of our device. We have to have the leaflets going over our anchors and freely in systole and diastole. So once
is there any specific measurement on echo? How much, for example?
We have to see them all moving freely. We don't want them to be impinged in any way. We have to have our device at this point to be below the leaflets by at least half a centimeter, if you want to give you a number. The next step of this is to do the further retraction of the capsule, and now the anchors come towards the atrium, and that's what we call the atrial flip of the anchors. Again, this is a very important step that we want to assess that all the anchors are below the leaflets in systole and diastole. For instance, you can see here in this view that this leaflet is not over the anchor. The anchor is above the leaflet, so we have to advance our depth a little bit and again do our spinning maneuver to assess that all the leaflets move freely above our anchors. So the next step after, so once we have that, then we can also use our biplane imaging. If there's anchors that we haven't clearly visualized in our MPR, we can go back and see if these were an anterior anchor, for instance. We can see it down here very nicely that the leaflet goes over it and it's moving freely above it, that it's either engaged or ready to be engaged with the anchor. So the next step is to do what we call ventricular expansion. As you see, retracting the capsule widens the device and progressively will widen to come and engage the annulus. Again, very important at this stage to reassess all the anchors, all 9 anchors that are moving above the anchors or and they're freely moving and not being pinched in any way. And again, we're going to do our spinning, and from you can see here that we spin the green line, and we look at this image here to see that all anchors are nicely inserted into the device. Subsequently, we do our further ventricular expansion. Again, this brings the anchors even closer to the annulus of the tricuspid valve. At this point, we want to confirm leaflet engagement, and we can also do some tilting maneuvers, septal, lateral, posterior, and anterior. And once we have that, then we move on to atrial expansion and release of the valve. And so this is the final position of the valve with the final appearance. We may have a trivial central jet. We look for any paravalvular leaks, trivial, if any, may be noted. Again, we assess immediately also the functionality of the right ventricle because we want to make sure that we don't have any significant RV dysfunction. Some studies have shown that long-term, in the short term, we may have a drop in the ejection fraction of the right ventricle. However, this is offset by an improvement in the stroke volume of the right and the left ventricle. And what we see usually is a drop in the right ventricular end diastolic volumes. With that, I would like to summarize with the fact that the valve replacement with the EVOQUE valve now offers patients complete resolution of severe tricuspid regurgitation with, as we saw before. The CT will determine the choice of valve size. Intraoperative guidance by 3D echocardiography and multiplanar reconstructions is critical to enhance procedural flow and success of the procedure. Learning curve is expected. However, one will see that TTVR procedures may be more predictable as compared to the edge-to-edge repair procedures. Thank you very much.
Thank you, Dr. Christos, for the excellent presentation. Is there any questions from the audience?
Congratulations again, Dr. Christoheris. You pointed out and you demonstrated very nicely how image quality is very important for the success procedure. And I was wondering, sometimes it's challenging to image the tricuspid valve, not only because of the anterior location, but sometimes the horizontal axis of the valve makes taking pictures more difficult. And I was wondering whether in more complex cases, like you had patients with previous surgeries and prostheses that have significant acoustic shadowing, plus with difficult imaging modality, what would you do? Would you consider adding to your toolkit, for example, 2D or 3D eyes? Would you do pre-planning surgery? What's your point?
Yeah, we've had a few cases that were actually very challenging indeed. What we learned how to do is how to do MPR from transgastric views, something that we have not been exposed to, but it's something that we can easily learn to do. Transgastric offers a direct view of to the tricuspid valve. And if you have decent transgastric views, you can really guide the whole procedure with MPR from transgastric views. Now, we haven't had experience with 3D eyes. I know some centers have tried to use it, but it's an alternative, obviously, method for imaging in very difficult cases. But I think if in one way or the other you can find your image to do your procedure. And again, some of these procedures, this procedure might have been very, very difficult image-wise for edge-to-edge repair. However, for, I think, valve replacement is a little bit more forgiving in terms of its imaging.
Is Velasys online or not, I think? Yes? He is now? No. Okay. He's not, okay. Now we should maybe move on to other. Thank you.
Thank you, Dr. Harris. Our next speaker is Dr. Murmuris. Dr. Murmuris is a radiologist. He's our valve expert. He's the person that we always look for at Hygeia Hospital for all kinds of valve procedures. and I think he really knows the anatomy best. Dr. Maurice, the floor is yours to discuss about TTVR imaging pre-procedure CT.
Okay, good morning, everyone. For the next 10 minutes, I'm going to present the role of CT in the evaluation of patients before this procedure. Now, CT play a major role in pre-procedural planning. Due to high isotropic spatial resolution, can provide 3D morphologic information on tricuspid valve and adjacent structures, and also provide accurate and reproducible measurements. In order to provide all the information, we need a good quality CT scan, and that means, first of all, that we need optimal and homogeneous opacification of the right chambers. This is a very challenging protocol because we may have artifacts due to competing flow from vena cava or strict artifacts due to high concentration of contrast media in superior vena cava or right ventricle. So we need to perform a triphasic injection protocol. This is a protocol where we inject to the patient different mixtures of contrast and contrast medium and saline in order to avoid all these artifacts. As you can see, the upper images, this is the appropriate opacification of the right ventricles, and you can see in the lower left images how strict artifacts due to high concentration of contrast media could affect the evaluation of the ventricles. And also in the lower right images, you can see suboptimal opacification of the right chambers. Now, the appropriate scan protocol consists of retrospective ECG gating of the whole heart. We don't want with no modulation in order to acquire data from the entire cardiac cycle, and we reconstruct images every 5 to 10% of the cardiac cycle. We keep the slice thickness as small as possible, and also we add a non-gated scan of the venous access from neck to pelvis in order to evaluate the venous system. We pay special attention to patients with atrial fibrillation. In this case, we may require ECG editing, and also we may have metallic artifacts from implanted devices like a pacemaker. And in this case, we apply iterative reconstruction techniques in order to enhance images. So the role of CT is to evaluate the TV apparatus morphology, provide information regarding 3D relationships with adjacent structures, and provide all the necessary measurements for procedural planning. We know that TV apparatus consists of leaflets, annulus, cordia, tentina, and papillary muscles. There is a considerable anatomic variation, and CT can provide information complementary to the ultrasound on tricuspid apparatus morphology. And that means that we can provide some information regarding the number of leaflets or the papillary muscles. Also, we can assess the effect of leads from previous implanted devices on the leaflets. CT also provides information regarding the morphology of the annulus. We know that tricuspid annulus normally is elliptical and saddle-shaped, but in cases of functional regurgitation, the annulus appear more circular and more planar. Now, CT can provide measurement regarding the size of the annulus. This is the most important measurement because accurate measurement of annulus is essential for device selection. We can perform that in a Synchronous workstation when we perform measurement on short axis view from double oblique reconstruction. However, this method may underestimate the size of the annulus. The most appropriate methods in these cases is to use a dedicated 3D software where we can place seeds around the annulus like we do in the mitral annulus. And this is the appropriate way to accurately represent the complex shape of the annulus and provide accurate and reproducible measurements. We know also that tricuspid annulus is dynamic structure with changes in size and shape, so dimension may change up to 20 to 35% throughout the cardiac cycle. So we need to perform measurements during in systole and diastole. Another important measurement is the size of the right chambers. We know that minimum atrial ventricular size is we need the minimal atrial ventricular size in order to achieve optimal device deployment. So CT can provide information regarding the height of the right atrium and depth of the right ventricle. And this measurement should be performed during systole and diastole. Another information is the relation between right coronary artery and tricuspid annulus. We need to provide the minimum distance between these two structures because during the implantation there is a risk of compression. CT also provides information regarding the optimal procedure of fluoroscopic angles. This is an important information in order to ensure the accurate device deployment and also to decrease procedural time, radiation dose, and the amount of contrast medium. CT also provides information regarding the catheter simulation and trajectory. And finally, CT can provide information regarding the access route, and I'm talking about the venous anatomy, the size of the venous structures, and also to exclude the presence of thrombus. So, in conclusion, CT plays an increasingly important role in pre-procedural assessment for this procedure by providing information for the TV apparatus morphology, by providing information regarding the 3D relationship to adjacent structures, and also provide device-specific measurements necessary for procedural planning. Thank you.
Thank you very much. Excellent presentation, especially about the tricuspid annular measurements and also about the risk of compression of right coronary artery. And my question will be, as you know, a lot of people are now doing TAVI procedures, and we are using Tremencio programs, and we are very close to the aortic annular measurements. Compared to the TAVI measurements, the protocol is the same for tricuspid, or is there any difference for the CT protocol for tricuspid measurements?
First of all, in TAVI case, we target the left ventricles, and in these cases, we mainly target to the right chambers. We also want some opacification of the left ventricles, but it's quite different the target chambers. I mean, TAVI wants left chambers only, and I think I think the difference. Another difference is that in TAVI we target the arterial route, and in tricuspid valve we target to the venous system.
I mean, contrast, for example, same. The protocol is the same.
Contrast. Usually in my department we use monophasic contrast protocol for TAVI. But in cases of tricuspid valve, we use a triphasic protocol. First, we have 3 phases. First phase is when we inject around 40 to 50 ml, where 60 to 40% contrast medium saline. Then the second phase, the second phase is a mixture of 40% contrast, 60% saline, and then just saline. In TAVI, we only perform.
We should wait a little bit because of the venous return, and also for some specific valves, we should also see the superior vena cava
from neck.
Thank you very much, Dr. Murmuris. This was a really outstanding lecture. We're experiencing a period where technology really leaps forward with very high rates, and I think we have photon counting CTs coming up and other enhancements. Do you think that all these will improve our measurements, will make it safer, faster? Will it be more applicable for people with arrhythmias? Where do we expect to see the benefits of technology evolution?
Photon counting CTs is better for, I think, the photon counting CT can provide significant details about the structures who have a better quality. Also, the spatial resolution is very small. I'm not sure about the temporal resolution, because nowadays is about 65 to 74 milliseconds. I'm not sure that it's going to go lower using photon counting CT. But another issue is that using photon counting CT, we can provide less contrast medium, which is very important in these cases, because often patients have renal function problems.
Okay, now we should move on to the two. Thank you very much, Dr. Murmuris, for the excellent presentation. Now we have got two important, interesting cases. Now, for the case presentations, I want to invite the Hygia team, Dr. Konstantinos Stogiannis. Yes.
Hi, thank you very much. Yes, now it's going to be some presentations from the THV heart team, live in the box cases. And it's not just going to be me. The whole team is sitting here, so they will be making comments, and you're more than welcome also to make comments. So this is a 68-year-old female patient, rather obese. She's been very symptomatic for the past few months. Has a history of a TAVI 70 years ago. She presents with a TE and TT that has massive TR, huge coaptation gap, tethered leaflets. We're going to see all these things in a second. Other history, she has a dual chamber PPM, chronic AF, Hodgkin's lymphoma with radiation and chemo. And just a small note, a year after TAVI, she had the pacemaker just the day after TAVI, and a year after TAVI, there was some moderate TR. So we have the imaging team if they want to describe what they see.
Yeah, so here is an assessment of the right ventricular function. We see a free wall strain of minus 29%, a dilated right ventricle. The dimension at the base was 57 millimeters, and mid right ventricle was up to 63 millimeters. TAPSI was 22. The fractional area change was about 40%. So reasonably preserved systolic function in a dilated right ventricle. Significantly also dilated right atrium.
And these are...
Yeah, we see here that we have torrential tricuspid regurgitation. The etiology of it is more likely ventricular functional. and the ERO was estimated at 1.2 square centimeters. Also, we have significant dilated IVC with hepatic vein flow reversal. Biplane imaging from the mid-esophageal view reveals a big coaptation gap at the center of the valve, which was measured at about 15 millimeters. So the patient was ineligible for edge-to-edge repair. Transgastric views show that we have probably 3 leaflets of this valve, or maybe even 4 actually, 2 posterior scallops. The jet is wide from across the coaptation zones. The wire seems to be moving freely in the center to septal posterior area. It doesn't seem to be impinging on the valve.
And these are
Can I ask a question? So this patient had a TAVI before. Left ventricular ejection fraction is good. So this patient had a ventricular functional tricuspid regurgitation. Why?
So as you can see, this is a great image. Maybe from the history, she had a Hodgkin's lymphoma. There was some huge, she underwent radiation and chemotherapy multiple times. And as you said, left side is very well. You get to see this hugely calcified as well from the CT images. So, and you saw the TT and the T image as well. So
right ventricular function is very good also. Very, very suitable case for tricuspid replacement for the large coaptation gap, etc. Should we, for example, measure pulmonary artery pressure, cardiac catheterization in this patient?
So we did have, for the sake of time, we didn't show it. There were raised pressures, right A as well. Right atrial pressures, they were high. But right ventricle pressures were more or less okay, as well as the wedge pressure. Okay, so you saw the CT images, very dilated right atrium, right ventricle. You can appreciate the wire as well coming in. As Dr. Chrysoheris said, there's a quadricuspid valve, and you get to see, for these cases, we like to know that the pacemaker has adequate slack, and you'll get to see why when we go to the procedure. This is the current landscape. So heart team approach, we never take decisions, personally, so we discuss them through, and we decided to proceed for a TTVR with the Evoke. Dr. Chrysoheris has already discussed about the Evoke, so I'm not gonna spend time. That's a very brief video showing about how the company and the people working for the company mount the valve. You get to see the valve right here, and they were going to mount it in the catheter, and you can appreciate the anchors that they will go under the annulus. I'm just going to go very quickly, and you get to see the 28 French delivery sheath, and you see this is the 2 knobs that the operator uses, the capsule knob and the release knob. This is what you use first to release the valve in the ventricle, and then the blue knob to release the valve in the atrium. And you have a primary, secondary flex, and this is your depth knob. And let me just walk very quickly. And you know how they just mount the valve very quickly. And I'm just gonna go to the next video. So this is how the room is set up. This is the hybrid, GS room, hybrid room. These are the team from Edwards preparing the valve. These are our nurses, operators, imaging, anesthesiology. So you get to see images on the right side as well, radiation and echo initially. So we always pre-close. We're going to use 1 or 2 pre-close depending whether we feel we should go with 1 or 2. There's the Agilis catheter. I'm not sure if Dr. Spargias wants to make any comments.
Yeah, this is the initial part. We have to be sure that we puncture the femoral vein at the right height, not too close to the groin and not too far away, because there'll be a large bore sheath going through. So we don't want to travel a long way under the skin.
And then we use the agilis to take the turn towards the right ventricle and advance the safari wire alone there. And as Dr. Harris said earlier, this is a very important part of the procedure. The safari wire has to go to the right ventricular apex, avoiding the papillary muscle, and as deep as possible. Otherwise, the capsule won't be able to get deeper into the right ventricle, so the procedure will be impossible. And now this is the step that the only step that the interventional cardiologist do something. So we advance the device, you see the capsule, and we start giving the primary flex, and then we have to time pulling back the safari wire and advancing the system, giving flex at the same time. Once this is done, and you don't have buckling of the safari wire into the right atrium, basically the procedure is over for the interventional cardiologist. Very minute movements from now on, just releasing and retracting the sheath and exposing gradually the valve, initially the hooks and then the rest of the valve. This is the point where we create the initial gap in the capsule, so very tiny retracting of the capsule to create a gap that makes visualization on echo much easier, and this is the point where we define the depth. We have to be, the gap has to be at the coaptation point of the leaflets at this stage, or a little lower, like here. And this is the timeout, and we decide if we have the correct perpendicularities, the correct coaxialities, and the correct depth. If everything is fulfilled, then we proceed to expose the valve. If not, then we have to remove the system out. If the hooks come out of the capsule, then you are committed to deploy the valve. So this is the initial part. We have the hooks to 45 degrees, then to 90 degrees, and then it is the flipping. Now it's completely flipped. And for all of these steps, we do the spinning on MPR, you see on the right side. So in each of these steps, we stop, and we spin the calibers to make sure that the leaflet is moving freely or is engaged into the hooks. And so we do that 9 times. In all these cases, we adjust the depth. So usually, initially, we are a little deeper, 1 to 1.5 centimeters, because when the hooks flip back, then you lose the depth of the system. That's why you need to be deeper at the beginning. If you, at some stage, you think that you are deeper septally or laterally or in the anterior, in the posterior side, you can make corrective movements on the system using the primary, the secondary flex, or torquing the system to obtain coaxiality. And once this is done, then the valve is released. And in all these stages, the cone of the capsule, it is retracted at every stage back to be close to the valve. And now we have to remove the cone, making sure that it remains coaxial, so it doesn't, it's not caught on the valve. And now we reverse all the movements on the system, so the primary flex, the secondary flex, and then we close the capsule, and now we can remove the wire, and the procedure is finished. What we're doing is we're using one ProGlide in most of these cases, and a suture of 8 at the end. So basically, it's a very lazy procedure for the interventionalist, but very busy for the echocardiographer.
Excellent. I want to ask a question, especially in, for example, when we use transcatheter aortic valves in tricuspid position, like in valve-in-valve procedures, we use Landerquist wire across to the pulmonary artery to make a support. The support for the press-shaped Safari is adequate, or sometimes do you prefer to put the wire distal to pulmonary artery?
You have to be at the right ventricular apex because your capsule will have this direction. It will be pointing to the RV apex, so you cannot have a wire into the pulmonary. And then you have to be a wire strong enough, like the Safari, but not so strong to have its own opinion and gives you a trajectory upwards, anterior. So I think Safari has been tested to have the right properties, to be strong enough, but not too opinionated.
Too much, yes. And now we are
We're going to move to the second case.
Moving to the second case.
Yeah.
Okay.
Dr. Aravadinos will be presenting, and again, we'll have the comments from the whole heart team.
Okay, so now we have an 85 years old female with a BMI of 21 km per square meter. She has shortness of breath and fatigue the last 6 months, and she was taking up to 245 furosemide per day, and she had multiple hospitalizations for and pleural effusions, drainage before MTIR. 1 year ago or some months ago, she had MTIR with a Pascal ACE device and no need for rehospitalization after that. She had also chronic atrial fibrillation, chronic kidney disease, PPM, chronic artery disease. In the previous coronary angiography, she had a CTO of the right coronary artery, past PCI in LAD and left circumflex artery, with a moderate ISR in the last of the LAD at the last coronary angiography. Here we see the screening, the echo screening. She had a severe tricuspid regurgitation. It is mainly considered atrial functional TR and related to the pacemaker, as you can see, with an arrow of 0.4 square centimeter. And from the transesophageal echo, we can see a 3-leaflet anatomy with the pacer wire posteroseptal and mainly a significant tricuspid regurgitation from central and posterior area. Here we see the CT scan. We can see the dilated right atrium and the right ventricle and the lead, the pacemaker lead. And the posterior side, also we can see from the CT scan the truly tricuspid valve and the length of its leaflet, anterior posterior and septal. Here is the Lux valve that we decided to proceed with the anchor tongue on the ventricular that goes on the ventricular septum, the grasping clips, and the fabric skirt that is used to reduce the paravalvular leakage and fits onto enterial wall. And here we see the procedure. I don't know, Mr. Sparias want to...
My comment here is that this lady has an impeded posterior leaflet by the pacemaker lead. It was obvious. And that she was rejected for EVOQUE because of IVC offset. So the plane of the IVC to the plane of the annulus were really apart, and the secondary flex of the EVOQUE system wouldn't be enough to make us perpendicular. So it's not only the sizing considerations, but also
the anatomy of the IVC in relation to the annulus of the tricuspid valve. So no tear option here because of impeded leaflet, and no evoke option because of the IVC offset. So we had to search for compassionate therapy with another valve, and Lux valve was available, and the screening was okay for Lux valve. So we proceeded with Lux valve. So this is a different approach. It's a jugular approach. So we go from the jugular vein, and initially we have a wire into the RV. We do an RV angiogram. This is different from the evoke. Just to see the plane of the tricuspid annulus, you see our Chinese proctors, and this is the way they have done hundreds of cases, so they're very experienced, these guys. And then, as you see, the capsule, which, if I remember correctly, Dionysus, 38 friends. 33 friends. It comes from above and without a wire. Initially you have the wire, but then you retract the wire. So the capsule is wireless, and it has just one flex, not two flexes like the Evoque. And by using a combination of flex and advancing the system in and out, and also torquing the system, clock or counterclock, basically you achieve the same movements you can achieve with Evoque, coming with the two flexes from the leg. So very similar. And then you release first there are two hooks, as you can see there, that go behind the lateral leaflets in a similar fashion with the Evoque, but only two. So this makes echoing less complicated, complex, Mike?
Yes, indeed. The anchors that this valve has is two, something like they call it rabbit ears, but once they are exposed, we have to check on biplane imaging that the lateral leaflets anterior and posterior are above these hooks. And once they're above, and we confirm that, then the next stage is to open the valve, which is opened in a very rapid sequence. Subsequently, what we need to do is to essentially adjust the depth of the valve, make sure the atrial flange is opposed to the base of the right atrium. And at the end, the very critical part and very interesting part is when there's a hook that is going to be pinned to the interventricular septum, and we have to carefully guide that with echocardiography. And I'm not sure if we have that sequence but it's a particular anchor that gets nailed, in a sense, into the ventricular septum. And that really stabilizes the valve position.
I think we have it in a separate slide.
We have it in a separate slide later. Here, we can see the ventriculography of the right ventricle. Sorry. Here. We see there the delivery catheter advanced near the tricuspid valve and then into the right ventricle. We have to make sure about the coaxiality and the depth assessment into the right ventricle. Then here we see the clasps, the paddles, exposed, and we have an assessment. Yes, here.
So here.
Okay.
So here you see the two hooks that are opening in a similar fashion with the Evoque hooks, and you see this pad here. That there is a fabric here. All this is a fabric between this nitinol frame, so this valve stabilizes at 3 points: the two hooks, and then the pin that comes through the fabric to the septum.
Okay, and now that the paddles are exposed, we have the assessment of leaflet engagement. And here again.
So here is very similar to like a tri-clip or Pascal. You check the arm of the hook and you make sure that your leaflet moves above it.
Here's
you
the
see
valve. The valve expansion, and also. And here what Mr. Chrysocheris said before about the anchor deployment in the mid-septal area.
So here you have to make sure that this pad, you see the two nitinol here, it's compressing the interventricular septum. There is no space between the pad and the muscle. And once you see that, here you see you advance this catheter that is connected with sutures there, and you see how in a moment these three hooks, very tiny, comes out. They come out and they pin the fabric on the septum.
And here is our final position and the result with no regurgitation, and the 3D images also after the Lux valve release.
Congratulations, very excellent case. And actually, which fluoroscopic position is this, right anterior oblique or AP for the tricuspid?
This is RAO 20 to 30 degrees.
22, okay. And one another question. In both cases, I think the ICD-related cases, good selection for the TTVR, but we saw no regurgitation, zero regurgitation. This afraids you or not? In general, question.
First of all, in both the evoke and this case, you see how the pacemaker wire is pushed apart by the frame of the valve without any problem. That's why you need to have a redundancy in this pacemaker lead, and we always check, of course, the parameters, the pacing parameters before, after pre-discharge, and 1 month afterwards. And the valve, the position of the valve, it's critical, so we have to check on fluoroscopy from various angles that we have good position of the valve is not constricted. And then the RV function, supposedly we check the RV function before we make the decision. You know, a severe RV dysfunction is not accepted. But we had cases with moderate RV dysfunction, and our experience said to start milrinone in these cases during the procedure, just a preemptive movement to prevent or to help to reduce the possibility of RV dysfunction.
As we did in this case.
Very helpful comments, okay.
Congratulations once again. One more comment. You pointed out that anatomical features led you to choose Lux valve for this case. Are there any anatomical issues that you would choose Lux valve instead of Evoke, apart from what you said about the IVC? And what degree of paravalvular regurgitation would you accept in these very complex cases as okay? What do you say?
Ideally known. That's why we select a valve and we're not going with a clip. So I think that is the target, the aim, when you go with a valve to have zero tricuspid regurgitation. Because from all those studies we know that even moderate residual regurgitation may be a prognosticator. So, but we have to correct the cases anatomically and also clinically, for sure. And let's move to
Yes,
the
I want
last
to
case.
invite Dr. Katsianos from Hygia team for another interesting case.
So hello, dear President, hello, dear colleagues. I'm moving on with the third case, a patient with torrential TR due to carcinoid heart disease, 93-year-old female, patient BMI of 33.1, short of breath and fatigue with signs of right heart failure, ascites, anasarca, multiple hospitalizations for IV diuretics, ascites drainage, and as we said, metastatic carcinoid in the last 6 years on telotristat and somatostatin. A wide open tricuspid valve with free TR. We have also a hepatic flow reversal. From the rest of the history, chronic AF, chronic disease, anemia, and hypothyroidism. We have a high Euroscore 2 and a tri-score of 22%. We see the left ventricle non-dilated, and we see the images of torrential TR, a wide open tricuspid valve, as we said, due to carcinoid. Here are our assessments. We see an area of 15.2 square centimeters, and the CT assessment. As we said, it is crucial to assess with CT such patients that we plan to proceed with, as we said, the Lux valve, since there are specific characteristics. For example, we have a minimum diameter of the internal transjugular vein, brachiocephalic vein of 8 millimeters. We have to have RV length more than 45 millimeters. We have to have thickness of the intraventricular septum of at least 6 millimeters and an angle of the tricuspid valve annulus with the septum, the intraventricular, between 80 and 100 degrees. So there are specific and criteria to choose such patients. So we proceeded with the orthotopic independent radial force valve, the Lux valve. Here we see the valve. Dr. Arvadinos commented on the valve before. As Dr. Spargias also said, it stabilizes with 2 graspers, 2 rabbit ears, as Dr. Chrysoucheris said, and the anchor that we set in the septum.
Kyriakos, just to clarify that the reason this patient was excluded from EVOQUE was the plaster septal leaflet. So the septal leaflet was on the septum, so there will be no space for the hooks, the EVOQUE hooks, to go behind.
And here we see the video of the intervention. We will move on. The preparation of the valve is very thorough from the proctors, and we proceed with ventriculography for road mapping. We see the pigtail.
You see, the preparation is very tedious. There are multiple tiny nitinols that they have to be pinned in specific places for the release.
I'm sorry. Here's the insertion. We pre-dilate, as we said, with 30 until 33 French of the right internal jugular vein.
Κυριάκο, το βίντεο δείξει, γιατί εδώ πήγε στο τέλος.
Πήγε πίσω. Yeah,
Ας το
sorry.
μου παίξει.
now have introduced the sheath. We stabilize. I'm sorry if I press here. Sorry. And here we see the stabilizer, the sterile stabilizer. Now the delivery system is coming.
As you see, the stabilizer is a different concept than what we know about the stabilizers of the systems that are coming from the leg. A lot of arms, and it can go anywhere, but you need to stabilize the system very well, because even 1 millimeter of movement from outside will have a big effect when you're into the heart. So it has to be absolutely stable on the table and not moving.
So we introduced the delivery system initially in the atrium. It is with a wire, and then we introduce the system with the ventricle, as Dr. Spargia said also before, without a wire, through flexing the system.
So the movements here to get coaxial, the anterior posterior, if you advance, you go posterior. If you pull back, you come anterior. And then the septal lateral, it's by torquing. If you torque, you go septal. Counterclock, you go lateral. And then you can also use, of course, the flex of the system that will also bring you anterior posteriorly. If you flex, you come anterior septally. If you unflex, you go posterior septally. So I think the secret for all these capsule valve cases is to be absolutely coaxial. So you see here the septal lateral on the right image, and the anterior posterior on the left image. The septal lateral, it's very good. You agree? It's the trajectory is good. The other one you cannot see in because you have to bring the caliper across, but probably we'll see it later. It appears to be in the center. It may have a posterior trajectory. Now, yes. So now you can see he moves the caliper there. It's quite central, probably with some slight posterior trajectory, which you can correct by flexing the system. So you have two ways to, if you just want to come anterior, you flex the system. But if you want to move all the capsule anterior without changing the angle, you just pull it back.
It looks like the maneuvers that you use in mitra clip. I mean,
it's all similar with the maneuvers you use in tri-clip or Pascal in the tricuspid. So
the anterior and posterior.
Yeah, and the terminology is similar.
Terminologies, yes.
So we begin to unsheath the system. We see on the left picture, the fluoroscopically, the unsheathing of the system, so that the two graspers, as Dr. Chrysoheris said, the rabbit ears come gradually out. We want that these two graspers, the anterior and posterior, are about 1 centimeter under the annulus before we proceed with the explosion of the graspers. So Dr. Chrysoheris is looking thoroughly through the valve. We have to be sure that we have that we see leaflet above the graspers, the anterior and the posterior. before we can proceed with the next step, it is unsheathing the ventricular portion of the valve. I'll try to move on. In cases that the TOE imaging is not adequate, it is described that we could use ice. So we see the rabbit ears are orthogonal, perpendicular to the system. Moving on. And we see that now we're satisfied with the leaflet positioning above the rabbit ears, and we have revealed the ventricular part of the valve. We see that the anchor septum, the anchor is towards the septum, the interventricular septum, and we see also the nice movement of the two graspers. Now we have also, we can see the tube in the middle between the graspers that we are going later on to place orthogonal to the membrane of the septum membrane.
Kyriakos, yes. On the right image here, we see that we can advance a little bit the valve to come into to engage the annulus as possible, to reduce any PVLs before we do the final stabilization of the valve with the anchor in the septum.
Thank you, Michalis. Since the system is still attached to the delivery system, we can do this fine adjustment, as Dr. Kyriakos said, so that we are satisfied and we see that there is no PVL before proceeding. So we'll move on a bit. We have released also the atrial part of the valve, and now we see the tube, the anchor, placing orthogonal to the membrane of the anchor, of the septum anchor.
So this valve releases in a very quick succession. Once we know that the hooks are below the anterior and posterior leaflets, and the position is corrected to not have any PVLs, the valve opens in a very quick succession, and it's open. You see it open here, and now we have the deployment of the anchor at the septal level here, which is done under fluoroscopy and echo guidance, as you can see here.
These are those nitinals. Michalis, can I have this? You see the valve is still connected to our system, although it's released. So the flange is open, the valve is open, the hook through the fabric is on the septum, but you see we're still connected to our delivery system with these multiple nitinol wires. These were the tedious part that these guys were doing in crimping the valve. And now this is the final release of the valve. When you release those multiple nitinol hooks, and now the valve is completely free. And then you have to reverse all the manipulation you did earlier. You see how we straighten the capsule to make sure that we're coaxial with a tab that is still in the ventricle, and we pull it back slowly, and the procedure is finished.
Retracting the system.
And here we used, if I remember well, 2 proglides.
That's correct.
So it's not surgical cut down, it's with puncture of the jugular, echo guide, and 2 proglides at the beginning.
Yes, this valve offers another option for patients with large annuli till 70 millimeters, as Dr. Spargas mentioned before. We introduce the system initially with a wire in the atrium, and then we proceed without a wire. We introduce the system in the ventricle. We see that the valve, we assess the delivery system and the positioning of the valve to be coaxial to the valve. We check the anterior, posterior, and septal lateral, and we correct it through maneuvers. We adjust the depth and the trajectory. We use MPR for coaxiality to the annulus plane, and we expose the 2 rabbit ears at the beginning, then the ventricular part of the valve. Then when we see there is no PVL, we proceed with exposing the atrial part, and then we anchor the valve with the 3 nitinol anchors. Yeah, this is what we presented, and here we see nicely fluoroscopically the tube, as we said, orthogonal to the membrane of the septum. And here are the hooks, the 3 nitinol hooks, which are fired through just pressing a button of the delivery system.
So this system has 2 passive components of anchoring, which are these rabbit ears, and 1 active component, which is the hook that is pinned into the septum, and also the atrial flange, which is also a passive component for anchoring and stabilization. And in comparison, the Evoque has passive, mainly anchoring with the hooks. There's nothing active. And I don't know, I think the footprint, the metal footprint of this device is probably less than the metal footprint of the Evoque valve. But none of the 2 exerts a lot of radial force on the annulus, because they are not anchored like the aortic valve on the annulus. They have anchoring at other levels and with other manners. And because there's basically the annulus of the tricuspid valve is virtual, it's not a real annulus.
So risk of embolization, if not delivered properly?
If the anchoring is correct, then you shouldn't have it. And the initial part is, we are very familiar with clips in the tricuspid valve. So the initial part is like a clip. You have to make sure that you have the leaflets above. Once you do that and you release the valve and you're coaxial, it stays there. And then you do the active fixation.
Here we see immediately after the RV function on the table. RV STDI is impaired and TAPS dropped off as well. So even the appearance of the right ventricle seems to be a little bit depressed. So we initiated some Milner-known preemptively, and the patient did well, was able to get out of the hospital within the next 3-4 days.
Congratulations, really. We watched 3 important tricuspid valve replacement cases, and I really want to congratulate the whole team, Professor Spargias and his team. So, do you want to add some comments? Okay.
What was the mean gradient? Gradient of the diastolic gradient of the valve was low. It was 1.
I think these cases are not only the first cases in Greece, and these are the first cases in Europe. So congratulations to all team, and I hope these all procedures will light the literature and will be very beneficial to all patients. Thank you.
Thank you.
Further delay. It's a great honor and a privilege to be with you this afternoon. Me and my co-chairs, we will be hosting a session with what else? TAVI, which is the main topic. It's a great deal of pleasure to be with friends and colleagues that we have evolved as the procedure has been evolving over the years, and we would be delighted to see what they have to offer us for this year. So with no any delay, I would like to call Dr. Andreas Netos from Cardiothoracic Hospital to present their case. Andreas, you have the floor.
Thank you very much for the invitation. I'd like to thank the Professor Spargias, Dr. Patakos, and all the friends of the organizing committee for the kind invitation. And we will see a case that we did a couple of years ago, and it's a patient that is of high risk for, thank you, for occlusion of the left main. And we will see how we can, sometimes we can be misled by the evidence that we have from the echo and from the coronary, from the catheterization. So let's see our case. She's an 87-year-old female with severe aortic valve stenosis, good ejection fraction preserved, a Vmax of 4.5 and an area of 0.62. She was on NIHA Heart Association, New York Heart Association 3 to 4, and she had a permanent implantation of a permanent pacemaker DR a couple of years before the procedure. In the coronary catheterization, she had no significant coronary artery disease. She was deferred for SAVR, and of course, she was planned for transfemoral TAVI. These are some facts from the CT scan that we had. As you can see, we had the two major concerns. The first one was the high of the coronary ostium, especially on the left main, which is 7.9, and the right ostium is much better, and the small diameter of the sinus suprasabra, which was below 28. So we knew that this patient was of high risk for coronary, for occlusion of the left main, so we decided to go with an Evolut R with a 26 millimeter, and we intended to go with a very deep implantation. We knew exactly that the skirt of the depth of the length of the skirt is about 13 millimeters, so we intended to go with a depth from the annulus of about 7 millimeters, so the remaining 6 millimeters would be enough not to have occlusion of the left main. In this case, we had two major concerns. The first one was that we were not afraid of the possibility for a pacemaker because the patient had already a pacemaker, but we had to go with the oversizing because we didn't want to leave any significant PVL in this patient. So this was our setup. As you can see, we went with left femoral 6 French Jenkins 4 guide, with the right radial with the 5 French pigtail. This is a setup that we use especially with the pigtail, so we think that it's much safer and not to have complications from the femorals. And we decided to go also with the chimney technique, so we parked the 4.0 stent in the mid LAD, hopefully, and we didn't intend to use it. This is you can see on the left panel that we have already the first aortography and the amplats in the left ventricle. And you can see also we passed the confida, and this is the first valve that we did with a small balloon, 16 millimeters balloon, and we see the aortography. On the right panel, you can see that it seems that we have a massive AR, regurgitation of the aortic valve, and there's not a very good visualization of the left main during that time. The problem was getting much worse because the patient was hypotensive. We thought that she had the left main occlusion, and she lost consciousness. We started to go CPR and intubation, and we inflated the stent in the left main, and all of the others continued. However, nothing changed. The patient was getting worse. You can see that we had a lot of good CPR because we were able finally to keep the patient alive. But however, we couldn't have any ROSC, return of spontaneous circulation in these patients. So probably what we did was not enough. And finally, after a couple of minutes, we used the echo, and we saw that the problem was not the occlusion of the left main, was this effusion of the pericardium that we drained. And as you can see, the final result was quite good. The patient survived and was extubated after 2 days. She was in the clinic after 4 days. She had a coronary COVID infection, and during our last checkup, she was planned to go for some other minor operations, and she wondering whether she could stop the antiplatelet therapy. Thank you very much.
Wonderful case, Andreas. So, what do you think was the reason for the effusion? What do you feel is
most probably was, if you could see, during the second or third slide, the balloon was moving towards the apex of the LV. So most probably, although it was a small balloon, 16 millimeter balloon, that was the reason what caused the rupture.
You didn't push the wire.
Yeah.
Any comments from our moderators here? Dr. Javier?
Congratulations, Andreas. As far as I understood, the annulus was not so calcified. Did you consider to go straight with the valve and to avoid the balloon, the predilatation with the balloon?
Okay, it had some calcification. However, we wanted to see also how it will be the calcified just after the balloon, because it would be a good chance to see how it will behave, the whole valve. However, it was an option. The calcification was not quite high, so we could go directly. But usually, it's when you go for the left main, you try to have a strategy to see whether the behavior of the native valves would be, or the calcium will be good or not appropriate.
Congratulations, Andrea. Excellent case. To pinpoint that there are many things that could go wrong, and not only our automatisms. It's not our automatic thoughts. So it was different. It might be from the massive regurgitation. It might be from the coronaries, but it was from the pericardium. Should you have done this procedure more recently? Would you prefer some other materials or another valve or another procedure?
Well, this was what I was thinking about. During that time, what we were thinking, and the common knowledge is that usually you need a short valve, a balloon expandable valve. That would be much safer in this case. However, as you know much better than me, probably, there are some case reports and some case series that show that these valves, the self-expandable valves, they can go much better, and they have less percentages with occlusion. Most probably, this is because of the concave part of the mid part of this valve that does not exist in the balloon expandable valves. So I am not sure whether we would go with a different strategy. The wire, I think, was the confida, it was hypertrophic ventricle. I think we would go with the same. I think what we will do, most probably we wouldn't be so easily misled by the fact that we were afraid that well, the most possible cause would be the occlusion of the left main, so would avoid the implantation of the stent.
All right, thank you, Andreas. Thank you very much for the case. I would like to call up Dr. Lambropoulos from Euroclinic. And just in the interchange, I would like to say that it's always a good idea to pre-dilate with a balloon when you have a small aorta, aortic root, because you have to have a good idea how would the leaflets of the small in the leaflets of the aortic valve would interact with the left main. So, Kostas, you have the floor.
Yes, thank you very much. Thank you for the kind invitation. Once again, I would like to present the valve-in-valve in aortic position. Why we do more and more valve-in-valve? Because the use of the bioprosthetic valve increase, because the operative mortality increase more than 30% in high-risk patients, and because the valve-in-valve is minimally invasive alternative choice. We know predictors for early tissue valve failure. These are young age, renal failure, and valve type. And of course, the most common reasons, wear and tear, classification, pannus, endocarditis, and thrombus. And let's see our case. This case we done together with Dr. Zacharoulis 2 years ago. This is an 86-year-old lady. She had a single CABG, Lima to LAD, and one self-expandable supraannular sutureless bioprosthetic valve, Perceval valve, large size. She was in medical background with hypertension, dyslipidemia, atrial fibrillation, and implantation of pacemaker. And the reason for referral is recent onset of angina and dyspnea. We have some findings, clinical findings. These are the medical treatment, beta blocker, statins, and apixaban. This is the Perceval sutureless valve, and according to the sanotubular junction, these are the sizes, small, medium, large, and XL. It is important to know how these valves we can see on fluoroscopy and what are the markers of this valve and why they use the surgeon these valves, because it's a minimal invasive approach, because they have shorter duration of cross clamp, because prevent patient's prosthesis mismatch, allow a larger effective orifice area, and because it's an ideal solution for elderly people with a small annulus. Back to our patient, we have elevated NT-proBNP, we have pulmonary congestion from the chest X-ray, and from echocardiography we saw a significant failure of bioprosthetic valve with peak velocity 6 meters per second in aortic position. We performed coronary angiography, and we saw also that this lady had two vessels disease, 80% in mid RCA and 80% in mid circumflex. The Euroscore was 15, and the heart team in our hospital decided to proceed with valve-in-valve. The next step is which valve we are going to choose, and we have decided to do two steps management. First, we done the PCI at RCA, and then the PCI at the circumflex artery with good result. And we performed the CT scan, the trimation, and we saw good femoral arteries. The height of the coronaries was quite good. And the valve that we are choose was the accurate neo, the large size. This is the characteristics of these valves that we know all. And the ideal placement will be in line with the lowest visible margin of the Perceval valve stent, as you can see in the right picture. And we start the procedure, transfemoral access. We are pre-dilatation with a balloon atlas, and then we implant the accurate neo exactly at the position that we said. And this in the right slide is the final result. The follow-up of our patient is quite good. 3 days hospitalization and then discharge. The residual mean gradient was was below 20 millimeter per mercury, and we follow this patient 1, 3, and 6 months without any symptom. This case we present last year to the European Society of Cardiology, and we won the bronze award in the Healthcare Business Award in 2023. 2 years follow-up of our patient, we see without the symptoms, the valve is quite good, and the peak and the maximum velocity is 3 meters per second. We have data for valve-in-valve, early and mid-term, with good result versus redo SARV. We have less mortality and stroke in valve-in-valve. Meta-analysis, in 1 year, we have less mortality in valve-in-valve. For balloon expandable valve, we have better results versus redo SAV in all complications, and also in balloon expandable valves. Regarding the two supraannular valves that we have, the Accurate and the Evolute, we have similar procedural and clinical outcomes according to the average registry. So the only question that we have is the durability, and we need long-term data to answer this possibility. Thank you very much for your attention.
Congratulations, Kostas. And I also forgot to congratulate you on your new position in the University of Thrace. May you prosper there. Any comments from the panel?
Actually, it's a very nice case, and such a pity for this woman to have surgery at 80 and then have a new problem at 86. And I think that the approach you did was quite good. My question is, did you try to see if you could actually cannulate the ostia after the valve-in-valve procedure?
No, but this is a reason that we chose the Accurate Neo, in order to have the possibility later, if it happens something, to have a better catheterization in the ostium of the left and right artery, coronary arteries.
Yes, I completely agree. Very nice. Thank you.
Dr. Gabrielatos.
Congratulations, Kostas. I noticed that you did the pre-dilatation and you carefully implanted the valve. Do you usually do the post-dilatation in order to get a better alignment?
Not in all cases. Because
in Percival, not?
Yeah, not
but
in all cases.
If it was a trifecta?
Yes, perhaps, yes. Yeah.
Okay.
Great job on the price as well. If there's going to be a need for a third valve, what would you choose?
This is a good question, yeah. But the lady is 90 years old now.
Kostas, congratulations. You think that those 3 meters, I don't know what it was immediately post-procedure, but you think that those 3 meters of transvalvular velocity is...
It's acceptable.
Is acceptable on one hand, but it has to do, it has a large Percival, it was a large Percival beforehand. I don't know how was the base gradient, the ID gradient when it was implanted, and I don't know how it was, how much was the gradient immediately after your procedure.
Yeah.
Because if we have now 3 meters, that is a harbinger of not good news.
At the beginning, the velocity was 6 meters per second. After the procedure was 2.7, 2.6, something like that. And 2 years ago, it's 3. I think it's acceptable for this lady.
Okay, thank you, Kostas. It's acceptable. What is one can do, what one can do. You can do better. Dr. Halapas is going to present the next case from Athens Medical Center. And having that said, before we go that, and there's going to be some discussion with regards of TAVI, valve in valve, and all these things, we should keep in mind that there is a shifting of the game. I think that we're going to be doing more and more TAVIs in the next few years, rather than TAVIs in surgical valves. Anyway, go ahead, Antonis.
So, dear President, dear colleagues, I want to thank the organizers for having me, and in the next minutes we are going to discuss an interesting case regarding bicuspid aortic valve anatomy and TAVR. And why this subject is of great interest is the fact that we face this issue in almost 20% of the TAVI cases in Western population, and we face this anatomical variation even more often in Asian population. It is also an issue that we face it usually in younger ages. It is characterized by great anatomical heterogeneity having to do with a number of commissures, heterogeneity having to do with a number of sinuses, the calcium burden, the localization and distribution of it, the length of and the height of the coronaries. We have high frequency of coronary anomalies, the coexistence of aortopathies that occur up to 60 to 80% of the cases. And also it's of high interest because we do not have solid data based on randomized controlled trials. This it is also reflected in latest published guidelines. The European guidelines do not recommend TAVR as an option. From the other side of the ocean, the American guidelines recommend them as an alternative for surgical approach when the patients are of high prohibitive surgical risk and when there is no aortopathy. Here comes our case. This is a lady, 82 years old lady, who came to us due to congestive heart failure symptomatology. She has no coronary artery disease. The ECG at the baseline had a PR interval of 230 milliseconds. And by the baseline echocardiography, you can appreciate the severity at the level of aortic valve stenosis with a mean gradient of 43, an AVA index of 0.54, a borderline left ventricular ejection fraction, and mild left ventricular hypertrophy. And also you can appreciate at the baseline echo the fused valve configuration at the aortic valve with left to right cusp fusion that you can appreciate in the parasternal short axis at base. So we proceed further with coronaries. The coronaries revealed no relevant issues, right dominancy. The hemodynamic assessment of the aortic valve stenosis confirmed the severity. The height, as it was estimated by the CT analysis, was sufficient enough in order to avoid any coronary obstruction. And the CT analysis at the level of the aortic valve revealed a moderate to severe calcification, type 1 with left-to-right fusion according to severe classification, functionally 3i commissural raphe type with no relevant asymmetry based on the Bavard classification. The anatomy at the level of the aortic root revealed no any relevant calcification at the level of the LVOT, no severe ellipticity at the level of the annulus, and you can appreciate by measuring the dimensions 4 millimeters above based on the Bavard registry and based on the configuration at the aortic root and the landing zone. You see that we have a tubular configuration at the landing zone based on the data derived from the Bavard registry and presented by Dieter Zetsche. So based on that, sizing of the new implanted valve must be done based on the annulus diameter. There is no any relevant issues regarding ascending aorta and aortopathy, and the annular angulation was in the normal range. And the iliofemoral system, the peripherals were with no relevant issues, no severe tortuosity, no calcification, no relevant stenosis. So based on all that, we have an old lady who had an anatomy which is favorable for transcutaneous aortic valve replacement, and who were possible to proceed with that through the transfemoral approach. The data that we have up to now revealed that based on the low-risk bicuspid study for the Evolut platform and based on the Partner 3 bicuspid registry for the Edwards platform, when we compare the transcutaneous treatment for tricuspid versus bicuspid anatomy, there was no relevant difference in terms of MACE. So that was the reason why 2022 the BAV and the TAVR approved by FDA. Based on real-world data coming from observational studies, when we compare surgery versus TAVR in such anatomies, long-term there is no huge difference in terms of mortality. So in each case, we have to individualize the treatment approach. And according to the device that we have to choose, we have data revealing that both most commonly used devices, the self-expandable platform and the balloon expandable platforms, may do not differ in terms of mortality. It seems, however, that the self-expandable platform may have a more favorable anatomical features. That's why we decided to proceed with a new generation device, the Hydra valve. This is a valve which has certain anatomical features that are very important during the procedure, such as the no flare at the inflow portion, diminishing the risk of conduction abnormalities, and also the large frame cells at the level of the coronaries, making the engaging to the coronaries easier after the procedure. Here is the valvuloplasty, semi-compliant balloon under rapid pacing, and thereafter we proceed with a gradual release of the valve. We proceed with the implantation at cusp overlap view. You have to try to be as high as possible, and this is the final result, a stable platform, no relevant paravalvular regurgitation, and great hemodynamic performance, having a mean gradient less than 10. The technical characteristics, we have a procedural time which was less than an hour, the fluoroscopic time was less than 20 minutes, and the device time was less than 5 minutes. A couple of hours later, the lady developed high AV block requiring permanent pacemaker. Otherwise, the rest of hospital course was uneventful, and she was discharged on day 3 after the implantation. And 1 year follow-up, you see a stable platform, a good left ventricular ejection fraction, and a very good hemodynamic performance with a mean gradient of 8 millimeters of mercury. And with that, I want to thank you for your attention.
Very elegantly done, Antonis. Any questions from the panel? My surprise here in this case is that you have a bicuspid valve than an 82-year-old lady. You would have expected a much younger patient with a bicuspid valve to develop symptoms, and she was neglected. What happened? Why did she came so late, or it was a very low progress of the disease? What is your take on that?
She doesn't have any other cardiovascular risk factors that may accelerate the propagation of the calcification of the valve. And she was a type of valve which was showing by you can appreciate that the ascent aorta was in normal rate, so you didn't have any significant hemodynamics that may influence the fast propagation of the severity of the aortic valve stenosis.
Perfect.
Congratulations, Antonio.
It was a yes.
I think we are talking about two different subsets. We have the congenital bicuspid valves that come with those orthopathies or coarctation of aorta, etc., and maybe predominantly regurgitation or stenosis. I think this is not inherited. It's degenerative. Sometimes those raphe of the valve stick together, and it's not congenitally bicuspid valve. It's a different story because there you have to consider other things. You have a valve in a very young person, so you have issues of durability of the valve beyond procedural aspects of asymmetry of the annulus, etc.
So you're saying that it was a functional
May I make
bicuspid, not congenital.
Achilles, may I make a comment on that? There is a great classification based on Bavard registry. And as you can show in my slides, I mentioned that it was a tricommissural bicuspid type. So this is part of the BAV morphology that we face. So BAV, it's an anatomical variation with great heterogeneity. And that is also the reason why we do not have a standard algorithm approach in such cases.
Great. Just one last comment. I think it's very important to distinguish between what we said, the functional bicuspid or the congenital bicuspid is a very good evaluation of the CT. When you have calcification extending up the wall all the way up to the STJ, then it's probably a congenital rather than a functional bicuspid. Anyway, Adonis, thank you very much. Wonderful case. So, yes, I'm sorry. I didn't. So.
Dr. Hlapaz, could I ask a question? To begin with, congratulations, this was very elegantly executed. But considering this is supposed to be a bicuspid valve, either functional or not, if you had a younger patient, let's say 65 years old, and it was indeed a bicuspid, and you have severe calcification, usually on the leaflets, would you consider using cerebral protection in these cases?
This is a very nice comment. Protection, especially the bicuspid anatomies, it was referred that they have higher percentage of strokes versus tricuspid anatomies, although there is individualization and there is great heterogeneity on that. A great issue why we have more strokes is the fact that there is usually under-expansion. That was also shown in the Notion 2 trial, was recently presented, showing that we have to be very careful when we treat bicuspid anatomies. Protection, embolic protection, although there are strong data showing that there is a great benefit, should be part, especially in younger patients, yes.
So, congratulations, Dr. Hlapaz. Do you have any data from randomized control trials or any other registries about this valve? The first time I met this valve, I have no any idea.
There are data not for bicuspid anatomy. There are data published in high-impact journals showing 3 to 4 years. Data showing a very sufficient results.
Non-inferiority data comparison with the commercially available valves?
Not yet. Not yet.
Okay, so we have to really move on, get moving on. Our next case is from St. Luke's Hospital, Thessaloniki. Is Dr. Dardas, is he online? Do we have him?
Everybody, good afternoon. Can you hear me? Is it all right? Okay. Thank you for the invitation. I'm going to present a case. It's a relatively old case, but it's demonstrated because of the unexpected complication that we should all be aware of. This is our heart team at St. Luke's Hospital, and these are my disclosures. Now, 83 years old female, suffering with severe AS, and back in 2014, she received a Percival small valve due to the aortic stenosis. She had radiation for SCA breast in 2017. She came to us about 6 years ago with progressively worse breathlessness, and she already had 2 admissions with acute heart failure and also had moderate kidney renal chronic renal failure. The echocardiogram showed severe bioprosthetic valve stenosis with a mean gradient of 54, good LV, severe pulmonary hypertension, so a quite advanced case, and mild mitral regurgitation. The coronary angiography showed normal coronary arteries, and this is the transthoracic before, good LV function, and severe gradient to the Percival bioprosthetic valve. She had a quite high Euroscore, and we decided to perform a TAVI on her. Because it was a small Percival, we decided to go ahead with the supraannular Evolut 23 millimeter TAVI valve. Because he was quite sick, we wanted to perform a transesophageal also and see what was happening. And you can see that there is a quite thrombotic environment. She was in a state of low flow. You can see a lot of smoke in her LA and possibly some thrombus in the LA appendage. And also you can appreciate here the motion of the leaflets of the Percival valve, which are quite akinetic. So this is the status of her LV, and this is her aortogram. And we went ahead with the routine procedure of valve-in-valve TAVI operation. By the time we were trying to cross the valve, the patient suddenly became grossly hypotensive and hemodynamic collapse and simultaneous VF arrest. So at the time, we didn't know exactly what was happening. You can see here LV. You've got to consider some options. First, tamponade. Second, whether we damaged one of the leaflets while we were trying to cross with a straight wire. And the LV showed a lot of severe hypokinesis. You can see that suddenly the LV became very hypokinetic. We performed an aortogram in order to see whether we had any annular rupture. And I don't know whether you can see that there was something strange happening in the coronaries. So we thought that coronary damage could be a cause of her sudden hypertension. We took a guide cath, and this was the first appearance. Remember that her coronaries were normal. All the left system was full of thrombus. So we assumed that at the time that trying to cross the valve, that not only the heart, but the valve also had thrombus. So some thrombus was dislodged and went directly to the left main and blocked both arteries. The patient was pretty unwell, you can understand at the time. We had to do something very quickly. So we tried to aspirate. We first aspirated the circumflex, then the LAD. Fortunately enough, the circumflex opened quite quickly after 3 aspirations, but the LAD required 15 aspirations and 3 aspiration catheters that were used. And you can see all the thrombus that we extracted from the left coronary system. This is the first appearance. As soon as we opened the dominant circumflex artery, the patient started recovering a bit. The blood pressure started, she was on full inotropic support, but the blood pressure started going up a bit. We tried hard with the LAD, and we managed some thrombectomy proximally. We couldn't advance the thrombectomy catheter more distally. So we took a filter XT. We performed another thrombectomy to the LAD. We had some flow distally. We performed a small balloon and another thrombectomy catheter. And also we gave intracoronary episiximab and gradually starting restoring the flow down to the LAD. And we performed the thrombectomy to the diagonal as well. And in the end, we managed to have a good flow down to both vessels. So all this took some time, and the patient started recovering, but she was still on inotropes. So we decided to go ahead for the TAVI and not to stop the procedure. We used a smaller catheter. We used an AR to cross. uneventfully this time. We put the confida. The evolute couldn't actually cross, so we had to pre-dilate with a balloon. We changed the Landerquist again the evolute couldn't cross, so we dilate with a balloon. And after the balloon, the evolute crossed quite easily and was deployed according to our initial plan. And this was our final angiographic picture. No stenosis, trivial regurgitation, the hemodynamics fully restored, and the transophageal showed full restoration of her LV function and very good functioning of the new TAVI valve. And you can see the LV post and the LA thrombus still there, but she recovered quite well. And the gradient before was 50 to 60, the gradient afterwards was less than 5. Well, this was not the end of the story because she developed right femoral thrombosis. But after prolonged balloon inflation, we managed to restore the flow down to the femoral artery. She was discharged day 6 in class 2, and she gave me a phone 3 weeks later to ask me if she can invite her friends for a party at home. She survived for some years uneventfully. So the message is that in TAVI, you may have one of the usual complications, but sometimes you may have unexpected complications, and always keep calm and walk on. Thank you very much.
Wonderful case. Do we have any comments from the panel, please?
Yes, actually quite a scary case, a nightmare probably in the cath lab. My question is, after restoring all the flow to the LAD, before attempting to continue with the valve implantation, did you consider placing a filter at this point?
We had enough. And we thought that all the thrombus went down to her coronaries.
Congratulations for the great save, Petros. I have also a short comment. And since you did the transesophageal, and the save was very nice because you didn't use a stent. This is very, very fantastic. And I don't know, maybe it was from the thrombus that it was in the LV also and migrated also to the valve. And did you consider to put the patient in some more intensive antithrombotic treatment and come back for the procedure?
No, the patient was pretty unwell, actually. And one of the reasons that she was intubated was because we want to control her hemodynamics better. She was not to wait. And actually, the transophageal showed all this thrombus. We were not aware of the thrombus. And I presume that there was thrombus on her valve, on the Perceval valve as well. And this is why all the picture came after we tried to cross with a straight wire. Presumably some thrombus, some clot went to the left coronary.
Petros, this is Kostas. Hi.
Hi, Kostas. Hi. Thank you for the invitation.
Petros, you keep surprising us every time with awesome results, great saves, unexpected things happening. And I'll say again, οι ασθενείς έχουν Άγιο στον Άγιο Λουκά.
This is why it is called Άγιος.
But not only Άγιος στον Άγιο Λουκά, αλλά έχουν και skillful cardiologists and teams ready to face any complications successfully. So congratulations again. Just a short question, because I wasn't there from the beginning of the presentation. Did you have any indication from the CT scan, the screening CT scan, that there could be any clots on the leaflets?
No.
Any thrombosis? No, it was thin
And,
leaflets.
Yeah, that's right. And also the transesophageal, the initial TOE picture that we performed didn't show any thrombus. So clot in the LA appendage, but no thrombus. But possibly there was thrombus, small thrombi on the leaflets. But nothing obvious.
Right. We had a couple of cases that we had ham on the leaflets on the screening CT scan in surgical valves, and we defer the procedure for a few weeks, giving syndrome, anticoagulation. Even if that was a false image of clot, it brings peace in mind that you've given anticoagulation, so if there is any fresh thrombus, it goes away. If it's an old thrombus that is like a fibrous now, you have no effect. But if you see something pronounced and marked, then you should think about deferring the procedure for like 4 to 6 weeks. And thank you again, great case.
Thanks.
So congratulations, Petros. I'm Yorgos Georgiou from Nicosia.
Yeah, so Yorgo.
So just to highlight that crossing Percival valve needs special attention because sometimes you can cross under the struts of the valve.
Sure.
And this can cause some damage to the whole system and makes the whole procedure catastrophic. It's the same just like accurate neo when you lose the weight, the wire, and you have to recross it, and sometimes needs special attention. Thank you for the nice demonstration of your skills.
Thank you. Thank you.
One more question in the back, and we should conclude. Dr. Pipilis.
Please. Did you have difficulty in maintaining ACT during the procedure? You had to use a large dose of heparin? Or
Yes, we did. We had an ACT of more than 300 continuously.
Okay. So, our next presenter is Dr. Asnauridis from Procratian Hospital, a very skillful operator and great experience in TAVI and coronaries, an old friend. So, Kostas, you have the floor. What is your case?
Dr. Sparias and Dr. Patakos for the kind invitation. I will be presenting another Percival case where we faced a rather unforeseeable, not complication, but difficulty. We did this case a few months ago with Drs. Vaina and Dimitriadis, and the case will be presented in a few days in EuroPCR. So, this was an 84-year-old male with severe exertional dyspnea. 4 years ago, he had undergone an AVR with a Percival, 23 millimeters, severe degeneration of the valve with a mean gradient of 64 mercury per millimeter. So a decision was made for transfemoral valve-in-valve. Pre-procedural CT showed that there was good peripheral access. So seemed to be a routine case. At the beginning, right femoral access, we plan to implant a 26 millimeter evolute valve. We spent some time to cross the valve with a wire. After we crossed, we put Landerquist wire down into the ventricle. We had significant difficulty, though, to cross the Percival valve with the evolute valve. The problem was that the tip of the transcatheter valve was actually impinging on the upper border of the frame of the Percival valve. We did several attempts. We tried to pull the wire, slightly push the wire, rotating the delivery system of the evolute valve. However, after trying to cross the valve for about 20 minutes, if I remember well, we had been unable. The evolute valve was always stacking, as you see there, on the superior border, was impinging on the superior border of the Percival valve, and we couldn't push more. So, sorry, excuse me. So you can see the problem here, the valve we were trying to go through, impinging of the tip of the transcatheter valve, of the evolute valve, on the upper border of the Percival valve. So we changed operators, we did several things. We couldn't cross, we couldn't advance the evolute valve past the upper border of the peripheral valve. So we decided to use a snare. This technique has been described in the literature. So we remove the wire from the ventricle. We put a snare, a goose snare catheter from the left radial artery. We crossed the valve again with the wire was snared, the catheter was snared. After crossing the valve with a new straight wire, which was snared, we exchanged this wire through a pigtail catheter for a new Landerquist wire. We advanced the evolute 26 millimeter valve through the snared Landerquist wire. We had to be very careful so that we would snare the evolute valve just proximal to the capsule of the valve. So by applying gentle pressure when we're trying to cross the peripheral valve, we would kind of redirect the valve at the center of the peripheral valve. It seems this worked. So you see here, the evolute valve is down, gentle pressure is applied through the snaring device. And at the end, we had been able to redirect the evolute valve and put it through. So we removed the snare. After that, the evolute crossed easily. And we implanted the valve with the routine techniques. With a good result, no significant gradient. The patient has been doing well after 4 months of follow-up, if I remember well. Thank you very much for your attention.
Very well done, Kostas. Any questions from the panel or the floor, maybe? Okay, Kostas.
Costa, thank you. Great case and great save. This technique has been used a lot with old core valve and now evolute. It seems that the capsule of this valve is quite stiff, so if it stacks, it stays there. So I wonder, for all these cases with Perceval's we've seen earlier, Petros, your case, other cases yesterday, why to put a supraannular self-expandable long valve with so much metal in another valve that also has a lot of metal? Because essentially you exclude any access to these corners now. You have two networks of metals there, and also you exclude another TAVI in TAVI in case you use it. So why not using a balloon expandable valve in these cases?
You're absolutely right. TAVI in TAVI, I don't think this would be an option in this particular patient. The patient has been 84 to 85 years old. You're absolutely right. I think a balloon expandable valve would be a great option here. However, at that time point, due to logistics in our hospital, we have to go through and use this valve.
Okay, thank you. So, our next speaker is Dr. Kolokathis from Attikon Hospital, a good friend and an old brother in arms. He's been around for almost 15 years with the TAVI business in Attikon Hospital. Fotis, you have the floor. Show us your stuff.
Thank you, Achilleas, for your excellent words. I would like to thank the Organotic Committee and especially Kostas Parias and Patakos for the invitation. Let's move to the case. No disclosures. The case is a 85 years old male. It has a history of AVR 7 years ago with a trifecta 21. And it was presented to our center because of exertion dyspnea that was exacerbated the last 2 or 3 months. There isn't any other comorbidities except hypertension. The cardiac echo revealed severe AR with a good injection fraction. And as we know, trifecta is a valve that has withdrawn now because of the early degenerations. And As you can see, this study, almost at the fifth year, the generated has started, and except the early degeneration, this valve is associated with increased mortality. That's why we should act soon, and the coronary angiography revealed no significant stenosis in the left artery. The right artery, there was a difficulty to engage the ostium, and you will see in the following slides why. Nevertheless, there wasn't significant stenosis in the right coronary artery. The risk is high. According to the guidelines, the TAVI was the choice, but we have now enough data in the literature that the TAVI is also a good choice for the rest of patients except the high-risk patients, with good results, especially good late results. There is a meta-analysis of 16 studies that show us that in valve it's almost a comparable choice regarding the redo SARV. Let's return to the case. Trifecta has our valve trifecta 21 has 19 only internal diameter. It also confirmed in our orthography and analysis with the trimensio. You can see the diameter. Fortunately, the cusps isn't also small, but the problem was the height of the right and the left coronary artery. It was below 10. The problem was especially in the right coronary artery because there was the distance between the right ostium and the valve was only 3.5. This was the explanation for not engagement of the right coronary artery. There wasn't enough space between the valve and the aortic wall. According to the studies, we need to protect the right coronary artery. Of course, there are, except basilica, there is also the Gimli technique. There isn't issues from the legs, so let's proceed. We advance a wire in the right coronary. Also, we choose a balloon expandable supraannular valve in order to avoid more reduction of the diameter of the trifecta valve. After deploy the valve, we pull the stent above the level of the trifecta, and we inflate the stent with excellent result. This is the echo 1 month later, good LV function, and the mean gradient was 15. There isn't any AR. And thank you. This is our team in our hospital.
Very good case, Fotis. One quick comment. I think it's very important to keep in mind that as things will progress, we're going to be dealing with more and more calcified and bulky leaflets, especially when we move into the TAVI scenario, which is not the case here, however. Having that said, I think that what we saw yesterday and our experience is that protecting the coronary ostia with Gimli technique is as efficient as doing any other leaflet modification procedure. So that saves time and money in some cases. Any questions from the panel or from the floor? Comments? Okay, so let's move on because we're having time issues. Our next case is going to be from Dr. Rapazis from the Interbancal Medical Center. Dr. Rapazis, good afternoon. You have the floor.
Thank you very much. I'm okay. I'm good to go.
Yes, you're good. Go.
So our patient is a 73-year-old male with diabetic and hypertensive. He has had a bypass operation 10 years ago with two.
Τις διαφάνειες, να κάνετε share τις διαφάνειες αν μπορείτε.
Okay.
Όχι ακόμα. Πάμε.
So he has had a bypass operation 10 years ago with two grafts, one lima to the LAD and a T graft to the PDA and the marginal branch. He has symptoms of dyspnea and exertion, and he was hospitalized in our clinic several months ago with pulmonary edema. During his investigation, we see that he had patent both grafts. And from the echo, we demonstrated a calcified tricuspid aortic valve with a valve area of 0.7 square centimeters. You can appreciate the low ejection fraction. So he had a low flow, low gradient aortic stenosis. This patient is a Greek patient who lives 9 months in Germany and 3 months in Greece. So we advised him to seek for treatment in Germany. The patient has declined from 3 centers percutaneous treatment because, as you can see with the CT scan, he had an extreme large annulus of 860 square millimeters, a perimeter of 105 millimeters, and a mean diameter of 33 millimeters. So we know that both valve prosthesis, balloon and expandable valve, have a cutoff point of 6.83 square millimeters for the balloon expandable and a perimeter of 94.2 millimeters for the self-expanded valves. And this patient immediately became an off-label patient for treatment. As you can see, this is a rare entity because in a large single center European center experience, you can see that only 6 patients, 0.27%, had a valve perimeter, a valve area above 840 millimeters. So we decided to proceed with the patient because he came back in Greece and he asked if we could treat his valve. We explained thoroughly the risks of treatment of this large annulus valve, and we decided to proceed with the XL My valve 32 millimeters with additional 6 mLs to achieve an expansion of 33.5 millimeters. The main access was the right femoral artery because we could use the 2 proglides. You can see the puncture site was done very nice, the aortogram. And we had a total uneventful course, a total uneventful procedure, a pre-dilatation. Very easily the valve crossed with a Novi wire. And you can see that this huge valve took us several seconds to inflate and also to deflate. I have to say that this is the largest valve that we have placed in our team. And you see still inflating and now becomes the deflation. The result was acceptable with minor PVL. The right groin was okay. And that was, this is the echo before discharge with low gradient and a good LV function. The patient was hospitalized for 4 days, but he came back in day 7 with dizziness. He had a complete AV block and we placed a permanent pacemaker. Thank you very much for your attention.
Very, very good case. I think this is exactly what we would like to see here and pushing the envelope exactly and doing TAVIs in borderline cases, and I think that is the reason why TAVI is here to stay and is going to progress, because it gives you the opportunity to even go further and further and do things on borderline cases. Maybe Dr. Spargas has a comment on that, because I see you want to say something.
Just a funny comment. Germans cannot do it, but Greeks can do it. Congratulations.
No, Kostas, can you hear me?
Yes, I know.
I think that the particular valve was not probably available at that time. I don't know, because I thoroughly asked the patient, and he said that we went to 3 centers and with balloon expandable, but probably they didn't have the MyValve system. I don't have any other explanation.
Akis, congratulations. It's Leonidas. That's the reason we can prefer a certain platform, and we have a workhorse platform in our lab, but then we should know and should be aware of alternatives to give the patients possibilities, because we have different subsets, and now as the indication broadens, we should have different solutions to provide.
Congratulations, Akis. I noticed, do you always pre-dilatate in bicuspid valve? And at this case, what size balloon did you use for pre-dilatation? I mean, did you downsize or?
No, the valve was tricuspid, not a bicuspid.
Sorry.
We pre-dilate with a 22 millimeter balloon. And as we wanted to advance a big valve, we wanted to be sure that we will cross the calcified original valve.
Just a comment to say that using the extra-large MyValve in aortic stenosis, it makes the procedure easier compared to using the extra-large MyValve in aortic regurgitation. So you had the benefit of having a little of calcium. It was not a very calcified valve, but at least it was stenosis and a little of calcium. So that was good, and we have similar experience with 2 or 3 cases of extra larges that wouldn't be candidates for other valves. So this is exactly what Leonidas said. It demonstrates that you should have an open mind and use multiple platforms, not exclude platforms if you don't use them, because every patient at the end of the day may be good or best for one platform and not the others.
Exactly. And having that said, don't fear. If you have calcification, then you have something to grab on. And even in those borderline cases, I think it does worth the effort, as you did very well, to take the chance and go ahead and do it. So our next case comes from the house, from Aegea Hospital. Dr. George Kakopoulos will present their case. Dr. Kakopoulos, you have the floor.
Thank you, Mr. Chairman. My thanks to the organizing committee for having me. So I'm going to present to you the case of a 70-year-old gentleman who has history of ischemic cardiomyopathy with a very low ejection fraction and severe aortic stenosis. This man was highly symptomatic with shortness of breath with minimal exertion. He also had lots of palpitations, dizziness, and lots of runs of VT. The echocardiogram showed a very low EF of around 25% with AV max of 3 meters per second, which increased to almost 5 meters with dobutamine without any change in the aortic valve area. So the history is significant for coronary artery disease. He had CABG many years ago. His coronary anatomy is rather stable over the years with patent lima to LAD and a patent graft to the circumflex. His RCA is occluded, but he receives collaterals, and as I said, there is no change over the years. He had a Euroscore 2 of around 15%, so the decision was made to proceed with TAVI. He's relatively obese, he has a big annulus, not so much calcification, so the decision was to proceed with a Medtronic Evolut 34 millimeter valve. We didn't have any problems advancing the valve. The problem is that this man would go into VT very easily, even with pacing at 100 beats per minute. So we went ahead without pre-dilatation. He developed during deployment of the valve VT and VF a couple of times, and we had to shock him. We're fortunate that he came out of it easily. So the valve was successfully deployed. We did have some paravalvular leak. We decided to go ahead with the dilatation with the balloon. We placed the balloon on the ventricular side because, as I said, we didn't want to pace very fast. And we're able to achieve a pretty good result in terms of the regurgitation. We still had some, but we were okay to accept that given the circumstances. So we're happy that we have a good result in this guy with a very poor EF and lots of ventricular tachycardia. But once we pulled everything out and we tightened the proglides, we saw some bleeding from the access site, and actually, when we took a picture after crossing from the contralateral side, we had a gush of blood coming out, as you can see here. So we know that would be a difficult bleeding to control. That's not just leakage, it's almost like the entry point is wide open. So as is the protocol in these cases, we advanced the balloon and we occluded the vessel, applying some manual pressure. And in the meantime, we're thinking how to proceed. There are a couple of things that you have in mind in this case. You're considering extended manual compression. You're thinking about a stent grafting with a usually covered stent or an open surgical repair. So after applying the pressure for around 25 minutes, we took a picture, and it looks pretty good at this point. So the option of the surgical repair goes away at this point. And we had a question in our minds, should we stent or not stent? And this may sound like a trivial dilemma, but it's not that trivial. If you're going to stent, usually you're going to use a covered stent, and below the inguinal ligament, usually we use self-expandable stents, although balloon expandable stents have been used. Why stent? Because that's a fast solution to your problem. The patency of these stents is pretty good, and they have a high rate of success, almost 100% in terms of controlling the bleeding. But you have a couple of reasons to avoid the stent. There is a restenosis rate, which is about 3 to 5% in the first year. Some of these stents may fracture. As I said, this is a hinging joint in the hip. And especially in younger patients, you want to keep the femoral artery easily accessible for future procedures, especially if other access sites are calcific or stenotic. So we discussed a little bit with vascular surgery, and we decided to give it another go at inflating again the balloon for another 30 minutes, since we had a good result so far, and applied a little bit of pressure. And we took another picture, which looked pretty clean. So we are convinced that we are okay. And we stopped there with careful monitoring of the patient. The patient did okay. He was discharged home the 4th day. The ultrasound of the area was normal. And a few months down the line, he's doing okay. The leg is good. He does not have any more runs of VT on ICD interrogation, which is a good sign, which seems that this aortic stenosis apparently was putting some extra burden on his LV in terms of arrhythmia. So in summary, large leaks like that usually are treated with stents, but in younger patients that might have a reasonable life expectancy, and you might need access to the femoral vein to be easy, and you don't want to have the problems of stent restenosis or issues like that, you might want to give an effort to manual compression, and oftentimes it works. Thank you.
Thank you very much, Dr. Giagopoulos, reminding us that TAVI procedures are 2 procedures in one. One is putting the valve, and the other one is taking the system out. So, any questions from the panel or the floor? I think we should get moving. And last but not least, from Athens Naval Hospital, a good friend, Dr. Mastrokostopoulos, will present their case. Always interesting stuff from the Navy.
Dear Chairman, dear colleagues, thank you very much. I would like to thank the organizing committee for their kind invitation. So we will talk about a TAVR patient, bicuspid and large annulus. So we will begin with the patient. It's a 77-year-old male with hypertension, dyslipidemia, AEF, carotid stenosis. He was autonomous in his everyday activities. So he had an LV fraction of 50%. In the last 3 months, he had developed NIHA 3, an AVA of 0.9, and this is the risk source of our patient. So when we performed the CT, we saw that it was actually a bicuspid valve, and it was actually a very large annulus. So you can see the area is 773. So we had the problem of choosing the valve for this patient. So if we go and see how the valves and their specifications, we can see that the Evolut platform was not correct for our patient. Either the accurate platform and Edwards platform was not, could not fit our patient and the Abbott device. So we had to use the MyValve system for our patient. So this is the setup that we use for our procedure. So we use opioid-free anesthesia for sedation. We use a temporary pacemaker from the left femoral vein. We have the pigtail, and we use the left radial artery for this. The closure device system we used for this patient was the Manta device, the 14-French Python sheath. Valvuloplasty would perform with a 26-millimeter balloon, and we would use the MyValve system, the 32. So what we should know when we are discussing about bicuspid patients is this is the common classification that we use. So for the type 2, I don't think that there is any available data for this patient. It's very rare. So we usually go for the type 0 or for the type 1. There is also another classification that is specially used for the TAVI procedures. But we should always keep in mind doing bicuspid is that this is the anatomy that we have. We have here, sorry. Okay, as you can see here, I will use, can you see? Yes, okay, so if this is our annulus, this is something that we must always take into account, that if we have a RAF, it's actually above our annulus plane. So what we should know is how to exactly measure in the CT, and how do we choose a valve? Because if you're going to open a valve, and if it's a high frame, this here will probably restrain the full expansion of our system. So using the CT, we can see how this can affect the expansion of our valve. So there are 3 methods available that you can use. The one is the Bathard method from Cheche, which actually use 4 millimeters above the aortic annulus in the intercommissural distance. But there are some colleagues from Italy that are now using the Lyra, its implantation at the level of the RAF. So you can see here in the CT that someone would measure this. So this is our annulus plane. This is the 4 millimeters above, but the RAF is actually 10 millimeters above our annular plane. So when you're actually thinking of implanting a valve, you should know all this, because this will probably predict how your valve is going to expand. Because concerning bicuspid, there isn't a single bicuspid that is common. All bicuspids are different, and the anatomy is different in every valve and in every patient. So in the literature, there's always this algorithm, the Caspal algorithm, that actually uses the calcium score in the CT. I don't have any experience using these systems. Now we're actually in our hospital, we're using the first one and the second one. But if someone has experience using this system, I will be very glad to know. So going on with our case, this is the orthography in the initial one. As you can see, there's some calcification, and there's a very bulk of calcium towards the left coronary sinus. So we performed the valvuloplasty, And what I would like to show you this and keep in mind is because we have the rough and the rough is above the annular plane, you might see what we have as a dog bone effect. It's probably some millimeters above your annular plane because this is where the rough is, and this is what you should anticipate when you're doing valvuloplasty in a bicuspid valve. So after this, we did an arterography just to be sure about what was going on. We did not have any hemodynamic instability. And then we started to implant the valve. So as you can see here, when you're going with a bicuspid valve, we have a tendency to not put it as deep, so we went about 1 millimeters above our initial what we normally do in a tricuspid valve. And you can see here that the valve, because it's a very large annulus, it's a 32 millimeter valve, we had really to start, when we started to inflate, it was very difficult because as you can see, it's a little bit slight more high, the pressure of the valve. And we were really inflating. At the end, we saw that this liter here, this thing we wanted to be, because this would affect the expansion of our valve and probably our long-term outcomes. So we inflated the valve, we were pushing. At the end, this is the result with the guide wire in the left ventricle. There is minimal paravalvular leak, and this is our final arterography. It's a very good result. The valve is a little bit more higher than usual, but this is what we were thinking, and this was our plan from the beginning. So take-home message, you have to have a clear setup of the procedure, especially when you have two possible pitfalls, bicuspid and large annulus. In young patients, coronary protection is important, and you can almost keep in mind that you may need to recannulate the coronary, so choose wisely what valve you're implanting, and proper valve selection is of paramount importance. Thank you very much.
Very well done. Any questions from the panel? Any questions from the floor? Yes, sir. Dr. Chalapas?
Great, Antonios. Great presentation. Just as far as the sizing is concerned, you have the three methodologies that you have already described. However, there is two more. The one is the circular sizing methodology, especially when you use the balloon expandable valves. And the last is the balloon sizing when you are in the gray zone, just as an additional comment.
Just follow up on Andoni's comment. What was the size of the balloon you used for the valve?
It was a 26 millimeter balloon.
Okay. So the balloon sizing with the 26 millimeter balloon, so no peri-balloon leakage, which means that even 29 valve would be
fit,
fine.
yes.
And I think that was the reason you couldn't really expand the 32. You had the waste. So this is, as a general rule, if you have bicuspid valve, and the more calcium the bicuspid valve has, so you can downsize the valve you're going to use. And this is true for both self-expandable and balloon expandable. So if you have bicuspid and you are borderline between two sizes, go with a smaller size. And this holds true, especially if you have a lot of calcifications, like you had. So the more calcification you have in a bicuspid valve, the more you can downsize. And then the other thing is that where the calcification is, if you have a calcified rough, these were the highest risk bicuspids, and you had a calcified rough. So these are the highest risk because this is like a pillar of calcium that holds you away from the annulus. If you don't have a calcified rough and you have calcium elsewhere, then this is an easy bicuspid. So I think in general, these are the bicuspids that we should still discuss with the surgeons, especially in younger patients, and given the results of the Notion 2 trial that we've seen so far. Excellent case. Thank you.
There's one last comment from Professor Kilic in the back.
congratulations for the excellent case. Another point for Professor Spargias, that we can also measure the supraannular measurements in bicuspid aortic valve, like from the Bavard registry. And there are also two other methods that where the bicuspid raphe is this. And the shape of the valve, according to these measurements, can be tubular, flared, or tapered. If it is, for example, tubular, you can use the same size of the valve. For example, if it is equals to 32 tubular, you can use the 32 millimeter. But if the supraannular measurement is lower than the original annulus, we should go to smaller size. The problem with the other balloon expandable platform is the absence of the intermediate sizes. In my whole and the Nivok core series, there are intermediate sizes. So, for example, if you use smaller valve in a very calcific area, for example, you should put extra amount of contrast, and this means risk of annular rupture. Or if you use larger size in a very non-calcified area, for example, this means the risk of the development of paravalvular leak. So the intermediate size really make great game-changing in this balloon extendable area. Thank you.
Okay, thank you. One last comment for the comment of the comment.
If you use the balloon sizing with simultaneous orthography for bicuspid valves, you shouldn't be stingy and misery with the amount of volume you give. Because if your pigtail is on one side of the aorta and you give just a little, like the usual 20 or 15 mLs, then you may not appreciate the regurgitation you have at the commissures. So the commissures are tiny, your contrast is in one direction, so you don't appreciate it, and you may be misled, and you go then with a smaller valve like a 26 here, and then you'll get a lot of regurgitation, PVL, and you won't be able to fix it. So if you use the balloon simultaneous orthography, use a lot of contrast, at least 20, 20, 20.
Okay, so we all agree that the only outlier in the TAVI cases probably are the bicuspids. We have to carefully review the CTs and be ready to change our plans in flight. I would like to thank everybody for staying with us so late in the afternoon. I would like to apologize to the organizing committee for taking half an hour from our lunch break. Hope you will forgive us on that. And thank all the colleagues. I think we leave the room a little bit wiser than before. Thank you.
Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients. Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
Dear colleagues, please take your chairs as we have to start now. Great. So the title of this session is Rapid Fire Session, a glimpse into the future, which means that each of these presentations will be rather brief, up to 8 minutes. And then we have to give the opportunity to 4 marvelous moderators to comment about the topics presented. I would like to get 30 seconds of this session to address to Spargias, to Kostas Spargias, and Dr. Spargias, I am impressed and indeed thrilled by the quality of these presentations and these sessions. Congratulations, not only for the work you're doing every day, the innovation you had introduced to Hellenic cardiovascular community and to Aegea hospitals particularly, but also for the quality of this marvelous event. I think the event is reimbursing because a lot of persons are attending these sessions. Saying that, I would like to ask Dr. Karanassos to present. Dr. Karanassos, you have 8 minutes to present. Future outlook for transcatheter AV therapies.
Thank you, Mr. Chairman, and I would also like to thank Dr. Spargias and the organizing committee for this invitation. May I have the slides, please? Okay, now I do have them. So let's see what this crystal ball of predictions have for aortic valve in the next years to come. And actually, we now have a treatment which has been well established. Of course, at the moment, we are treating patients that are of older age, but perhaps this is about to change in the coming years. And we have several valves that are being used, each with its own advantages and disadvantages. And of course, we have 2 large studies in low-risk patients showing that TAVI is an established treatment for aortic valve stenosis and is at least as good as surgery. So what are we expecting for in the coming years? Well, the first thing is to try to have a procedural optimization to try and minimize all the complications of the procedure. So we do have improved delivery systems. All companies are constantly improving their systems in an attempt to improve depth control, flexion, and commissural alignment. We're also going towards lower size of sheaths. At the moment, we already have sheaths of 12 French, showing the cement valve, which is a 2-piece valve. The current sheath is 12 French, and they are planning to downgrade it to 9 French. And the Mirusigel that uses rhenium instead of nickel will have a delivery sheath of 8 French. This is still to come. What about conduction disturbances? Well, we're already in the process of minimizing it by using dedicated implantation techniques and have valves that focus on optimizing the radial force so that conduction disturbances are minimized. And of course, for PVL, all valves at the moment come with skirts or wraps that allow to minimize the leaks. Of course, we still have to look for how long a valve is going to last, and of course, what's going to be needed in the life course of a patient. So a couple of years ago, we had studied with Dr. Sathogiannis from here what are the long-term outcomes, and we had shown that actually the rates of structural valve deterioration are not that high, and they are also dependent on the valve size. But of course, all bioprosthetic valves are doomed to fail at one point or another. But at least with TAVIs, what we know from the long-term follow-up of the NOTION trial is that perhaps we're less prone to this degeneration than the surgical valves. And also that especially when we have a large annulus or use a self-expanding valve, then the deterioration rate is quite lower. But we are also working on increasing it, on having better tissues and testing its valve in order to extend its durability. And of course, the first step is optimal implantation in order to avoid things such as the ones that you see here, these deformations, this thrombus formation, and of course, all the things that are different from the bench experiments. And companies are working on better tissue, on tissue that has been stabilized in order to prevent degeneration, but also new valves are coming that are trying to mimic the biological process and try to mimic the native aortic valve in order to have increased durability. And of course, there is the subject of coronary artery disease when we are discussing the lifetime management of such a patient, and also the question of what should go first, should it be the coronary, should it be the valve. This also should be done in the context of selecting which lesions we have to treat, and this is what we are testing in the escalation PCI TAVI trial. But what we have all seen is that, especially in the US, almost half of the patients that are lower than 65 years old are getting a TAVI. So what this means, that we're getting a lot of valve-in-valve procedures in the future, and most of these are derived from the TAVI-in-TAVI. And all this comes with all this consideration, both for the index implantation, but also for the follow-up about how we're going
Recording stopped.
How we're going to treat such a patient, especially in the course of the lifetime. This means that perhaps there is some new room for leaflet modification, both in the context of a valve-in-valve, but also in the context of coronary protection, or even bicuspid valves. This can be done by the Basilica technique or with dedicated catheters. And then, the aortic valve might also have some new indication for transcatheter interventions. And this review summarizes all the potential targets that are coming in the future, but I think the most intriguing is treating the asymptomatic AR and moderate aortic valve stenosis. And there are several studies that are trying to see it, whether when you have moderate aortic stenosis with some cardiac damage, or you have asymptomatic severe aortic stenosis, you should intervene at the moment. The early TAVR study saw the benefit, mainly derived from the decrease of hospitalization, whereas the EVOLVE trial, which was actually not the planned size, did not show a clear benefit. Then again, TAVR unload study was also prematurely stopped due to slow enrollment. Didn't make a difference, but we're also expecting the progress and the EXPAND TAVR study to see if there is a benefit in treating moderate aortic stenosis with cardiac damage. But of course, in moderate aortic stenosis, there may be a role for some emerging therapies, such as ultrasound therapy that may reduce calcification in the valve, or valvulopathy with a type of cutting balloon that do lacerations in the leaflets of the valve. And of course, there is artificial intelligence, which is being used more and more this time, that may predict the disease progression either by ECG or by imaging. And then, of course, we have randomized studies that are trying to show whether TAVI has an established role in bicuspid aortic valve stenosis. And then again, we have dedicated devices for aortic regurgitation, either as an add-on clip or dedicated valves. JenaValve Trilogy has been tested with promising results in the LINE AR study, whereas J-Valve is also coming. So I think these are the three main things that we're looking for in the future. how we can make our procedure better with less complications, how can we treat a patient and make sure that we have a solution for the entire length of his life, and of course, see whether we can move transcatheter interventions to other levels. Thank you.
Thank you very much, Dr. Karanassos, for your nice and precise presentation. Please take your chair. We have to move on, and then by then I will have the opportunity to discuss. So the next speaker is Dr. Grabsa. Dr. Grabsa, as far as I know, is attending. She is attending the session, but her presentation will be by video. So please, may I have the video then?
Thank you so much for this honor to be with you in this amazing meeting, Transcatheter Heart Valves Greece 2025. My name is Julia Grabsa, and I have this presentation from Brigham and Women's Hospital. And I will speak about the future developments in transcatheter mitral valve replacement technologies. I'm working under the structural team, and also I'm a member of the PCR mitral focus group. So as you will see, we will discuss the current status, the future developments, the challenges to overcome, and how does it look, the long-term outlook. Now, with regards to the current status, we understand that we have a large population of mitral patients. We know that the patients with mitral regurgitation are 4 times larger than these with aortic stenosis, and still they're undertreated with interventional options. 150,000 will be treated with MitraClip, while actually many will remain untreated as the screening failure for transcatheter mitral valve replacement rates very high. As you can see from the CHOICE MI registry, almost half of the population were actually failed screening, and this is a real-time registry on the transcatheter mitral valve replacement. However, we need to think that MitraClip has also certain limitations. Mitral valve is complex, so it's not suitable for all anatomies as we know it so far. Concerns about long-term efficacy and residual mitral regurgitation, which of course is associated with higher mortality. So a procedure may be successful, however, it may actually not provide long-term improvement in quality of life and outcomes. Still, transcatheter mitral valve replacement is largely in investigational phase, as I will show you soon, and most procedures are done off-label and in clinical trials, and we're waiting to be applicable in low and intermediate risk patients. Rather, at the moment, they're only applicable for high-risk surgical patients. The transcatheter mitral valve replacement classification, we have many different valves in pipeline, and you can see practically the challenges of for mitral regurgitation and the different anchoring mechanisms as it was published early in main JACC, and also the different types of valves. We have 2-stage devices such as HiLife or SAPIEN M3. HiLife has open LVOT struts and it's self-expandable, while actually the SAPIEN M3 is balloon expandable and it's completely transeptal. And also the Tioga uses a 28 French sheath and it's completely transeptal, and it's a short valve design, while actually there are also the anchoring devices such as CFEA, which is a low-profile valve with axial compression and leaflet barbs, and it's self-expandable, and the Intrepid valve, which is completely transeptal and it's a self-expanding valve. Also, the Alta valve, as we know it, that's the important part of the Alta valve is that it's an atrial cage, it's self-expandable, while actually it has minimal ventricular presence. And last but not least, the InnoValve, the transcatheter mitral valve replacement system, which has this chordal twisting that helps potentially the LV remodeling, and it has small ventricular presence, while actually protects the anterior mitral leaflet from the LVOT, so it does not, of course, relates to LVOT obstruction. Now, it's important for the future developments, the improved this device design, so the devices will become smaller, easier to implant via transeptal approach, when compared, of course, to the first approaches which were transapical. That increases the risk of procedure, and they're more adaptable. While actually the anchoring mechanism will make the valve more adaptable even in the case of lack of calcification in the mitral annulus. Then for us, me, I'm an imager, so we have worked and we will soon have also a state-of-the-art review about artificial intelligence in valvular heart disease to be published. But we know that the fusion imaging and also artificial intelligence will help us in the appropriate selection of patients and predicting procedural success. Other important considerations for future developments are the expanded indications. As I said at the beginning, we need to actually to use these valves in intermediate and low-risk patients. Up to now, we have used them in high-risk surgical patients, and we need to see long-term outcomes. We need to see the durability of these valves. And also, it's important to compare directly with transcatheter mitral repair options. For example, it's nice to have head-to-head trials or even better, a randomized control trial. It's important also to have simultaneous CE marks and FDA approvals and also cost-effectiveness data that will guide us to the best treatment of these patients. Just a reminder that next weekend we'll have EuroPCR, and there is the launch of PCR Mitral Focus Group. And why this was important? Because we see more mitral valve patients that they cannot have open heart surgery, more patients that they will need advanced transcatheter therapies. Just before the end, and I would like to thank you for your attention, on the 10th of June, we have an ESC webinar on mitral and tricuspid regurgitation. This actually is like brother and sister. They go together quite frequently, and it's nice to explain exactly how to assess and what is the appropriate treatment for the right patient. With that, I would like to thank you so much for your attention and have a great rest of the day.
I'm afraid, okay, great now. So, Dr. Grabsa, thank you very much. And by the opportunity, I would like to congratulate you for this marvelous career abroad, so many years. We have the opportunity now, if somebody likes to have a question or a comment to Dr. Grabsa, because she's in live now, is live now with us, in the contact with us. It's not in the video now. So is anybody who likes to address any question to Dr. Grabsa now? Anyway, thank you very much, Julia. It was a marvelous and precise future outlook for transcatheter mitral valve therapies. So we have to move on now. Julia, Dr. Grabsa, if you could stay with us later, in 10, 15 minutes later, because 4 commentators are going to discuss here, correct? Okay.
Yes,
great.
definitely, I will stay with you. Thank you so much. Thank you. It's a great pleasure to see you all.
Excellent, great. So the next talk, the title is Future Outlook for Transcatheter Tricuspid Valve Therapies, will be presented by Dr. Exarchos.
First of all, before starting my presentation, I'd really like to thank you for the invitation. It's a pleasure for me to be here, part of this Congress. It's also a pleasure for me to be here to see so many good professionals, so many good colleagues, but also some very good friends. Future outlook for transcatheter tricuspid valve therapies, and I am going to start with drawings. Drawings coming out from old cardiosurgical manuals, drawings revealing how minimal invasive transcatheter tricuspid valve therapies actually recreate the main principles of cardiosurgical tricuspid valve repair and replacement. And we have, of course, the coaptation devices based on the Alfieri stitch. We have the Cardioband based on the Carpentier annuloplasty. We have the K-clip based on the K procedure, the bicuspidization procedure. And we have a plethora of devices for orthotopic and heterotopic transcatheter tricuspid valve replacement. We have about 30-35 devices that are waiting at the pipeline, waiting for clinical evidence. My intention today is actually to focus on alternative strategies based on the everyday clinical life in Berlin, and to try to think and rethink how the future landscape may look like. We have here our first patient. We have the typical dilatation of the right atrium, tricuspid annulus, and right ventricle dilatation. We have a patient with HFpEF, with atrial fibrillation. We have a patient with severe to massive tricuspid regurgitation with overlapping features. We did a transthoracal, a transesophageal echocardiography, and at the end we decided for a cardioband. First, we have to understand what is a cardioband. It's a flexible band that is covered by a polyesteric sleeve. And the main idea here is that I want to target first the anterior segment of the tricuspid annulus. I want to move to the posterior segment of the tricuspid annulus. I have to attach using anchors, deploy the band, moving along the hinge point of the tricuspid annulus, contract the band, and at the end, I am reducing annular dimensions and I can reduce tricuspid regurgitation. Stepwise approach. For a good navigation, I need inflow-outflow view, biplane view. I need also 3D and fast view. I need fluoroscopy, and I have everything. For the deployment of the band here, we have to be careful. So we have two main phases. First of all, the deployment of the first 6 to 8 anchors. And here I want you now to focus on, at the left side of the slide, what we see actually here is the tip of the band that moves from right to left, from anterior to posterior. You can also focus now on the right side, and you see the tip after 2, after 4, 6, 8 anchors. For the second phase, now we are at the posterior segment of the tricuspid annulus. It's a little bit more tricky. What we need here is MPR. What we need here is, What we need here is fluoroscopic view, because we have to test again and again for RCA proximity and RCA compression. We're moving forward. We have now the adjustment, the most important part, of course, of the whole procedure. I want you to focus again at the left side of the slide. What we see here is that we are contracting the band, we are increasing the sensing, and we are reducing annular dimensions, and at the end, we are treating the tricuspid regurgitation, at least to a great improvement. Here we have another patient. Here is the typical patient with a big gap, with a flail tricuspid regurgitation. Here again, tricuspid regurgitation with overlapping features, and we decided again for a cardioband. Before every cardioband procedure, we need a good CT examination for 3 main reasons. First of all, annular dimensions, RCA proximity, and IVC position. Extremely important for the whole procedure. Here what we see, we are again at the last part of the procedure, adjustment. Again, at the right side, you see improvement of tricuspid regurgitation because I'm increasing the sensing. But I put this slide here actually for the right side because we see how the reduction of the annular dimensions actually has a positive impact on the whole coaptation of the tricuspid leaflets. What are we waiting general from annular devices? Of course, the next generation cardioband comes in the future, but we have also other devices like the MIA system. Less invasive procedure. Here we have a thermoplastic elastomer. Here we have low mass polycore anchors. And here we have a bicuspidization technique. So we are plicating only the posterior segment of the tricuspid annulus. Here we have another device, the K-clip, again based on the bicuspidization procedure. Here we're plicating the anterior segment of the annulus. We can use 1 clip or a 2nd clip. And here we have another device, a Corofix. Because of confidential reasons, I can only show you this picture here. Actually, we're talking about the system. We don't talk about the device. So here we don't use a device. We know that the company has already started with the first attempts for the mitral valve. We are waiting to see the attempts for the tricuspid valve. We know that they are developing the system. And I really put it here because we have to understand we go less invasive, faster, and we are trying to manipulate the tricuspid leaflets as less as possible and the annulus generally. Here we have a single leaflet device attachment after the implantation of a 2nd clip. Here, so it's just mathematics. I mean, if we are doing more and more procedures, even if we're trying to optimize everything, we will have more complications, or we will have complications. So we have to think, and in the future will play a very important role, think and rethink about bailout options, about complication management. And here I have a very nice example. It's already published. We had a patient. We tried with massive tricuspid regurgitation with a big cap. We tried first with 2 triclips. After the second triclip, we had a single leaflet device attachment. And at the end, we decided, because of right heart decompensation signs, we decided for a tric valve. We have 2 valves. They are not identical. There are some differences, one for the IVC, one for the SVC. The most important thing is actually to understand for the IVC, I need actually a shorter skirt because I don't want to block the hepatic veins. And for the SVC, I need a long skirt because I don't want to have a paravalvular leakage. After the implantation of the tric valve, we had a significant improvement of clinical condition. And now we have our last system. We are talking about the pivot system. We have a spacer that I have to implant actually in the vertical aches of the tricuspid annulus. The main idea here is that I'm trying to improve the coaptation to block the tricuspid regurgitation. And the most important thing here is that I'm talking about a short-term implantation like the pivot TR system, and we have the pivot bridge trial, which already started, for about 7 days. So it's like we have to think about a bridge to next therapy, a bridge to optimization. And we have the pivot extend system, the pivot Mandu system, and we have a very good trial, the pivot extend. We are going to use these devices more and more in our valve center. And I'd like to end now my presentation. I could end my presentation and just say that, just in a few words, annuloplasty matters. Combination of therapy, combination of devices matters for complication management or even for rehabilitation procedures. But I really think that I would end here this presentation using these open questions, not direct answers. What's the best device or strategy for a given patient anatomy? Will transcatheter annuloplasty be alternative or adjunctive? Can hybrid or combination strategies improve outcomes? Which are the optimal bailout and complication management strategies? Thank you very much for your attention.
Great. So thank you very much, Dr. Exarchos, for this very important presentation. You have summarized indeed nicely some of the main points of these techniques. And now I have to move on to the last, but not least, presenter, Dr. Rousakis, the future outlook for surgical therapies.
Good afternoon. Good afternoon, everybody. I would like to thank the organizing committee, myself, for the kind invitation and to express my gratitude. So it will be, I will be talking about the future aspects, about the surgical treatment of valvular disease. So the anatomy and the pathology of all valves is known to everybody. Mainly we treat aortic stenosis or mitral regurgitation. Then the next to come would be the aortic regurgitation, the mitral stenosis, and the last will be the tricuspid valve pathology. In comparison to the transcatheter methods, surgical treatment is known for more than 100 years. It has evolved a lot and it has tested a lot, and the experience has summed up. So we have mechanical valves used for more than 60 years, and tricuspid, again, the tissue valves used for more than 50 years. Also, apart from the changing the valve, we have the ability to repair it, and this has also started far ago, over 100 years ago, and we have managed to reach at the point where the results of repairing the valve, mainly mitral and tricuspid, are excellent. So what is the future? So there are three main pillars as far as the surgical approach is concerned. Is the surgical approach, are the new technologies that are coming on the manufacturing and the industrial level, and some surgical techniques that I'm going to show you. So the surgical approach, the three first are well established, mainly the two ones, the right anterior thoracotomy and the endoscopic approach now is all around the world well established, but not to all hospitals, but not only with some teams. Transcervical and robotic approaches are still developing. So this is the main approaches, and this is the present approach with the mini sternotomy, the thoracoscopic approach, and the endoscopic view, where we can see an excellent view of the mitral valve, which is a great advantage to the surgical approach. And you can see that we can achieve complex repairs with a ring, with a neocords, and even reducing the excess tissue of the leaflet. The future approaches may be either with the assistance of robotic machinery or with other devices. They are still developing. There are very, very few centers using this technique, but still the future we may have to do with this. But how do we evolve as surgeons? First of all, we have to go step by step. We cannot skip some of the procedure, or some steps of the procedure, and I would suggest that at this point, at the present time, all the surgeons who should be involved in the endoscopic surgery, and then try to make the next step. What are the technologies that we have and we are coming? Already there are some valves that they're advertised that they may last for more than 25 years. The Inspiris valve has already the in vitro test of 1 billion circles that has with a success. That means that if we can project that would be 25 years without problem. That's of course very long time, and we will need still to be find out if it would be true. And there are some other valves as well already being used that they can be combined with the minimal invasive techniques, the intuitive valve and the Perceval valve. We have already experienced more than 10 years with the Perceval valve with good results, especially in small roots and annulus. But the bioengineering is evolving. We can, at some point in the future, they believe that we would be able to print valves built by collagen, and it will be custom made for each patient, and with the ability to shoot exactly at the patient that each different patient. You can see here that there is already been tested, and the pressure that can hold is above the pulmonary and tricuspid valves, but of course there's still some way ahead. Another possible aspect in the future will be the use of polymeric heart valves. In the United States, I have already used this valve in the tria valve in human, not only the aortic side, also in the mitral valve side. And this kind of valve that is polymeric, it means that it's mainly done by material like silicone or Teflon, and it may have they will try to keep the advantages of the mechanical and tissue valves, so you won't have to use the anticoagulation, and but you have durability like the mechanical valves. So, talking about mechanical valves, we should say that we should always keep them in mind. We have already valves that need less level of anticoagulation, but we are already trials checking on the ability on some valves to have different shape and be able not to need anticoagulation at all. This is the TriFlow valve, and the trial has started already from 2023. Some surgical techniques, I will show you 4 or 5 techniques that I had the chance to work with. So the Ozaki technique is a technique when you replace the aortic valve and you use autologous pericardial treated with glutaraldehyde on the surgical site, and you are able to reconstruct the valve with great coaptation. It has a minimum stenotic phenomenon post-surgically, and in only some very few cases you can find some minimum regurgitation. On the aortic valve, we already using and they have already implanted more than 1,000 globally. Is the heart valve. It is a heart ring, which is a way to improve the aortic valve regurgitation even with a large root, and the preliminary results are very promising for the future. The neocord is a surgical transapical approach to put neocords on the mitral leaflet, especially on the posterior leaflet. Already 2,000 of them have been, in 2,000 cases, have been tested, and the final results are maybe of the RECORD trial may be published within 1 or 2 years. I would like just to pinpoint the ability to use both techniques with the transapical on the transaortic approach. I had the chance to work with Dr. Bapat at St. Thomas's, and we were using a transaortic approach for transcatheter valve implantation even 10, 15 years ago. This is a good alternative, just with, of course, we cracked the sternum, but we still have good results. The Tendyne valve is another valve we used. We have implanted at my center, at Donasi Center, and we have used the 2 first in Greece. It has a surgical approach. It's a transcatheter mitral valve. It has a great hemodynamics post-operatively. It's very strict in order to be for the including criteria at the moment, but 1,000 of them have already implanted around the world, so we're waiting for the future results, and maybe a good way to treat our mitral valve regurgitation in the future. One last comment. I know I'm over my time. One of the problems with the use of transcatheter techniques in younger and younger patients all over the world is that we will have to face in the future a problem. Maybe we will have to face some problems. The most growing rate, the operation with a growth rate of 6,000% is the TAVR explantation in the United States. It has to do with the meteoric rise of use of TAVR in younger patients. And the thing is that when we will have to deal with this problem, the explantation of the original valve is a very difficult operation, and in some cases you'll have to replace the whole aortic root. This is the same view of the same problem, and we have to be very careful what decisions we make for the management of the aortic valve disease in the young patients. This is to prove that what I'm saying is that already in California, in the state of California, almost 50% of the patients below the age of 60, they are treated with a transcatheter aortic valve, and the results are have some even if the results are 2.5 times higher the mortality than the surgical aortic valve. This is the same. We have over time. I know, sorry. So the future will come, and we'll have to be very careful with our choices. We shouldn't forget the methods we are using up to now, but we have to evolve, get better training, the new techniques, and be always ready to learn new things. Thank you very much.
Thank you very much, Dr. Roussak. It's a very difficult job to present all these developments and these realities in a such very short period. Just allow me only a very, very brief question, yes, before the commentators will start on. I was pondering, do you feel a bit old-fashioned after all these new transcatheter valve, new techniques and therapies?
Old-fashioned maybe, but it's the results of our techniques they have the transcatheter techniques. They haven't given better results. We will always have young patients to treat, and the surgeons should never lose their core surgical skills because even if all aortic valves are treated by transcatheter methods, at least 30% of the aortic valve will still be done by open heart surgery.
Great. Yes. Okay. This is the reality at the moment. Yes, but just my feeling is that already mechanical valves sound a little bit old-fashioned already.
Yes, but
mechanical valves.
Yeah, a few days ago at my clinic, I had to see a patient that was 88 years old, had put a mechanical valve 30 years ago, but still it's
at the moment.
Yes.
Since the durability will change, everything will change. Anyway, let's start from the ladies first. Dr. Mavrogianni, you are one of the commentators. Please make your comments.
Yeah, good evening, everybody. Excellent talks, everybody. I think the technology is already there. It's the first time in our practice that we're going against all valves, full frontal attack, and it's going to get better and better. Mitral clips are going to get better, mitral manipulations are going to get better, pulmonary artery is there, tricuspid is there, TAVI, there's no question about TAVI. We've been manipulating the aortic valve for 20 years now, but I don't think that's not quite the issue. I think the issue is that through all these manipulations with the valves, we have gained tremendous insight on the pathophysiology of the valves, and therefore we know now, not quite clearly, on which patients to intervene and when. And I think that is the big question and what we are aiming after.
Yes, of course.
Thank you very much, and it was an excellent presentation. I have basically a comment and question at the same time, and it's not only for this presentation. As the indications broaden and include younger patients that you mentioned, and for example bicuspid valves and transcatheter valves, one question is the durability, and the comparison would be fair to be with bioprosthetic. So what's the 5-year durability or 10-year durability? And the second common question is regarding the, for example, I've seen personally patients in their 40s and 50s who have done TAVI out of preference in the United States. And these patients, if they need reintervention, okay, valve in valve we know, but surgically, is it possible and is it feasible to do a surgery after TAVI?
It is feasible. It's a very difficult operation. At some point, you'll have to replace the aortic root. It will be a bendal operation. It's very difficult to extract the transcatheter valve implanted. It's already part of the aortic wall. It's very difficult to take it out itself and just replace it. On the other hand, when you do a redo surgical salver for an old valve, it's much less difficult. It's easier, and in most cases you don't have to deal with the root. So it is feasible, but it will be a difficult operation with a high-risk operation with a high mortality risk.
Great. So we have to move now to Dr. Pipilis. Comment?
Okay, since we have the surgeon here,
okay.
Let's start from the last end to answer the comment of Professor Vardas that the mechanical valves are definitely not obsolete, and I totally agree with you. There's place there, and pharmacology is improving its anticoagulation, and perhaps factors aiming at the 11A factor might be also a solution because they block the contact pathway of coagulation, have minimal bleeding risks. They're being tried in many trials now, first in atrial fibrillation. It's a field that will be expanding, and it may revive the new valves with minimal anticoagulation for young people. So that's something that won't be obsolete, I'm certain. In terms now of comments for the whole session, if I may, we heard how the technology goes fast, and all the advancements are impressive, and we can't predict really the future because it comes faster than we think. But in terms of clinical medicine, what we need to be better, it's to see how the indications are expanding towards younger people and more early phases of the disease. So that's one thing which we'd like to have more information when we're advising our patients. And also, if we are in a position now to have a very personalized approach, which procedure is for which patient, and that's where perhaps the favorite topic of Professor Vardas, AI, might be helping. Iulia Grapsa had a very beautiful comment on that we need to be very precise in prediction of the degeneration of the valve. So that's what we really need in the future, to be able to say, so that we can advise the patients on what to expect from their transcatheter procedure, what to expect. And if we're very precise on that, then that's a major advance for the future. These are some comments, and perhaps would like to know what the speakers think about the prediction of if we're in a state to predict the durability of the valves at the moment, or would we expect something apart from technological innovation that are moving towards technology, biotechnology?
Great. So, Doctor.
It is important that we have traveled that far and still have a lot of refinement to do by means of patient selection, delivery systems, imaging, fusion imaging, and of course, if we have proper imaging, AI can help us have more predictable procedures. I would like to ask you something. Do you think that with this synthetic non-metal valve, we could have a game changer and stop the expansion of TAVI to younger populations?
I think that according to the designers of this valve, they think might be a game changer. It will have great durability and not need for any anticoagulation. But of course, it has only just implanted in very, very few patients, 3 patients so far. So larger clinical trials with larger scales should be run on this. But I think the future goes. I think that will be the future.
But this material is a customized one, is it?
Sorry?
This material is using the polymeric one is a customized.
It's not yet. It's not in the market. It's still in the trial.
In the market.
But they have already been implanted in humans. They have taken this. They are allowed to do that, and they are trying to put it in a larger study now.
Okay, yes, it has a much easier molding, so it will be both cheaper probably,
yes,
and customizable. So it's
custom made for each patient.
But I would like to make a special address to Dr. Spaghias. Very simply talking, it is a matter of durability nowadays to use all these devices in middle-aged patients, or is the stability of the valve? is mostly the durability of the fabric used? This is my naive question. Because if the problem is the durability and the fabric, I'm very optimistic that the science of materials will solve the problem.
I think, as you've heard from all the speakers today, there is work done currently at multiple levels, not at just one level. And we had 4 excellent talks, state-of-the-art talks. I was really impressed by all of them. And they were all to the point. I think the problem now becomes, for cardiology, we're lucky because we don't have differential diagnosis problems in our specialty, so the diseases are counted in the fingers of one hand. But now we have very complex treatment algorithms and therapy algorithms. As you heard, even for surgeons now, it's not just a aortic valve replacement. Is it stenotomy, J-stenotomy, robotic? So it becomes very complex. The durability issue is just for the TAVI valves or the mitral valves when they come into market, or the tricuspid valve. So in the valve replacement, yes, the durability of the leaflets is an issue. Certainly it's as good, I would say, as the surgical leaflets in the biological valves today. I don't think there is any difference.
So, please.
Let me try to add some more information to Vada's question. It's not only a matter of durability, but you have also to solve some other problems, like the increased need for a permanent pacemaker, and how will this affect the survival, and also the PVLs. These are I think, the 3 major drawbacks for the use of TAVI technology in this age category.
Yeah,
okay?
Of course, we cannot speak for all the kind of the valves. I would like to focus on the TAVI issues, okay? It seems to me, which TAVI is really, if I have understood well, because I'm not a specialist, the easiest of these discussions like tricuspid and mitral. The stability, etc., of the mitral solutions is a bit more complex. But talking about TAVI, I'm very curious to understand, is only the stability of the valve and mostly the durability of the leaflets to make this valve living forever? I don't understand, because if the problem is the fabric, if the problem is the durability, I am extremely optimistic that the science of materials will solve the problem. Come on.
It's not only, Dr. Vardas, it's not only the comparison of material between surgical and TAVI valves. It's the local condition.
Okay.
Dr. Rousakis is cleaning the aortic valve. He's living, after the operation, he's living absolutely clear sinus of Valsalva, but this is not the issue unfortunately, for TAVI.
Yeah, nobody doubts that the open chest, or even restricted stenotomy, makes clear job. Nobody does. But on the other hand, everybody likes to avoid the scars. This is the problem.
Yes.
This is a general comment, a little bit more philosophical comment. Unfortunately, we have no time. We have to move to the next person. Nikos, yes, you deserve your question.
Something different from this future development. It's about medicine. This known medicine sequence preventing or slowing the progression of calcification. So possibly we can find the medicine taking this and then no calcification.
So we have to speak about inflammation pathways.
Yes, I think it's other. In USA, if you take it for 6 months, they found that the calcification is.
There was a publication on this recently, on a new drug.
Great, thank you very much.
Thank you.
All of you being with us today, and we have to move to the next one.
Everybody, from my part, apart from thanks to Dr. Sparias for inviting me, I would like really to congratulate him seriously because of this top activity and interventional cardiology and structural heart disease that he has offered to us for the last years, and his contribution to the education of Greek interventional cardiologists in this aspect, which really we have to acknowledge this contribution. Our session is about structural heart intervention core knowledge, and our first speaker will be Dr. Aphrodite Zifa, who is Director of Pediatric and Adult Congenital Heart Disease at Matera Hospital and Honorary Clinical Senior Lecturer at King's College London. Dr. Zifa.
Thank you very much for the invitation. Well done, Transcatheter Heart Valve team. This is a really very wonderful symposium every year. I'm not going to bore you with the pulmonary valve. I'm just going to say the main things that we need to hear in terms of comparing it with other valves that you guys do. We are the pediatric cardiologists who do the pulmonary valve because the patients are congenital heart disease patients, and therefore we do them in kids and we do them in adults. That, as you know, is a growing population. So mainly our patients are tetralogy of Fallot patients, or anywhere else there is a pulmonary valve conduit, like Ross operation patients that you're acquainted with, or transposition patients that have problems in the pulmonary valve. It's a heart team decision, like with all valves. Our patients are usually multi-operated. They have some concomitant lesions like scoliosis, lung hypoplasia, syndromes, all the things that they need a congenital cardiologist to look after all these problems. This one, although a short kid, 18-year-old, 26 kilos, look at this population, you see severe chest deformities, you see scoliosis, very bad thorax. This is sometimes the kind of patient that comes to us for transcatheter interventions, because you understand that the surgeon would say, how will I get into this chest without hitting the heart? And therefore, the guidelines tell us that wherever it is possible to offer a transcatheter intervention on the pulmonary valve, that's what we should do. And as a class 1C, in fact, it says where there is no native outflow tract. So wherever there is a biological valve, an RV2PA conduit, then we should go for it. They say if there is a native, there is nothing in the pulmonary position, this has not got into the guidelines. But I'll show you today how this has changed since the 2020 ESC guidelines. So the available valves that we used to have, and we still have for the pulmonary position when there is a conduit, is the Melody valve that was implanted in 2000, 2 years before the TAVI, and then the Edwards valve that you're aware. It's the same, acquainted with, it's the same valve like yours for the TAVI. And then there's the Venus P valve, which is the valve that goes to high diameters, and we can implant it in native RVOT. The Melody valve goes up to 22 millimeters, and it's a bovine jugular vein, which is sewn onto a stent. The Edwards valve, I don't need to say. And the Venus P valve goes up to 36 millimeters diameter. So wherever there is no conduit and there is a native RVOT, a very pulsatile one that the surgeon doesn't want to go in, the patient doesn't want to have another surgery, we now use the Venus P valve, which has been implanted for about 12 years now, since 2013. But it got CE mark in Europe in 2022. With all these valves, we need to make sure that by implanting the valve, we do not compress on the coronary arteries. And we get an idea by the CTs and the MRIs, mainly CTs these days, because we very nicely see the calcification as well. And if sometimes where the coronaries have been reanastomosed, like in Ross operation, we don't expect them to find in the coronaries in the usual position, and we always need to check the CT or check a coronary angiogram and look at that, the vicinity of the left main with the homograft, which is terribly calcified, is very, very close. And therefore, this was not a case that we did in the cath lab. We referred this to the surgeon. Because if we don't, this is what can happen. The coronary can be compressed, and this is a case taken from the literature. The patient might die on the table. So the criteria for putting a valve or not is the size, the shape, the location, angulation, coronaries, and all of that. The size and shape of the RVOT is very variable in our patients. Look at these valves here, the RVOTs. Up to 3 years ago, we could only address about 15 to 20% of the patient's transcatheter, but now with the new valves, I think we will reach nearly 100%. If we have concomitant tricuspid valve pathology, it's not a problem to go through with our sheaths. We just need to be very careful, and occasionally we need to do TOE. This, in fact, patient, for example, had an Alfieri stitch by the surgeon, and you see that there are 2 orifices, and by TOE we chose the bigger one, and we went ahead and implanted a valve. And when there is concomitant branch PA stenosis, we need to address that too. So the operator, not only should he be expert in putting pulmonary valves, but dealing with any other concomitant problems in the pulmonary tree, because then the valve will not work. So if you leave peripheral pulmonary stenosis, the valve will fail. This patient of mine with severe scoliosis, one of my first patients here in Greece, you see the spinal rods, and you see I'm in the RPA, and before I implant the valve, I open up the RPA distally, a location in the hilum where the surgeon cannot reach, and if I leave severe stenosis, then my melody valve with the high downstream pressure will develop regurgitation. And then with the same balloon, it's a high-pressure Atlas balloon, I came back, ballooned the conduit because nothing could go through there. We prepare the RVOT by implanting a covered stent, and we do need the covered stents. This is pre-stenting because, as you see here, there is some contrast extravasation, but it is contained. Ruptures have happened. We need to be alert, careful. We need to have pre-planned, and we need to have the surgeons near us. And sometimes our congenital patients, they don't have azygous IVC to array. They have azygous continuation. Like this patient, I've gone up his femoral vein, and this is going down the left SVC to the coronary sinus. So what do we do in these cases? We don't go through the femorals, we go through the neck. And this is actually a better route for kids as well because the jugular vein is bigger than the femoral vein. And when we've implanted valves surgically that are small for size, what we can do is we can break them and put a larger valve. Pacing leads, we don't mind. We can go through the tricuspid valve with care again, but it's not a contraindication. And a few slides about the new valves. The venous P valve, this is an excellent valve. It's withstanding time. It has low risk of endocarditis to date. It goes up to high diameters, as I said, and you see here, this was my first patient that I implanted a venous P valve at Mitera. We prepare the patient by MRI or CT, preferably MRI, because you want to see the maximum pulsatility of the pulmonary artery, whereas CT is static. And we use the sizes up to 3630, and this is how we do it. Inflate a balloon. At the same time, my adult cardiology colleague injects the coronaries. I don't inject coronaries because I'm not an expert on coronaries, and adult cardiologists don't implant pulmonary valves because they're not experts in congenital heart disease. But the collaboration is really important. So me and an adult cardiologist does that together. I inflate the balloon. We do an injection in the right ventricle. My colleague does the coronary injection, and we do this stop flow technique measure and then decide on which size of the valve we should implant. And this is a nitinol valve, so it's a self-expanding nickel titanium valve, and this is the end result. And if you now think that this looks like a big valve, this is what I thought when I first did it, but when you see the echo of the patient the following day, it looks like a normal pulmonary artery. It is a beautiful result, well opposed to the wall of the pulmonary artery, no stenosis, no regurgitation. Is it safe? Of course, but in safe hands. And even in safe hands, you can have complications. But if you're an expert team, then you can deal with the complications. And this is what expert teams do. They deal with the complications successfully and they minimize the risk of the patient. What can happen? RVOT tachycardia, obviously, because it may impinge on the RVOT. So it's very important that you don't come right down to the RV. You need to be very careful to start distally. We may have endocarditis, but more rare, and we may have valve thrombosis, and that's why we give double antiplatelet treatment. As with every pulmonary valve, where our wire is really important, and we use the Landerquist wire, the wire can cause complications, like in this one, there was a small perforation, and our patient was in pain after the procedure. This went away after 2-3 days. So the new valves are coming up. The Harmony, the Altera, is not a valve. It's from Edwards, and it's actually a stent. Why do we need it? It's a stent that we actually need when there is, sorry about that. Can we have this again, please? It's a stent that we put with a landing zone in the middle so that, yes, this one, thank you. So that we create a landing zone for our valve, you see? So when the pulmonary artery, the main pulmonary artery is really huge, we implant this stent, there is a waist in the middle, and then within this middle part of the stent, we put an Edwards valve. This is the new Edwards technology, and this is one of the cases that I was involved recently, and we hope that we will start with the Altera stent plus Edwards valve in Greece. This is the Altera stent going up. It looks like a venous P valve. It's pretty straightforward, actually, if you're very careful, and then this is the valve implanted. So what is important, and the messages I always want to pass when I give a talk on pulmonary valve is that we shouldn't wait for the right heart to be massive. There is criteria. We need to do MRIs and make sure the volume, the end diastolic volume index of the right ventricle is not more than 150. Because if we leave it and it grows and it grows and it grows, and the patient ends up having ascites and lower limb edemas, it's too late. And this RV may not come back. So timely recognition is one very important thing. If you have patients that have tetralogy of Fallot and have not had an MRI, please get them to do an MRI and refer them to expert centers. The second thing is that you see that transcatheter valves are evolving also for the pulmonary valve, and that is because the patients are growing and they're surviving, and there is a need for this technology. But the key to success is expert teams and collaboration. Collaboration with radiologists, with adult cardiologists, with anesthetists and surgeons. Thank you very much.
Thank you very much for your nice presentation, very impressive cases you showed to us. And, very brief question, how many venous valves, P valves have you already implanted here?
We've done 5 in 9 months.
Good. And the latest to understand is, you said for cases with very dilated initial
Pulmonary arteries.
Pulmonary artery.
Absolutely.
So it's not a problem that can be solved by the P valve. So you create I understood that you create
and narrow points, and at that narrow point you...
That's the Altera technology that is coming up. That's the Altera technology where we create a narrow point, a landing zone, and then we implant the Edwards valve. And then the venous P valve doesn't need anything.
Cannot solve this problem of dilated...
The venous P valve, oh no, the Altera is for even bigger pulmonary arteries.
It's a matter of size.
Yeah.
Okay, we'll have the opportunity for discussion later.
Yes.
Let's go to the next speaker, Dr. Halapas. Is going to talk to us about transcatheter PVL closure and the mitral valve.
So, dear President, dear colleagues, I want to thank one more time the organizers, Dr. Patakos, Professor Sparias, for this kind invitation. And in the next 5 to 10 minutes, I'm going to present the data regarding the PVL defects in mitral position. So, opposed to defects in aortic position, the mitral valve PVLs are more common, more symptomatic, they are larger, and often repair is more complex. In most of the cases, these defects are located between the anterior lateral and posterior medial aspects of the mitral ring, and in most of the cases, up to 80 to 85%, they are oval or crescent in shape, having irregular borders. As far as pathophysiology is concerned, there are several factors favoring the development of these defects, such as the existence of significant annular calcification, the existence of connective tissue disorders, the chronic treatment with corticosteroids, and of course there are several technical considerations as well. In most of the cases occur relatively early, up to 75% in the first year post-operation, and the rest 25 may occur later after the year post-operation. However, we have always to keep in mind that infectious endocarditis could be a cause of such defects. Clinically, in most of the cases, they are asymptomatic, having a benign clinical course. However, up to 5% of the cases may lead to severe clinical consequences, such as congestive heart failure due to volume overload, when we have large leaks and large defects, symptomatic hemolysis that may often occur with smaller leaks, and of course, infectious endocarditis up to 8% of the cases. This is a very interesting slide coming from Garcia, showing the different hemodynamic patterns that PVLs combined with hemolysis suggest, to mention fragmentation, coalition, and acceleration. Repair is the gold standard treatment approach when we have symptomatic such defects, and although surgery is the gold standard, there is often associated with significant morbidity and mortality, and up to 30% of the cases may not be very successful in terms of recurrency. Very recently, data coming from the Mayo Clinic showed that the transcutaneous approach could be a very good alternative to surgical approach in high surgical risk cases, having very good long-term results. And this is data coming from the KISS registry revealing that the transcutaneous approach is characterized by low in-hospital and shorter-term complications and mortality versus the surgery, which is characterized by better long-term results, but however, it's associated with high perioperative mortality. This is a very interesting meta-analysis with almost 2,000 cases, revealing that the transcutaneous approach is associated with lower perioperative mortality. However, we can see often moderate to severe PVL thereafter, and of course, sometimes we see also congestive heart failure symptomatology. All this data reflected by the latest guidelines from both parts of the Atlantic Ocean, suggesting and recommending transcutaneous approach as Class 2A indication when there is a prohibitive surgical risk, when there is done in centers of excellence, and when there are favorable anatomical features, such as having a sufficient distance from the sewing ring, when there are smaller in size, when there are single and short tunnels.
However, limitations for the transcutaneous approach exist, and just to mention the instability of the mechanical valve or the prosthetic valve, the existence of active endocarditis, the need for another cardiac surgery, and of course, the presence of thrombus. Imaging plays a crucial role in order to define the severity, in order to define the anatomy of these defects, especially at the place of the mitral position. The toe is of paramount importance. And when more information are needed, especially at the place of the aortic valves, we can proceed with CT analysis, with 3D and 4D reconstruction, which can give us insight information about the location, the size, and also we can take information regarding the optimal crossing view angle. Imaging is also important during the procedure in order to evaluate the correct position and device and to confirm that there was no any disturbance of the existing valve, and also to estimate if there is any residual PVL. And here is just an example of an arrow projection showing the sine ring on its side and how you can appreciate the release of a such device. Fusion techniques can also be used. They can give us inside dynamic information during the procedure, reducing the time needed. And as far as the crossing and the approach, we can appreciate that there is most commonly used the undergrade approach through the femoral vein, through the septum, the transeptal by transeptal puncturing, where we use and follow the guides as the TEER procedures. And in such cases, we have to go as posterior and as superior as possible in order to have appropriate space inside the left atrium. Retrograde transapical approach could be another option, especially in posterior and septal located defects. However, there is a surgical approach and therefore requires, it's characterized by higher degree of perioperative complications. When further support is needed, we can use the different loop techniques. And as far as the device we choose, there are several not at the moment dedicated devices, such as the vascular plug 1, the vascular plug 2, the vascular plug 3, which is oval in shape. It is most commonly in use in oval and crescent-shaped PVLs. Most commonly used in Europe. There is no at the moment FDA approved by the USA. Also the AVP4, which are small and are very suitable for small oblique PVLs. And just to mention the atrial septal defect occluder device, the ventricular septal defect occluder device, which however they are stiffer and some very often they are correlated with hemolysis. The only at the moment dedicated device is the Occlutech. It has CE mark since 2014. It's made from nitinol. It comes in 2 different geometries. It has secure mechanisms and they are available in different sizes. So when we have large defects, oval or crescent shape, which are very often very complex, the possibility of using more than one devices simultaneously or in a sequential deployment way could be a very good option. This is a nice also technique described by Emory 1 year ago, showing that the sequential deployment of a covered stent and thereafter a vascular plug could be a very good option. And the recently published data revealed 100% procedural success. There is no complications, and there is no significant, with a significant reduction of PVL. When resistance occurs, in order to pass through these defects and leaks, we may use stiffer wires. You can use smaller hydrophilic catheters. You can choose a different point of access. And of course, you can use the so-called inflated swan cans in low to advance the shield. And of course, you can use also the different loop techniques. Of course, during the procedure, we have to avoid complications having to do with the access site, and of course, complications having to do with the release of the device in order to avoid the interference with the prosthetic valve that may obstruct the mechanical or the bioprosthetic valve, and of course, you have to avoid the embolization of the device. Another complication that can be seen when we have not totally occlusion of such defects is the hemolytic anemia, and it's more often seen in mitral position when there is severe calcification of the annulus. And in such cases, we have either to repeat the transcutaneous approach to go for the surgery or to wait, hoping that the epithelialization and the fibrosis that is going to be developed in the next 3 months is going to diminish such defects. The initial experience for PVL occlusion came and published in 1992 by a small series of 8 cases in the aortic position coming from Hurahan, and 10 years later we have the first publication for the defects in place of mitral position. And we can see, based on recently meta-analysis, that the technical and procedural success rates seems to be higher in place of the aortic defects versus mitral defects. This is a publication come 2 years ago. This is the Greek experience of almost 30 cases in the place of the mitral defect, where you can appreciate that the AVP3 was the most commonly used occluder device, and of course the transseptal approach was the most commonly used approach. Data coming from the Occlutech shows that the device success, the procedural success, and the clinical success goes up to 90% of the cases, and the data coming from the Spain reveal that an independent predictor for a success in such cases is the type of the device used, which most commonly is the AVP3, and of course the experience of the center. So this is a very nice treatment algorithm that we have always to keep in mind when we have a symptomatic mitral PVL, which there is no active endocarditis, when there is no instability of the existing valve, then we can think about the transcutaneous approach. And in summary, just to mention that the PVL defects are relatively rare. The procedure can be challenging, but the success rate in centers of excellence can go up to 90%. Imaging is of meticulous importance, and of course it is very important to resolve completely such defects in order to avoid hemolysis thereafter. And with that, I want to thank you for your attention.
Thank you very much, Dr. Halapas. We heard the transcatheter approach. Let's go to the next speaker. Dr. Panagiotou is going to support the surgical therapy for MV and AV PVLs.
Dear colleagues, Mr. Chairman, for me it's quite clear that we have to work together in this particular field. I'll try to persuade you that you should have a good relationship with your cardiac surgery colleagues in the next 10 minutes. So let's start with the definition of paravalvular leak. It's regurgitant jet or multiple jets between the prosthetic swing ring and native tissues. It's actually the most common non-structural valve dysfunction or deterioration. It has definitely major implication on long-term survival. With the TAVI experience, it has been clearly shown that with the PVL, you have increased mortality if you leave the patient with moderate versus no or mild PVL. It's the first cause of re-intervention in patients after mechanical valve replacement. All these are truths. Surgical correction remains the gold standard treatment since it has been shown that reduces the long-term mortality compared to conservative treatment. What are the risk factors associated with the development of a paravalvular leak? It has to do with annulus, with the environment, and it has to do with surgeons' either experience or surgeons' intraoperative choices, like continuous stitching, which is something that we should avoid because it has much more incidence of early paravalvular leak instead of putting intermittent and a big number of stitches. If you implant a small diameter prosthesis in a hugely dilated annulus, or if you choose to put a prosthesis without stitches, like the TAVI or like the sutureless aortic valve implantation, or like the rapid deployment aortic valve replacement. All these three kinds of implants increase the probability of PVL. In the aortic ring, the PVL incidence is much more in non-coronary sinus, and in the mitral ring, it is near the posterior medial commissure. And this actually reflects the vulnerability of these areas of the rings to mechanical stress. What is the incidence? It was clearly shown by Mr. Halepas that in the mitral valve replacement, there is in the literature between 5 or 32%. It is actually much more in the aortic valve replacement, up to 47%, but the majority, 90%, are very small with a benign course. Probably it has to do with the sensitivity of transesophageal echo in detecting these PVLs. What are the indications? Moderately severe or severe periprosthetic regurgitation with heart failure symptoms, progressive and recurring symptoms. Persisting hemolysis with small numbers of hemoglobin, increased LDH, decreased haptoglobin, and requirements of blood units. A combination of heart failure and hemolysis, failure of the transcatheter approach, either scheduled or on an emergency basis, complications of the transcatheter approach like valve stenosis, valve regurgitation, LVOT obstruction, PVL and prosthetic dysfunction or instability, PVL and active endocarditis, or PVL with need of something else. What are the surgical options? The simple surgical closure, either stitch closure or reinforcement with native tissue like pericardium or synthetic material, or valve re-replacement, redo AVR, redo MVR, or redo double valve replacement. Also, in the transapical approach, there is a role for the cardiac surgery. Let's see our experience, good and bad also at the same time, because you can see that these patients are not straightforward cases. They are very, very sick patients. This is a 56-year-old male patient with 4 months after his MVR for severe MR. In a hypertensive crisis, he went into pulmonary edema. He was intubated in the outpatient clinic. He was on inotropes, and he needed something to be done. He was transferred to our unit. We put him on intra-aortic balloon. We found a severe mitral PVL, so we re-replaced the mitral valve due to valve rocking motion, as you can see. Another scenario is PVL with aortic endocarditis. This is how we find in a difficult case of aortic endocarditis. And the problem for us is that we have to reconstruct the aortic annulus, which is destroyed by the infection. We need bovine pericardial patches, and in this particular case, we combine the operation with the NICS procedure for the reconstruction, also for the non-coronary sinus of Valsalva. 69-year-old female, 2 months after mitral valve replacement, aortoplasty for dilated ascending aorta plus radiofrequency ablation for AF in another hospital. He was on heart failure with pleural effusion bilateral, and actually we did a redo mitral valve replacement. We replaced the ascending aorta and we excised the membrane because the patient had cord triatriatum, and it was not realized by the first operator because he went through the right atrium and not through a left atriotomy. 72-year-old female, 8 months post mitral valve replacement and external grafting of the ascending aorta with bilateral recurrent pleural effusion, New York Heart Association class 3. On chest CT, she had chronic dissection of the ascending aorta inside the graft. which was outside of the aorta. And on echo studies, he was on severe mitral PVL with severe tricuspid regurgitation. So we have to redo, we have to replace the ascending aorta. You can see in the left upper how it was, the graft was stuck in the surrounding tissues. You can see the chronic dissection. We simply sutured the mitral valve. We did a tricuspid ring annuloplasty. Another nightmare, 56-year-old male with a history of bendal operation 10 years before. He was on a huge number of PVCs and heart failure symptoms. He did an unsuccessful redo 3 months before our operation due to false diagnosis of left main anastomosis pseudoaneurysm. This was the CT, and you can see the mass just below the ascending aorta graft. So we have to do the third operation. We did the hemianch replacement with hypothermic arrest. We did a bendal extraction. We closed the PVL and we rebendal the patient. So you can see that these are very, very sick patients. If you have the unlucky condition to deal with the double valve replacement patient, you should be ready for commando or UFO procedure. As you can see that you have to, in this commando operation, actually you have to open 3 cavities, ascending aorta, left ventricle, left atrium, and reconstruct everything just to host the 2 implants. This is the UFO modification of UFO. What are the results? The results are in big series of Milan, Ottavio Alfieri, 5% for the aortic redo for paravalvular leak and 13% for mitral paravalvular leaks. 1.6% were operated in the same admission because of very early recurrence and unsatisfactory result. Another big series from Canada, 3% for aortic, 8% of mitral, and 14% for double valve procedures. And in this series, it was clearly seen that there is also a PVL recurrence, 3% in the first year and 32% after 10 years. These are results in comparison with the redo, with the general population of redo AVR for many reasons, for many indications. Redo AVRs in the Europe, it's 5.1, and redo MVRs, it's between 4.9 and 6.9%. The experience, for me, it is absolutely clear that we have the increased information we have, and from the transcatheter approaches, we have to work together, and this is a very good algorithm that was shown by the previous speaker. What are the comparison from the Montreal group between redo surgery and transcatheter PVL closure is that despite the increased perioperative mortality and morbidity, surgery remains associated with better long-term outcomes, mostly driven by reduction in hospitalization for heart failure. So the take-home messages are, these patients are usually very sick patients. The possibility that you will need a demanding surgical procedure is very high. The early results in specialized centers are acceptable, with better sealing probabilities than the transcatheter approach and consequently better long-term results. Heart team approach should always be considered in these patients. Thank you very much for your attention.
Thank you very much, Dr. Panagiotou, for your talk and the very impressive cases you showed us. So complex surgery, really.
Yes,
it's not simply to close the PVL. Our next speaker is Dr. Mitsis from Nicosia General Hospital, Cyprus, and a previous student of mine. He reminded to me, and I'm very happy that he will present the deciding on when and how to perform transcatheter ASD and PFO closure.
Dear Chairman, dear colleagues, first of all, I have to thank the organizing committee and Dr. Spargias for this kind invitation. And in the next 10 minutes, we will discuss about when and how to perform transcatheter ASD and PFO closure. So what is a PFO? PFO is a persistent communication between the right and the left atrium. And of course, this communication is vital in fetal life, but after birth and as the lungs start to expand, we expect an increase of the pressure in the left atrium and a fusion of the primum and the secundum. But this is not going to happen in about 25 to 30% of adults. PFO is considered harmless in most people, and as you can understand, it's a completely different situation with the ASD. In the ASD, we have a hole, we have a defect, and of course, this is more infrequent, but it can create a continuous shunting between the left and the right atrium, and at the end of the day, volume overload of the right heart. So why we discuss about closing a PFO since it is harmless? Because under some conditions there might be a paradoxical embolism and material from the venous can travel through the PFO to the systemic circulation and embolize. And of course, this picture is something that none of us is gonna face most probably in our career, but it shows that the thrombus can travel through the PFO, even for the more skeptical. And speaking about strokes, almost 40% of the strokes are cryptogenic, meaning that we don't have a clear cause of the stroke. 12% of the population with cryptogenic stroke might have a PFO, and excluding the relative older patients, it terms that 4% of these cases, the PFO might have a causal role. So our job is to try to find and go from this 38% to find this 4% of the patients. So our job is to find the strokes that are related to the PFO. And what we need, of course, we need a stroke, we need the neurological symptomatology, we need imaging, we prefer MRI, and of course, we have to exclude other causes, more common causes of stroke. The risk profile of this population is a relative young patients with no common risk factors. We need to exclude the carotid disease, and last but not least, we have to exclude atrial fibrillation. And this is very important because quite often we have referrals from colleagues who said we put a 24-hour Holter and we exclude AF. But this seems to be not the case. We need to be more precise. As we know from Crystal AF, in this study they studied population with cryptogenic stroke, and they implanted ILR, and almost in 9% of this population, they managed to detect AF at 6 months, and almost in 13% at 12 months. So we have to be more precise in excluding AF. As you can understand, patient selection is quite tricky and challenging. There are tools like the ROPE score we can use. In our institution, a ROPE score above 7 is mandatory prior to proceed with closure of the PFO. And again, we need the neurologists, the stroke physicians by our sides. Usually, these are the referral doctors. A cortical infarct is the rule. This is the embolic stroke and not the lacular infarct. And at the end of the day, the decision is in a level of multidisciplinary discussion in order to find the proper patient. Since we agreed that we have a patient who might have a causal role of the PFO, we need to decide how we will treat him. And the last 2 decades, there are a big discussion and a big evolution. And especially with a longer follow-up from the reduce, close, and respect trials, we now know that percutaneous closure of the PFO is superior than the antiplatelet therapy in terms of reducing the risk stroke in this group of patients. And this is reflecting in the guidelines of the major cardiovascular societies. So in the workflow of the selection of the patient, apart from the clinical characteristics that we discussed earlier, we have to take under consideration and some special characteristics of the PFO itself. There are some PFOs that are considered in high risk, the large PFOs, the PFOs associated with large tunnels or with aneurysm of the septum. If there is a presence of a Eustachian valve and Chiari network, or if there is a PFO that is always open and doesn't need a Valsalva maneuver. The size of the PFO, we can judge it with a bubble test. And over here, we have the other two major risk characteristics. This is the PFO with a large tunnel, and this is a PFO with an aneurysm. The procedure itself is not very challenging, let's be honest. It's quite easy to cross the PFO with a 0.35 wire and put a multi-purpose and over a stiffer wire to close the PFO. This can be done in a completely minimalistic way without any guidance in less than 15 minutes. But is this what we want from this group of patients? Probably not. Again, these are patients relatively young, 35, 40 years old, and our responsibility is to offer a program with if possible, with zero complication risk and low recurrent event rate. Adding in our everyday practice the ultrasound guided puncture of the femoral vein and use of pre-close devices can minimize the risk of bleeding. And of course, the guidance of the procedure is better to be done under TOE or ICE, depending on the expertise of each center. There are many devices in the market. We will not go in details, but at the end of the day, the so-called simple PFO can be closed with a 25-millimeter device. Larger PFOs associated with longer tunnels or aneurysm might need larger devices, and probably the balloon inflation in this case is beneficial. As in this case, this is the case I showed you earlier with a large tunnel. We use a 25-millimeter balloon inflating up to the level when there is no flow anymore in the TOE. We measure the waist both in fluoroscopy and TOE, and in this case it was 11, 12 millimeter, so we have chosen a 30-millimeter Figula 2 device to close this PFO. After the procedure, the patient should be stayed in dual antiplatelet therapy for 3 to 6 months and lifelong on aspirin. And we have, of course, to follow up the patient with bubble test in 6 months to 12 months to assess the effective or complete closure. And of course, a brief comment about the post-procedure AF. This is a nice slide from the work of Professor Choufis and that's showing and summarize actually all the details. The AF post-procedure is not very common, 5%. Usually it's observed the first month and then it goes down, and probably because of local irritation or inflammation. And let's finish with ASD. The most common is the defect of the secundum, the ostium secundum. Over here, the decision to treat is more clear. If there is a paradoxical embolism, we have to proceed with closure. If not, we have to evaluate if there is a RV volume overload and pulmonary hypertension with less than 2 hoods and more than 2 hoods and less than 5. Which ASD is suitable for percutaneous closure? Usually the PFO that is less than 38 millimeter, and we need sufficient rim at least 5 millimeters apart except from the aortic side. Over here we have more devices that can be used in multiple fenestrations, but again the procedure more or less should follow the same steps. Over here the balloon is mandatory to size the defect and help with the correct size of the device. In conclusion, these both procedures require a careful patient selection. We have to be able to offer a safe procedure, especially the patients with the PFO closure, and the final selection of the patient should be done in a multidisciplinary approach. Thank you very much.
Thank you very much, Dr. Mitsis. Our last speaker is Dr. Asvestas from Itera Hospital, and he's, I think he's online. Is Dr. Asvestas connected?
Yes.
Okay, I can hear you. And he will give us the talk, left atrial appendage occlusion, sync procedure, or combining with catheter ablation. Dr. Asvestas, we can see you, but not your slides yet.
Not the slide.
Yes, you see the slides as well.
Just a moment. Now?
Yes, okay.
Okay, dear colleagues, I would like to thank the organized committee, Dr. Patakos and Dr. Sparias. I'm sorry I couldn't be there with you. So my presentation is left atrial appendage sync procedure or concomitant catheter ablation. I will begin. Atrial fibrillation, we know that it is the most common cardiac arrhythmia and the major risk factor for thromboembolism. And catheter ablation for atrial fibrillation is recommended as a first-line option by the latest guidelines to prevent AF recurrences and improve quality of life in symptomatic paroxysmal or persistent atrial fibrillation. However, guidelines recommend the continuation of long-term anticoagulation in patients after catheter ablation with a high stroke risk, irrespective of the rhythm outcome and successful ablation. And a significant proportion of patients have limited anticoagulation options due to contraindication, for example, a history of bleeding or high bleeding risk, or a high risk of stroke, patients who experienced a stroke under anticoagulation, or side effects, or there is a tendency from some patients who want to discontinue anticoagulation. So left atrial appendage occlusion is an option for these patients, for patients at high bleeding risk. Many studies and data demonstrate that appendage occlusion significantly reduces stroke risk compared to the expected risk based on the SATS-VASc score. And the question is if the combination of these two procedures is effective and a safe strategy, and can the combination of these two procedures can improve the prognosis in patients with a high risk of stroke. Indeed, as both AF ablation and percutaneous left atrial appendage occlusion require transeptal access to the left atrium, the combination into a single procedure may offer a straightforward strategy, leading at both rhythm control and stroke prevention without having the additional risk of multi-procedures and complications, and with a high device placement success rate, as shown in this study, about 97% in implantation of a Watchman Flex device. A very important trial recently published in the New England Journal of Medicine is the OPTION trial. The aim of this study was to determine if left atrial appendage closure is a reasonable alternative to anticoagulation following AF ablation. So patients randomly underwent left atrial appendage closure, the device group, or received anticoagulation, the anticoagulation group. The results of this trial showed that the device group was associated with a lower risk of non-procedure related bleeding than the anticoagulation group, and also was non-inferior with respect to a composite endpoint of death from any cause, stroke, or systemic embolism at three years. Another important sub-analysis of the option trial included two patient cohorts. The first sequential arm, there were patients who had an ablation 3 to 6 months prior, and these patients were randomized to device implantation or continued anticoagulation. And the concomitant arm, patients who were planning to undergo ablation, were randomized to device placement or continued anticoagulation. And as you can see, the 3-year efficacy was similar between the Watchman Flex device and anticoagulation in both arms, maintaining the safety advantage of the device in reducing bleeding risk, regardless of whether the ablation and left atrial appendage closure were performed in a concomitant or sequential manner. So choosing a concomitant procedure does not appear to increase adverse effects. Simultaneous AF ablation and left atrial appendage occlusion can be performed within a short overall procedure duration. According to this study demonstrated that adding the device increased the procedure duration by no more than 20 minutes, while also reducing the fluoroscopy time. However, there are some concerns with concomitant procedures. The first is the presence of sometimes edema in the pulmonary reeds. So the question is to upsize the device. This option can lead to device dislodgement, increased pressure, and increased risk of perforation. Deep device implant has been suggested, but there is a higher risk of device-related thrombus due to larger uncovered areas of the left atrial appendage. And here is a case report, 2 cases published in JACC, which demonstrates the edema of the reeds and how the reeds of the ostium of the reeds and the ostium of the appendage changed in dimension before and after cryoablation. Secondly, there is increased risk of device-related thrombus and subsequent thromboembolism due to ablation edema resultant endothelial dysfunction. Third, for the transeptal puncture, current AF ablation techniques often require a less posterior transeptal access than what is optimal for device implantation. And this can sometimes make the procedure more challenging. Some studies have shown a slightly higher rate of minor leaks in the concomitant procedure. And finally, the device itself may act as a trigger site for atrial fibrillation in some cases. Nowadays, pulsed field ablation, PF ablation, appears to be a promising alternative to thermal RF or cryo, and PFA is a more controlled form of energy and does not damage adjacent structures. The question is if there are advantages with PFA in combined procedures. The possible advantages can be that it's a single short procedure, providing shorter procedure times. Also, transeptal puncture can be performed in a more suitable position for left atrial appendage access. Also, PFA is a more tissue selective form of energy, and this theoretically can lead to a lower risk of certain complications in a combined procedure. And the question is whether PFA can create less edema in the of the reeds in the left pulmonary vein, and consequently decrease the risk of peri-device leaks. This recent study included combined and standalone PFA and left atrial appendage occlusion procedures, and found similar acute success rates of left atrial appendage occlusion in both groups. The study found that in this study, the pulmonary reeds thickness increased after ablation by approximately 69%. And at 3 months, the rate of peri-device leaks did not differ significantly between the combined and device alone groups. However, a significant link, more than 3 millimeters, occurred more commonly in the combined group compared with the standalone left atrial appendage occlusion group. And there is a study in this study, the aim of the study was to determine the effects of ablation first compared to occlusion first strategies in patients who underwent combined procedure. And they found that the incidence of chronic PDL, the chronic presence of leaks, was higher, 3 times higher in the ablation first, 15% versus 5% in occlusion first group. In summary, combining AF ablation and left atrial appendage closure in a one-stop approach is effective and safe for achieving successful PVI, successful AF ablation and left atrial appendage occlusion implantation. It may provide a way of addressing arrhythmia burden, stroke risk, bleeding risk simultaneously in appropriate patients. There's a higher incidence of mild or moderate leaks in patients post-ablation, and we need further research to clarify the beneficial role of the combination of these procedures and assess long-term outcomes. Thank you very much.
Very much, Dr. Zvistas. We have just a very few minutes. Dr. Mavrogianni, your comments?
Could I have a microphone, please? Yes. Thank you so much. Just a few notes. Dr. Zifas, I loved your talk. This is a very specific population of patients. You have to be extremely well educated to deal with these kinds of problems, but it's nice to know that somebody has solutions for children that cardiac surgeons cannot touch upon them. The 2 talks in combination for paravalvular leaks, I like them both. I think the less invasive you are, the more minimalistic you are, this is the best solution usually, but Dr. Panagiotou, I'm sold. There is still room for cardiac surgeons in this world. And as for the last 2 talks, I like the PFO talk. It's a revival of the closure of the PFO in the last few years. We have to be very strict about the indications and the patients we are dealing with. And as for your talk, it's a very nice approach. The one-stop shop approach is completely fine with me. Thank you very much.
Thank you, Dr. Deradimas.
Congratulations to all presenters for the very interesting talks. I had 2 short questions. One is for Dr. Gifa. The chimney technique is a technique we use to protect the coronary ostia in cases of TAVI procedures that we fear that will be occluded. And you showed some cases we are afraid of or deferring the case because there might be a risk of occluding the left main. Do you use the technique in pediatric population or not?
Not at all.
Is there a reason? Would you explain or not?
We don't use it because the coronaries in children are much smaller.
So no stents available?
Stents may be available, but
there are several reasons.
As
There are
they grow,
several reasons.
then
One,
the left main will remain very small.
it's not just that. It's not just that. One reason is that the coronaries may be smaller, and once you start with a stent in a child in their coronary, what is the future? You condemn them to long-term problems. Whereas if the surgeon goes in and puts another valve safely with FEMFEM bypass, then that's better. The second reason is that it's not always ostial, the compression. As I showed you, it's further down, it's more distal. So you're not sure about what kind of protection you can offer.
And the second question is for Dr. Panayotou. We know that less than moderate PVL after TAVI usually gets better over time, given the positioning of the valve. Could you share us your opinion and your expertise about the clinical course of PVLs that you don't treat immediately after surgery? When is the time to intervene, if you...
Of course, you have to... I have already introduced that if there is a severe, if it is characterized severe, you don't have to leave the patient in the first postoperative course, okay? But you have to close follow them up and to see what is the consequences of this PVL, not only in heart failure symptoms, in hemolysis, but also in, you have other markers. You can see in the cardiac triplex what is the consequence of this PVL in the LV dimensions, in the LA dimensions, etc. I think that it's a very difficult question to answer, and also it's a problem of surgical egos. You know, that's why it's you should deal in this patient, because it's a surgical catastrophe, a severe PVL after the first cardiac surgery. It's the Achilles heel of cardiac surgery. So you have to deal with the heart team there and close follow up the patient, and don't hesitate to do it earlier. You see, a redo in the first 6 months is also a nightmare due to the inflammation of the tissue, but sometimes you have to do it.
Okay, Dr. Halapas has a small comment on the PVLs.
First of all, there are not so often the symptomatic PVLs. The symptomatic PVLs are a rare situation, and in case after a surgery you have such a condition, you have to treat it as soon as possible.
Okay, thank you. And our final moderator, Dr. Dimitriadis.
Thank you for inviting me, Dr. Spargias, and I would like to ask, I really enjoyed the talk by Dr. Zifa, and I would like to ask her, we don't know from the prosthetic valves the dysfunctional part. I mean, do you know what are the main parameters that these valves in pulmonary area do present dysfunctional features, and are we more optimistic with the new designs on the new scaffolds?
We are optimistic that the new designs are going to last longer and degenerate that long, indeed. They're, of course, more expensive, one thing to take into account, but they degenerate the same way, so it's either stenosis or regurgitation, predominant, or usually mixed disease. And the criteria upon which we intervene are the same criteria that the surgeons do. So the stenosis above 4 meters per second with pressure loading of the RV, and then the volume loading of the RV in case of pulmonary regurgitation with an RV-DV of more than 150, 140. We've come down a little bit, but 150 mL per meter square. And we also see the ejection fraction of the RV. So careful about the RV. You may see the ejection fraction going down even with 130 and 140. And the second criterion is when the RV is double the size of the LV. And the third criterion that is going to come into play is reduction of the ejection fraction of the LV because of ventricular to ventricular interactions. So I've seen adult fallow patients followed up by adult cardiologists that are on treatment with Zardians and diuretics and da-di-da-di-da-di-da. And then they say, well, we fixed the patient, but it's actually the RV that is the problem. So it's a multifactorial thing. You need to know the disease really well to be able to treat your patient really well.
Okay, thank you very much. I think we have to conclude as we are running late. Thank you all of our speakers, moderators, and you for your patience.
Dear friends, on behalf of my co-chairman, Dr. Spardias, I would like, first of all, to thank the organized committee, starting from you, Kostas. Thank you for this kind invitation. Professor Vardas, Dr. Patakos, and congratulations for this great meeting. Without any other delay, I would like to introduce the first speaker, who is Professor Kilic. He is the current president of Turkish Society of Cardiology, interventional cardiologist with great experience in this field. Welcome and thank you for coming. And we are looking forward to enjoy your talk, interventional therapies for heart failure, a very, very difficult and challenging issue.
Thank you very much, dear chairman and colleagues. I want to thank you very much again for the organizing committee, to our friends for their kind invitation to this important structural heart interventional congress. My topic is the interventions for heart failure. It's really an interesting topic. These are my disclosures. When we look at the heart failure epidemiology and epidemic, enhanced survival in other cardiovascular disease such as coronary artery disease because of the interventional cardiologists and primary PCI, coronary deaths are down by half, but heart failure has almost tripled. So it is really increased. When we look at the mortality rates of heart failure, it is equal to pancreatic cancer and higher than the lung cancer. Mortality is very high. So there are some important referral signs of heart failure, and Guglin et al. Made an acrostic about it. I need help. Inotropes, functional class, end organ dysfunction, very low ejection fractions such as 25%, recurrent appropriate defibrillator shocks, and at least one hospitalization with heart failure in the past 12 months are very important signs, and also the prognostic medications. As we see large mortality benefits observed across key therapies for treatment of select heart failure, reduced ejection fraction patients, and this benefit was observed much from sacubitril valsartan, hydralazine, isordil, and some device therapies such as CRT and mitraclip. The combination of these therapies is associated with greater risk reduction And guideline-directed medical therapy improves heart failure, morbidity, and mortality. But when we look at the discontinuation of the drugs, large proportions of the heart failure patient population remain under target dose or have discontinued guideline-directed medical therapy at 1 year. This is a very, very important image of the heart failure, status of an heart failure patient. After the onset of heart failure, guideline-directed medical therapy institute, patient go to in a relatively stable phase, but then episodic acute and subacute decompensation periods begin. So this period is very important and required advanced intervention. Otherwise, pump failure develops and the patient go to the heart transplantation, and heart transplantation rates are very low, as you know. So pharmacological therapy alone may not be sufficient in all cases. These all are demonstrated in the Moxon study. So there are some new interventions required for heart failure. What are these? We can summarize. One is the left ventricular restoration devices like parachute device, cardiac contractility modulation, iatrogenic atrial septal defect shunt devices, AFR, prototype, V-Wave, Corvia, implantable hemodynamic monitoring devices. The featured devices are very, very useful among heart failure clinics. Pulmonary artery pressure monitoring like CardioMEMS, Cordella, and left atrial pressure monitoring, Heartport and VLab, and also neuromodulation and splanchnic nerve blockage, and novel devices especially for cardiorenal syndrome and also the valvular interventions. Today, in 2 days, we discuss about valvular interventions so much, and I want to quickly summarize other interventions. This is another summary of the novel therapies management of heart failure, neuromodulation therapy, vagal nerve stimulation, splanchnic nerve blockage, and left atrial decompression. Some of new shunt devices like Noya and Alleviant device, and cardiorenal syndrome devices, aortic right and pump, second heart assist, Dorea renal flow regulator and precardia, and also implantable cardiac hemodynamic monitoring, the Abbott CardioMEMS device, and Cordella and the VLab. So when we look at the CardioMEMS, it's venous no septal puncture. VLab requires septal puncture. This is the image of the CardioMEMS, and you can see the implant of the CardioMEMS device in the distal pulmonary artery. So when this device implant, the patient come to clinic in a supine position, and if the elevated pulmonary artery pressure observed, this means this patient is hypervolemic, and we can increase the diuretic therapy. This was clearly shown in the Champion trial, and during the 6 months and the full follow-up, the device group made 37% relative risk reduction in the endpoint, and one of the endpoint, primary efficacy endpoint, was heart failure hospitalization at 6 months. Guide heart failure trial design, one is the treatment arm and the other one is the control arm. Total follow-up was 12 months, and when we look at the 12 months follow-up period compared to the control group, the treatment arm has lower mortality and cumulative hazard rates. And the sustained reduction in heart failure hospitalizations were observed. Cordella is another prototype of a pulmonary artery pressure monitoring, and Sirona and Protect trials are ongoing, and VLab is another left atrial pressure monitoring device, and Vector heart failure and Vector 2 clinical studies are ongoing. When we look at the interatrial shunt devices, for the left heart failure, the aim is to decrease the elevated left ventricular filling pressures, to decompress overloaded left atrium, to decrease left atrial pressure, pulmonary capillary wedge pressure, and mean pulmonary artery pressure, and shunt will be left to right. And conversely, in the patient's pulmonary hypertension group, the aim is to decrease right atrial pressure, since the patients with right atrial pressure has the higher mortality rates, and to make the shunt to right to left. The prototype is the Occlutech atrial flow regulator in Europe and the Corvia in the United States and the V-Wave. When we look at the devices, in the first generation of V-Wave, there was occlusion risk at 12 months, but the new second generation is created and trials are ongoing, relieve heart failure. Corvia, it was a disappointed trial, the reduced left atrial pressure, like the renal denervation trial, but there are a lot of problems for the patient selection, like patients with combined pulmonary and isolated post-systolic hypertension. So these all group will be re-examined. Device fenestration is 8 millimeter, and positive results were observed in the AFR PRELIEVE trial, and implantation is very easy and no embolization was observed during the follow-up. This is another new device which we can put the device between coronary sinus and the left atrium, test septor shunt device. Noya interatrial shunt device of Edwards company, and you can see the left atrial and right atrial part, and the no implant shunt approaches are coming, like Alevian system and intershunt percutaneous atrial shunt system. But we are waiting the study results for the interatrial shunt therapies. Other group is the neuromodulation and subplanchnic nerve ablation. One is the Barostim Neo device, an implantable pulse generator placed in the chest area and connected to an electrode positions in the carotid sinus, and the device stimulates the carotid baroreceptors to reduce sympathetic activity and increase parasympathetic tone, thereby aiming to restore balance in the autonomic nervous system. Then the hope for heart failure and beat heart failure studies are ongoing. Harmony device is a system composed of an implantable unit capable of delivering electrical stimulation, and endo heart failure is now ongoing. And Vitaria device is another vagus nerve stimulation system, and Anthem heart failure reduced ejection fraction pivotal study and Anthem heart failure preserved ejection fractions studies are ongoing. This is the summary of the neuromodulation for heart failure. One is another interesting therapy is the subplanchnic nerve blockage because it has the potential to reduce preload and afterload by causing vasodilation in the vessels of the subplanchnic region. So oxygen therapy Satere ablation system is a new system, and the target is this greater subplanchnic nerve. And some of the devices like intra-aortic balloon pumps or Impella, like in acute heart failure, some chronic heart failure devices are developed to increase renal perfusion pressure, like aortic Raytan catheter pump, second heart devices. These are investigational devices, and Dorea renal flow regulatory revamp device, like Precardia. And one important device is which takes an FDA approval is the cardiac contractility modulation optimizer smart system, which gives some generations in the absolute refractory period to increase the calcium entrance into the myocytes. So these are the summary of the novel investigational device. And the take-home message, heart failure is the prototype of a structural heart disease, and structural therapies will save with structural heart patients. Thank you very much for your attention.
Professor Hills, for this very, very nice overview of this. This is a very, very challenging issue. Many therapies are promising, but of course we need more and more data, particularly a short comment on the neuromodulation. It's very interesting. Unfortunately, despite that pathophysiology supports the idea, all the studies, less or more, have been felt to show a clear benefit. Maybe in the other area of heart failure with preserved ejection fraction, we have more space for neuromodulation, renal denervation, and combined with other, let's say, areas of targeting. Thank you.
Thank you.
Thank you, Theo. A question for me, or your opinion, a comment about, do you believe in those LV reduction transcatheter therapies or LV remodeling therapies? What is your opinion on these that are under investigation?
Actually, in very selected patients, like patients with left ventricular aneurysm, like surgeons do Dopplerplasties and etc. The device, parachute device, was developed like this. The first results were positive, but you know that these are all investigational therapies, but we had to see the long-term results. And the very low number of patients included in that study.
And very invasive therapies.
Yes.
Into very badly diseased ventricles.
But the shunt therapies, I can say something. We are the first center involved in the AFR heart failure study, and we start the first implantations, especially some of the patients you know that who admitted to emergency service with acute lung edema. These patients are very, very, after careful right heart catheterization, this is also very important. Some parameters are very important to do shunt therapies. During the follow-up period, we observed no hospitalization, but appropriate therapies in appropriate patients, not in all patients.
Are these therapies more effective in HFrEF or in HFpEF?
Actually,
or both.
The studies were designed, you know that the Corvia in United States were designed for heart failure with preserved ejection fraction. But at that time, we also underlined that these therapies can be harmful if you don't measure the catheterization very well during the early phase of the studies. So the larger benefit was observed in shunt therapies in patients with reduced ejection fraction rather than preserved left ventricular ejection fraction, because the tissue is very important. Tissue stiffness, some of the other problems in the pulmonary vascular area, we don't know what's going on there. You know that some patients have very high pulmonary vascular resistance and some not. So I think the shunt therapy for heart failure is appropriate for patients with, for example, acute lung edema who are admitted to the emergency service with heart failure.
A last comment. The problem with the patients with heart failure that they have already undergone a number of procedures. Some of them TAVI, mitral clip, tri-clip, ICDs. So for me, it would be very interesting to see a new interventional therapy without leaving anything behind it. Yes. This is the ideal therapy for interventional therapy for heart failure patients, for every patient, but particularly for heart failure patients, in order to avoid any extra risk with one more tool that have been implanted in their heart.
Yes. For mitral clip patients, some group, for example, when you make a septostomy and you make a large hole in the left atrium, and, for example, after some AFRs cases, without mitral clip, mitral regurgitation decrease. Some patients can have benefit from these kind of shunt therapies, or some not, but the catheterization give really a good information.
Thank you.
Thank you, Dr. Kilitz. And we now move on. I think our next speaker is online, Madalena Gerbi. Hello, hi, nice to see you again.
Hi, hello. Thank you for inviting me.
Welcome, so good to see you. Madalena left Athens and Greece a few years ago, and she's having a wonderful career in the UK. She's the president of the British Heart Valve Society, correct, Madalena?
I am the current president of the British Heart Valve Society, and I'm a consultant at Royal Papworth Hospital in Cambridge. And you know, it's 20 years.
Right, it's not yesterday, so it's a long time. Okay, so Madalena is going to tell us about the shift, the paradigm shift in the transcatheter valve therapies.
Okay, so these are my conflicts of interest. So this paradigm shift brought on by transcatheter valve therapies began with aortic stenosis.
Madalena, can you share your screen?
I thought I do. I'm going to try again, sorry. Let me just try again to share my screen and start again. Where are you? You're here. And I'm pressing share. Can you see now? My screen?
Yes, please magnify, go to the
Excellent.
presentation set, yeah, and then you're good to go.
Yeah.
Great.
Okay. Excellent. So the paradigm shift brought on by transcatheter valve therapies began with aortic stenosis. We may all remember the partner trial back in 2010 when aortic stenosis patients that were inoperable had a very hard time in the last months of their lives and a very hard death. And partner trial initially was for the inoperable, and it brought on a therapy for the inoperable through transcatheter aortic valve insertion, which made a big difference to treatment of heart valve disease. Certainly because aortic stenosis is very common, is the most common valve disease, particularly in the elderly with comorbidities. The progress in evidence for this paradigm shift is more established in the case of aortic stenosis. I did not bring a slide for the partner 2, but partner 3 trial already moved to low surgical risk and still demonstrates benefit of transcatheter aortic valve insertion compared with surgery, even in the low surgical risk patients, and then obviously allowed envisaging early treatment of aortic stenosis with a very low risk therapy that TAVI is. You can consider TAVI for the asymptomatic, and you already know this trial published in 2024, late in 24, in New England Journal of Medicine, transcatheter aortic valve insertion in asymptomatic patients with severe aortic stenosis. And there is a benefit in them as well, again, because of the existence of a large proportion of patients with aortic stenosis in the elderly. There was a lot of assessment on evidence brought on regarding the structural damage, apart from the aortic stenosis, the structural damage of the heart as a result of aortic stenosis in these patients, and also evidence regarding the possibility of sudden death, which is there with severe aortic stenosis, even in the absence of symptoms, and explains why early intervention can help, even just immediately in the short term. I believe that if we were to be able to assess in the long term what happens with those patients and to have large populations of patients, we will find significant benefit in the long term, particularly in the younger group of patients with severe aortic stenosis, by avoiding the myocardial damage and the consequences, the hemodynamic consequences on both the left and eventually the right heart in these patients. So is it all about aortic stenosis? We need to move on with this paradigm shift towards other types of valve disease to be more daring. Firstly, recently we have transcatheter therapy for pure aortic regurgitation as well, and this allows consideration of paradigm shift in this regard. We know that severe aortic regurgitation, although is less prevalent than severe aortic stenosis, and cases are more less concentrated in one clinic, in around one operator. We know that actually looking into this patient's category, they have a higher mortality. They have the highest mortality of all patients with heart valve disease if they are symptomatic, and particularly if they are severely symptomatic. From New York Heart Association Class 3, you see that mortality is almost 1 in 4. So it's absolutely very significant mortality. But even in the asymptomatic patient, you have almost 3% mortality in patients with aortic stenosis, with aortic regurgitation. So why is aortic regurgitation forgotten? And I think tricuspid regurgitation used to be the forgotten valve, and at the moment, aortic regurgitation is in the process of being less forgotten and being more in the highlight, in the spotlight for investigations, because we have a bias which is caused by the aortic regurgitation in the young. which is the aortic regurgitation caused by bicuspid aortic valves, which is a condition that progresses very slowly from being just a valve which is dysplastic to being a valve which is dysplastic and severely dysfunctional, and subsequently with having immediate consequences. And because also the evidence, you can see even in this study, that this is published in 1999, so evidence is very old, that evidence that encourages us to follow up patients with aortic regurgitation without offering valve intervention comes from the times when treatment with surgery was higher risk than actually just follow-up, although things we know have progressed a lot in cardiac surgery as well regarding safety of procedures in patients with aortic regurgitation. So because transcatheter therapies allow us a paradigm shift towards an older population and a population that has more comorbidities and a higher surgical risk, we have this recently published beautiful study from Cleveland Clinic Foundation, which looked into what happens with the ventricles of individuals that are older, and they also looked at women. So practically, because of this bias of waiting for the ventricle to dilate and to drop ejection fraction that we had in time from the younger patients with bicuspid aortic valve in all the times, we did not observe that actually the left ventricle does not remodel the same in the elderly and in women. So the ventricle does not dilate. So we should not wait in individuals which are over the age of 65, and particularly in women over the age of 65, for the ventricle to dilate, particularly as we now have a low-risk treatment for them, which is the transcatheter aortic valve intervention for aortic regurgitation. And why is the ventricle not dilating? There's this beautiful study which was actually old but not observed, not put in the spotlight, that actually the dilatation of the left ventricle is a phenomenon of adaptation to avoid pressure rise, so to avoid symptoms. However, with age, we lose the adaptation to aortic regurgitation. And the pathology of the aortic valve, which causes aortic regurgitation with age, is usually degenerative, is usually calcification of the aortic valve, which does not stenose the valve, it's only retracting the cusp, it causes scarring of the cusp, or is a combination of the two, aortic stenosis with aortic regurgitation. And these individuals beginning their aortic regurgitation at an older age have lost the process of adaptation. And I would like to introduce this idea as well, the fact that it is observed that low flow is not specific for aortic stenosis. So the idea of low flow, so small left ventricular cavity, non-distensible left ventricle, is specific to age rather than specific to aortic stenosis. So it can occur in individuals that have mitral regurgitation, atrial secondary in etiology, in individuals that have aortic regurgitation. And we should not wait for a very large regurgitant volume in these individuals where their entire stroke volume is very small. So it opens our mind, and there's a paradigm shift towards looking to move treatment forward to lesser levels of degree. And there is more evidence recently, as observed from this paper published in JACC from Mayo Clinic, that actually adverse outcomes in patients with aortic regurgitation begin to be observed from ejection fraction 60%, not 50% and not 55%, but even 60%, and with a drop in GLS. And even more so, this beautiful study from Patricia Pellica at Mayo Clinic has looked at moderate to severe rather than purely severe aortic regurgitation, acknowledging the fact that nowadays the thresholds for considering aortic regurgitation high are too high. Severe are too high. And my hope is that there will be a paradigm shift in this regard as well. Furthermore, transcatheter therapies will allow a paradigm shift in the treatment of multivalve disease, which is currently really in the spotlight. Why it allows a paradigm shift? Because traditionally, treatment was concomitant. At the time of cardiac surgery, it was perceived as absolutely the right thing to do to treat moderate valve disease that coexists with severe valve disease or coexists with surgical coronary artery disease. However, for transcatheter therapies, we can consider stage intervention. Stage intervention is feasible. You can go back, you can do it, you can be wrong, you can hope that the second disease will resolve. And if it doesn't resolve, yes, you can be wrong because you can have a second chance to treat the patient with a transcatheter intervention, which is, low risk and low suffering compared with a reduced sternotomy that you may have to offer in case of not treating the less than severe second valve disease. So there are many combinations of valve disease we have to have in mind. Or as you can see, aortic stenosis with mitral regurgitation, aortic stenosis with tricuspid regurgitation are pretty frequent, and the opposite, mitral regurgitation with aortic stenosis, which I want to highlight, because when we put aortic stenosis with mitral regurgitation, we mean the severe is the aortic stenosis and the mitral regurgitation is coexistent. However, it can be the opposite, that you have severe mitral regurgitation and less than severe aortic stenosis. And that is, again, something to consider, the type of treatment and the treatment strategy you will use, particularly as you have available transcatheter therapy. So aortic stenosis and mitral regurgitation is the most common combination present in the multi-valve disease arena. And the transcatheter intervention has changed and makes us think deeper in the sense that we know that mitral regurgitation is secondary in nature. It also made us look better at the valves and actually consider the morphology, consider the etiology of valve disease. Because if you treat the aortic stenosis, mitral regurgitation, which is secondary in cause, can reduce in severity, although mitral regurgitation, which is primary in cause, is not to be expected to reduce in severity, although symptoms may be better and the patient may be able to have the treatment delayed. However, the question starts to arise whether or not we should offer treatment of the aortic stenosis, which currently is the better established, with the best results in more hands all around the world, TAVI for aortic stenosis. To offer that even in less than severe aortic stenosis, or even when the aortic stenosis is borderline severe and we are sure that it is the primary mitral regurgitation that is the main cause of patient symptoms, we may consider or thinking about considering offering TAVI in these individuals to improve symptoms and delay the need for transcatheter edge-to-edge repair, or allow the left ventricle to reverse remodel in order to allow a better result of the transcatheter edge-to-edge repair. We have to also take into consideration that if we leave behind moderate aortic stenosis when we treat the mitral regurgitation, if we have an excellent result of mitral regurgitation treatment, we actually cause afterload mismatch of the left ventricle. So it may be that the aortic stenosis is significant for the patient in the peri-interventional stage and may allow a better preservation of the result if it was treated in the long term. The strategy for transcatheter intervention will depend on valve morphology and also on the severity of disease, and using a multimodality approach in order to establish the severity of the disease, because obviously if we have mitral regurgitation, we cannot characterize the severity of aortic stenosis by echo only. That will be low flow aortic stenosis, and we need a calcium score to characterize the severity of aortic stenosis in these patients, and probably to look into early treatment of the aortic stenosis to allow better treatment of the mitral regurgitation. And indeed, also in secondary mitral regurgitation and in heart failure patients, TAVI can be used to facilitate heart failure treatment. So in low flow, low gradient aortic stenosis, TAVI will not only facilitate the treatment of the second valve disease, it will facilitate better action, better treatment of the heart failure with medical management in these individuals. So my conclusion is that transcatheter valve therapies have caused and are in the process of causing further paradigm shift in the way we organize our strategy for treating heart valve disease. It can currently treat the untreatable by surgeons, the elderly, the frail, the patient with comorbidities. And being low risk, it can treat early without allowing development of secondary consequences on the ventricle and hemodynamics. It can treat in stages, can be easily repeated. It does not need to treat everything at once, and it can treat to facilitate further treatment. Thank you very much.
Wow, that was so concise presentation. I think I will need to watch it 2 or 3 times again when I go home to understand and take in everything you told us in this 10 minutes, Madalena. Thank you very much. Where can I start? Where can I finish? There are so many things you touched upon. Aortic regurgitation is an issue. In my career, I think the patients that fared worst after surgery were those with aortic regurgitation that was really terminal and very delayed presentation. So certainly I think for those patients, transcatheter therapy will give a solution. The obstacle so far was that we didn't have specific devices for aortic regurgitations. Now we have the first one that has CMAC, the trilogy valve, and hopefully this will give us more options in these patients. The problem with these patients is that if they're young, usually they have some anatomic variation in the aortic valve to have aortic regurgitation at a young age. And the only thing I want to ask you and to give us your light is what you said about the dilatation of the left ventricle in aortic regurgitation, that this doesn't happen so much in elderly and in women. And the reasoning behind that was that the LV, the stroke volume can be low, and also the properties of the aorta in these people. Can you
The properties of the left ventricle, the ability of the left ventricle to dilate is lost with age. It is clearly demonstrated in a beautiful study that actually caused iatrogenic aortic regurgitation in sheep, young sheep and old sheep. And it demonstrated lack of development of dilatation in the old sheep, which developed symptoms and developed heart failure, although the young sheep developed dilatation of the left ventricle and tolerated the aortic regurgitation that was iatrogenically caused. I am putting that out there because that makes us there are many colleagues, cardiologists around the world that are waiting for the elderly with aortic regurgitation to dilate the left ventricle. They tell them, you don't need treatment. Yes. Your heart is not big enough. Your heart is still small. Your heart is holding on. And it's not true because their heart will never dilate. They will be breathless. They will die in heart failure from aortic regurgitation. Also is because the heart is small and the stroke volume is small, the calculations from echo of regurgitant volume, we should be expected to be smaller. So the aortic regurgitation should be expected to be severe at a lower regurgitant volume than it is in the young, which develops a severely dilated bovine heart of the young with aortic regurgitation. So yeah, I think we need to look into aortic regurgitation with more attention now that we have a tool of treating them at low risk. Because I agree with you, the risk remains high in patients with severe aortic, severely impaired left ventricle with aortic regurgitation with surgical treatment. However, the risk is not as high with transcatheter intervention.
And the other thing you mentioned, and it became evident to us now, is that with transcatheter therapies, there is no need to go all over the problems at once. You can delay. So this divides the risks. And in these cases, I think 1 and 1 and 1, it makes 3. But if you go for surgery and to do all this together, then it doesn't go 1 and 1 makes 3, it makes 5 or even 6. Professor Tsoufis, your comment?
Yeah, First of all, congratulations for your amazing talk. We really like it. And we'll learn a lot. And we have, as Costa said, to learn more when we come back to your talk. I completely agree. This is the major advantage of interventional cardiology, not to do everything at once. The problem for the surgeons is that they have to treat at one stage or let's say, the problems. But on the other hand, what we have to do as an interventionalist, we have, let's say, to have a plan in advance for our patients. This is something that in some case we missed now. We treat, let's say, we have to treat the valve that is first priority due to the severity, but when we select a device, we have also to have in mind what we will do after 3 months or after 3 or 5 years, to have a plan. It's something that we have to take into consideration. Thank you so much.
Absolutely. Thank you. Thank you for inviting me.
And it's now time to go to the third presentation by Professor Dangas. If I understood well, this is already pre-recorded. TAVI in women, a very interesting topic.
Χαιρετισμούς πολλούς από τη Νέα Υόρκη. Λυπάμαι που για οικογενειακούς λόγους δεν μπορώ να βρίσκομαι μαζί σας σε το φετινό συνέδριο. Πολλές ευχές και πολλά συγχαρητήρια για μια ακόμη χρονιά εξαιρετικής παρουσίας στον ελλαδικό, πανελλήνιο αλλά και ευρωπαϊκό χώρο της Νοτιοανατολικής Ευρώπης για αυτό το συνέδριό σας. Λόγω των εξελίξεων της τελευταίας χρονιάς είπα να διαλέξω το θέμα της εμφύτευσης βαλβίδος, αορτικής βαλβίδος σε γυναίκες και ασθενείς με μικρούς δακτυλίους. So let's switch in English. So my topic this year is going to be TAVI in women and small annuli, given the very important data that we have published over the last several months since your previous Congress a year ago. Let's see what we know, first of all. Women in general don't seem to be doing that well after TAVI, at least compared to the expected longevity that you can see there with black line, and you can see the men in blue. They seem to be approaching that a bit more so than women. And the disease itself, the pathology, the anatomy, the pathological anatomy, one can say, is very different. Women seem to have more fibrotic valves, still stenotic, and men have more calcific. So that may lead actually to some underdiagnosis or under selection or under treatment for TAVI, just because it's not the classic supercalcific presentation. At the same time, the hearts themselves may be somewhat smaller in women, and the concentric hypertrophy may be more accentuated. These are the differences that you can see in ascending aorta, sinus, annulus, and LVOT. So although you can see the sinus and the aorta, they're sort of approaching each other, the annulus and the LVOT seem to be smaller, significantly smaller. Let's keep that in mind. In general, when we want to study something, before a very large study, we tend to do some secondary analysis or a meta-analysis of small studies. And as you see here, what's depicted is that in a meta-analysis of about 4,000 patients, the women seem to be doing quite a bit. Why could that be, though? Let's look a little bit further into that. And that could be also any differences between TAVR valves. A first trial, a small trial, pilot study, 150 patients or so. No differences in hemodynamics, patient prosthesis mismatch or clinical outcomes between TAVR and SAVR, TAVR in blue, SAVR in red, and you can see the gradients and the valve areas depicted in the screen. This is the Viva investigators from Canada. No major difference. However, there was a very interesting study from Europe, European study, the RIA study presented in European Society of Cardiology last fall. And it was very interesting, had about, was double the size or triple the size of the Viva. There were about 250 per group. And they used only one valve, the SAPIEN 3 valve Ultra, or the SAPIEN 3 Ultra valve. And we had a composite endpoint of all-cause mortality, stroke, or repeat hospitalization within 1 year. And you can see that very clearly that TAVI was overwhelmingly better than surgery in women. And again, as I said, women, in essence, means people with small annuli for the differences I explained to you before. And this difference is mostly due to the death and the rehospitalization. We're not really talking about difference in stroke there, and they're both about 3%. Regarding the PVL, maybe a mild PVL might have been a little bit higher with the TAVI at 30 days in 1 year, but the PPM, the patient-prosthesis mismatch, was very similar. Severe PPM, no difference, and moderate PPM also not so different. And not small size though, moderate PPM, about 17% of these cases. So could we focus and do something about those PPM, and what does it mean really? Should we be focusing any attention, paying any attention? That's where we come to different types of valves. There's some valves at the supraannular position, they may have lower gradients, may allow you, if you want, to place a one size higher valve, as we practically say sometimes. So the patient-prosthesis mismatch, first of all, is associated with female sex, small annuli, and small prosthetic valve size. Obviously, the three of them are confluent and interrelated with each other, because the annulus is small, we definitely want the small valve. You do a good job because you don't want to rupture the annulus and place in the big valve. So they may, in the end of the day, it just reflects again the anatomic differences of women that I showed you in the very initial slide with the anatomy of the ascending aorta, the sinuses, the valve, and the valve annulus and the LVOT. Remember that great slide? So it's all very, very important. Severe patient-prosthesis mismatch after TAVR is associated with mortality in general, and probably the same happens actually, as we know, with the SAVR. I'm going to show the data a little bit different. This is different studies, as you can see, different times, different investigators. Everywhere the message seems to be the same. This is the association of structural valve deterioration in the Australian Echo Registry, and we can see the differences of mortality at even at 5 years without no difference between SAVR and TAVR. Again, I may point that out that although sometimes we have more data because there's more research happening with the TAVI valves, this doesn't mean this phenomena and these complications are particular to the TAVI valves. They're just understudied in the SAVI valves, some of them. And when you study both of them, you can see they suffer from the same complications, same issues, smaller size, higher PPM, greater concerns later on. So the intra-annular valve in the preliminary analysis was indicated to be perhaps a risk for PPM. Of course, it's a hypothesis generating, and it generated a hypothesis in the SMART trial that was presented in 2024, one of the highlights of last year, with patients with symptomatic severe AS, the small aortic annulus, exactly as depicted here, stratified by a site and sex, about 350 patients per group in the self-expanding or balloon expandable valve, essentially the supraannular self-expanding or the intra-annular balloon expandable valve. These are the two valves they compared, and overall, the mortality disabled stroke or hospitalization, there was not much difference at 1 year. However, the prosthetic valve dysfunction, as defined primarily in association with patient-prosthesis mismatch, seems to be higher with the intra-annular balloon expandable valve and lower with the self-expanding valve. So due to the gradients and the orifice areas and all the various things, all of them essentially speak to each other because the definition includes either one or the other parameter. In general, there were low gradients of sizable gradients with the self-expandable valve. What does this mean? Well, maybe superior, but what does it mean clinically? It may mean something, particularly women. You can see there seems to be a little bit of a trend happening in the balloon expandable valve, greater events, clinical events at 1 year. And again, the same picture in the women sub-analysis. Most importantly, we have the 2-year data. So far, nothing budges. As far as the clinical events, it was presented in a conference just a couple of months ago at the New Washington, D.C. And you can all the events independent of each other and no difference in any of the events. Pacemaker implant always a little bit higher with the self-expandable valves. That's actually expected. Otherwise, the stroke and the prosthetic valve thrombosis is really small. It happened 2% perhaps in the expandable valve. At 2 years happens up to 4.5%. Still a rare event. Nonetheless, seems to be less so in the self-expandable supraannular valve, 1% or less of that. Most of them are subclinical though, so essentially it's a CT angiographic finding in patients with high gradients. So the high gradients translate to some clots in the valve sometimes, and again, this is, I would say, hemodynamic and imaging finding and phenomenon. These are the patient prosthesis mismatch that you can see as adjudicated by the committees, but again, I would say it's mostly, subclinical, as I explained to you before. And again, it's a concerning finding. We're going to see in later follow-up in a few years more, what does it mean as far as perhaps the duration of the valve, which is I think the holy grail of research of TAVI this decade. So my take-home messages, and many thanks for paying attention, a brief lecture. We have to be aware for the risk of adverse hemodynamics, a severe patient prosthesis mismatch, and high gradients associated with TAVI in women. It's very important, as well as, I would say, the same with a small annulus. Although 90% of the people with small annulus are women, so only a small portion of men really fall into this category. TAVI may be superior to SAVR in women with severe aortic stenosis and small aortic annulus, as depicted in the European multi-center prospective randomized trial RIA last year. And when choosing a TAVR prosthesis, there's active research as a sub-analysis of the secondary analysis of the SMART trial, focusing into the increased gradients with the intra-annular valves versus the lower gradients of the supraannular valves, and we continue to track what this means as far as clinical events and as far as valve durability. Thank you so much for your attention. Congratulations for your Congress, and I hope to join you on site next year. So long from you.
Yeah, this is a big discussion about the issue George presented to us now. We understand and we know from studies that in small annuline in women, the self-expandable valve offer better hemodynamics, but we don't know. But we know that there is no difference in the clinical outcome so far. So you can say that if I get a balloon expandable valve, I have a mean gradient of 15, but patients are not coming to us saying, doctor, I have a mean gradient of 15, I have a problem. So it's important to follow up these studies to see the long-term results, but so far I don't think they have a big clinical impact, and the better hemodynamic is something that we take into account in the algorithm of device selection decisions. So it's a plus towards these valves, but this is not the only one. So I think it's now time to move on to Professor Vardas, our coordinator, leader, an inspiring professor in the group here, and he's going to talk us about metaclinical medicine, a non-human physician and or surgeon, I would add. Is it unavoidable destiny, Professor Valdes?
Great. Thank you very much, Mr. President, Professor Choufis, Dr. Spargias. Since we have not any more time, possibly I could present this title and just to convey some messages to all of you. Metaclinical medicine and the non-human physician, an unavoidable destiny. Is this an audacious title? Trust me, not. This is the coming reality. Is this reality very futuristic? The answer is no. The reality is already here. And I have to confess that I enjoy year by year that the AI is presented more and more versus 10 years ago or 6 years ago. Anyway, I will try to be very brief, 10 minutes sharp. So, first, I would like to explain that this is my view. I have separated the trajectory of medicine in three main periods. The ancient one, which I call the Hippocratic medicine, the modern medicine, which is running since 16th century, 17th century, and especially 19th century. Please keep in your mind that a part of the Hippocrates, it is Andreas Vesalius, the main person related to modern medicine, while Hippocrates is related to ancient medicine. And in this modern medicine, thanks to the technology, we are enjoying a lot of advances like MRI, like genomic analysis, etc., etc. But there is something very true and very specific. Still, physicians have the decisive role for everything, for the diagnostics and especially for the treatment. Physicians have the right to take the messages of the advanced modern techniques, but as I said, the decisive role is in the hands of the physicians. So this is characterizing modern medicine. And then let's examine the next scenario, metaclinical medicine. I have introduced this international term. I have coined this international term, metaclinical, and the definition is clear. In this new coming era, a significant portion of the decisions will be in the hands of artificial intelligence. So, in other words, in the metaclinical medicine, physicians will lose a significant part of their decisive role. I know that this does not sound so optimistic for the professionals, for the physicians, in general, for the professional, for all those related to medicine and especially the physicians. But this is the reality. And of course, the physicians should discover their new role to be closer to the patients. So, what I am calling metaclinical medicine as a term to define medical developments from this point on is the entire spectrum of diagnostic and therapeutic medical science that will increasingly depend on digital technologies and especially AI, while human participation in observations and decision-making will diminish to play a less decisive role. Is this a scenario? Of course this is a scenario. It's not a current reality, but unavoidably this is what is coming. Not in the very distant future. It is coming between now and the next 30 to 40 years from now, the latest. So this is what I would like to pass to you mostly in this presentation. The three periods of medicine, the West medicine. I'm not talking about Chinese medicine and other regional medicines, but
at least in the West medicine, we have to separate three main periods: ancient, modern, and metaclinical medicine. What about, particularly talking about metaclinical medicine, what about the main areas of this period? We have to speak about big data and analytics, wearables and sensors, decision-making models, foundation models, artificial intelligence-enabled diagnostic therapeutics. Of course, even this is the first one. This area is already here, working already in many ways. Even at the Hygeia Hospital, I have to confess that the IVC area, but also the brain cancer area, diagnostics and imaging in general, gastroenterology particularly also, is working with artificial intelligence. Possibly you don't know this. So, just for an example, to understand what I mean, what if we could identify the electrocardiographic signature of atrial fibrillation present during sinus rhythm? Is anybody here who could identify a past history of atrial fibrillation in an ECG of sinus rhythm? Nobody. However, it is already 3 years now, Mayo Clinic, and then from South Korea the same, we have some very important and very credible presentations where they have the opportunity using 12-lead ECG to identify paroxysmal atrial fibrillation history even on an ECG during sinus rhythm. So somebody could say, and do we have superhuman capabilities then in the case of AI? Yes, the answer is yes. We are talking here about superhuman capabilities. This is why I'm talking that the decisive role of the physicians will be diminished. But this is not bad. This is not necessarily bad. Please, not panic. I'm talking about a transition of medicine. Just in very brief, to talk about digital twins. What is a digital twin then? A digital twin is a digital representation of a physical object or system. We are talking here about the real thing, and here is the digital twin. But this is not just a painting. This is functional. So using, on the right, there is a replica of a digital replica which is functional. That makes the life of the engineers very easy because they could make any experiment on the digital replica and not on the real thing, which is very expensive. I know that this sounds very futuristic, but as I said, we're talking about something which is coming. It's not ready yet. This is an interesting presentation published at the European Heart Journal, the digital twin to enable the vision of precision medicine. Yes, exactly. This is the scenario. To develop a digital twin replica for each case, for each human being, and using this digital replica, the digital twin of each one of us, to have the opportunity to know which kind of therapy is ideal for this particularly individual. Doctor Who. Inevitably, the question arises as to the future role of the human physicians. Unavoidably, the physicians will change to a significant degree. I'm not talking that we are going to lose the physicians and their role, not at all. But based on this new scenario, many things will be much more better organized. The diagnostic role of the artificial intelligence will be much more accurate. The digital data will be much better organized. And trust me, the developments are extremely fast and very, very important. In my opinion, in the question if the AI is going to replace the physicians, the answer is no. But those physicians who cannot understand artificial intelligence will lose their job. But, dear colleagues, Heraclitus first observed saying everything flows and our planet is a world of change. So, in conclusion, the advancements in artificial intelligence and a subset of a significant number of AI-enabled technologies inevitably lead medicine to extremely new perspectives in terms of diagnostics and treatment. Inevitably, because this is our destiny. This is the destiny of medicine. Imagine 80 years ago, we were talking about artificial neurothorax. Now it sounds like a joke, correct? So the role of the human physician, initially in internal pathology, will be minimized. I'm not talking about skills. I'm talking mostly about internal medicine first. Restricted due to the superhuman capabilities of artificial intelligence. Doctors will need to adjust their existence according to these dramatic developments. You see this picture? Do you know how much time the painter spent to make this picture? The painter is me. And the generative artificial intelligence is the doer. And it took to me 4 seconds to create this picture. I sent to the ChatGPT, dear ChatGPT, could you make a small animal like this one to read a lexicon regarding the AI vocabulary? By the opportunity, I suggest to you to start reading the vocabulary and the main jargon of AI, because it's absolutely necessary, especially for the young physicians. I like to be very short here. I have to stop here. But it took to me just 3 seconds to organize this nice picture. Imagine what is coming next. Okay, thanks very much. Sorry, I was very under pressure because it's too late now, and I would like to be very brief.
So what is your advice for the academic people? How this should affect the training of the younger doctors or the students of medicine today or of tomorrow? I think this should be like predicted from now, foreseen from now, because it will be late.
Okay, first I would like to start in very brief saying to Professor Tsoufis, who is, as far as I know, Deputy Dean of the Medical School in Athens. Today, the latest tomorrow, they have to change the curriculum of the medical schools. Even in the high schools, they have to start talking about all these things. I would like, Kostas, you have to remind you something very important. Generation Z and Generation X are different, okay? Generation Z, who is younger than the Generation 6, nowadays, amazing, is teaching the olders. Okay, this is one. Second, what about the AI natives? So, a child born today is going to be, to a significant degree, AI native. The AI natives will be totally different than all the rest. So, for those, the young cardiologists, my humble suggestion is start from today, working actively in everything related to AI, starting from the basics and progressively go in. As I said, the skills is different, but I'm not talking about your own subspecialty. Your own subspecialty is going to be dependent from AI very soon. I had a very interesting discussion before with Michalis Chrysoheris, who very cleverly told me how many gaps could be fulfilled because the artificial intelligence in the accuracy around your own techniques.
If I could say one word, first of all, congratulations for this amazing talk. I completely agree with your view about the role of physician, the role of patient in the area of metaclinical medicine. I am optimistic that in this metaclinical medicine, the physicians will be more happy than now, because we will do, or they will do, because we are not being the metaclinical era, our job in a more effective way, and maybe we will have more time for ourselves or their self. That is missing nowadays in a successful, let's say, physician. And also, for the patients, I think that the use of AI will, let's say, improve the financial resource in order to come back for the better care of the patients. Coming to the Costa's comment about the role of academic universities and so on, I completely agree. We have already been late to adjust our curriculum according to what is coming. And I think this will be the difference and the competition between the private and the public university. For me, this is not something that we have to discuss, but the main difference will be who will be, let's say, more adapted in this area.
Absolutely. We have to be positive.
Of course.
Because the changes are amazing, and not only for medicine. For example, lawyers have the same problem. Now, if you go, imagine 5 years from now. Now, if you have any legal, let's say, important query, you could ask ChatGPT, and it is coming out with a very advanced and mature answer, not just superficial. No. They are. I expect that in 5 to 10 years from now, the latest, a significant portion of the lawyer's work is going to be shifted to ChatGPT. Yeah.
Πώς το θέλει, Κώστα.
Στα ελληνικά ή στα αγγλικά θέλεις.
Επειδή χάρτη είναι. Στα αγγλικά. Okay. Good afternoon, everybody. Thank you for the invitation. We move now in a very interesting topic. It's about heart team in action. And we have two presenters, Professor Tsoufis for First University Department of Cardiology, Hippocrates General Hospital, which pioneered the field. Professor Tsoufis in research and in clinical practice, and so it's more suitable person to develop this issue.
Thank you, Yannis. Indeed, we will present two cases. Irini, my co-worker, Dr. Irini Dri, will present two cases that are challenging in our decision. We have discussed this in our heart team. Every day in Hippocrates Hospital, we spend about 45 minutes to discuss some difficult cases where we have debate which is the right, let's say, therapeutic approach. Irini.
Thank you very much. I would like to thank the organizing committee on behalf of the whole on behalf of the Hippocratic Hospital. We are going to present two cases which were done recently under the leadership of Professor Choufis. The first case is an 81-year-old female patient with worsening dyspnea and orthopnea, NIHA class 3. She was transferred to our hospital due to hemodynamic instability, and she was in constant need of inotropes. Her background consisted of an aortic valve replacement. She had an epic supra 19mm valve, 2011. She had a permanent pacemaker implanted, hypertensive, and dyslipidemic. She was on optimal medical therapy and under quite a few doses of diuretics. This is her ECG. Her pacemaker was working fine. As we can see from the echocardiogram, there is quite a moderate plus mitral regurgitation, and also the aortic valve, which was implanted. We can see here that it was quite stenotic with a mean gradient of 23 and a max velocity of 3.5 approximately. So, 14 years after the replacement of her aortic valve, the lady is having a dysfunction of the valve. As we can see here, after surgically implanted valves, the expectancy of the durability of the valve is approximately 10 to 15 years, very good one, but then we expect to have some problems with the valves. The same thing happens with the cases where a TAV is the first valve implanted. As we can see here, the durability and the all-cause mortality is almost the same in these patients. And as the population is growing older and older, more and more people are having a bioprosthetic valve instead of a mechanical one. When do surgical valves present for valve-in-valve? I mean, life expectancy of 10 years for most of the valves, except for when there are other predictors of early tissue valve failure, such as young age, renal failure, or the valve type is not the best for the specific patient. So we had a heart team convened, cardiac surgeons we have in our hospital, we're lucky about that, also intervention cardiologists, anesthesiologists, and imaging specialists, and we decided for an interventional approach as the Euro score of the patient was 15.5 and STS score 14.1. The guidelines agree with our choice as well because the patient was in high operative risk, to be precise. We had a pre-interventional CT. This is the coronary angiography of the patient a few days before the decision was made. And the two axes that we used was the right radial one and also the right femoral artery, as we can see. From the aortography, we can see that the valve was having quite regurgitation. And as far as our decision is concerned, here we can see all our options for the valve that she already had, and it had an epic supra 19. And we need to point out the fact that it is a fracturable valve that has a tissue annulus diameter of 19 millimeters, because it's quite important to know. So it's a porcine valve. And now we can see the procedures. We advance the new valve. And because there was aortic regurgitation, we decided for a balloon, an 18 balloon, to be inflated, as we can see here. And this is the final aortography. We were quite pleased with our result. Manta 14 French used in order to close the right femoral artery. And her follow-up echo, her ejection fraction was slightly under normal, 54%. The mitral regurgitation was now moderate. It was better as expected after the procedure. And also her PASP was under 40 millimeters of mercury. We see that there is a small paravalvular leak. And the max velocity of the aortic valve now it's 2.5 meters per second.
nice presentation. Very few short comments from my side. First of all, this was, we have to decide very under the pressure of the fact that the patient was admitted to the ICU with orthopnea, and despite the optimal pharmacotherapy, the patient is not continue to be unstable. So we had something to do in an urgent fashion. The second point is that the previous surgically implanted valve was 14 years ago. I would say enough time, because unfortunately we have seen cases after 2-3 years, or in some cases I remember 1 month ago, one case after, let's say, 6 months post-surgical implantation of the aortic valve. So this was good in terms of time. The third point is that, as Irene mentioned, after the successful TAVI, the degree of mitral regurgitation was reduced. Now the patient is have a follow-up for more than 6-8 months, if I remember well, and the patient is doing well, and no symptoms either related with the aortic valve or with the mitral valve regurgitation. That means that TAVI in an urgent situation due to the dysfunctional surgical aortic valve is a nice option, and the patient 1 day after, 3 days after the procedure, discharged from the hospital, and no new admission to the hospital in the last 8-10 minutes.
Is there any comment about this case? I can say that in this case, the heart team is working well. With
I completely agree.
There's no disagree. Yes,
Dr. Padagos.
Congratulations for this beautiful case. And again, the heart team. The heart team requires a lot of things, and especially for the younger generation, requires people to get together. In order to get together, they have to have a common goal, a common practice, a common construction, and less hypertrophy of ego. Because sometimes it's nice in the conferences to talk about our team, but sometimes our ego is against what's going to be the best of the patient. I can tell you one thing, just for your age only. A year ago, a patient was referred to me, and then it was so difficult that I had to do the heart team. The heart team decided against operating the patient and doing a TAVI. Do you know what the other referring physician told to me? Do you know what did you do? You just tried to prove that I'm wrong because I suggested surgery and you said something different. So, to conclude, in order this to function well, we have all to put our egos down and see what's the best for the patient. Thank you.
But nowadays, the heart team in the United States and European guidelines, it has received class 1 recommendation in all cardiology clinics. But I don't know what is happening in our country, about how it's working. Do you have any idea, any experience?
No, I don't have any idea, but in these lines, I think that it's a good, let's say, practice from our side, starting this registry valve in valve, because for first time we will now have, we will have data in the next few years about how many patients with dysfunctional surgical valves or with dysfunctional TAVI after a number of years will need a second procedure, surgical or interventional. I would like to ask Kyriakos, who also participate in this case, if you, Kyriakos, want to have a comment.
Good function of the heart team. In Hippocration, we have this tendency to communicate. And I think the fact is that we have more and more people who are also in the list for TAVI, and they come to our department with, cardiogenic shock. They are in very bad shape. So what do you provide to them? Just a bath? or you can also do the valve. And actually, in our group, we performed a meta-analysis, and we've seen that it is feasible to perform urgent TAVI, and we see they have 50% reduction of mortality when you do TAVI compared to valve. I mean, the registries that are already, we have the data. So this is also, I think, a point of discussion for the ones who take the decisions, if we can really do urgent TAVI in certain cases, because a lot of people do not get the treatment. Also, in this case, we had the ability to do the valve in valve. We have also the person with native valves. I don't know, Dr. Spargias, if you have any comment on that.
Yeah, I think there was one presentation, I don't remember if it was this morning or yesterday, with all the data showing that BAV nowadays is only when you don't have the device, the TAVI device, or you don't have the TAVI team. So if you're in a hospital that is performing TAVI, you shouldn't do BAV today. You should go directly for TAVI if you decide to intervene. And
but of course, sorry to interrupt you, there are logistical issues in order to go to implant a valve. There is an extra cost. Let's say you don't have sometimes approval from the committee, as you know,
yes,
particularly in urgent case. So,
but BAV doesn't have an effect. It has an effect of 1 or 2 months, and then you get the same risk. It has the same risk with TAVI. So you get a risk for nothing. So if you have the team and if you are performing TAVI, you must go all the way to do TAVI. And my comment for this case is that something we all know nowadays, that bioprosthetic valves, if they start to degenerate, they can degenerate very, very quickly, within a day or two. So these are the cases that even without symptoms, when you see a degenerated bioprosthetic valve, it's an urgent case by default. You should do it as soon as possible.
I think this is a main message, because I remember some case in the previous years when we, let's say, select wait and see strategy, it was a disaster. The patient died. So this is now our strategy. If we see such a patient, we have to do directly go for TAVI.
Sorry I don't mean to prolong that, but since we have your experience here, we operate people and we do believe that we're doing better. 10 years ago, we had some firms, some valves, that they're disasters and deteriorated so rapidly that in 2-3 years we have problems. And half of the TAVI cases are around those valves. Today, we do believe that we have valves that we expect 10 to 15 years life survival. So now you're telling us that, because we don't see our patients that often, that you can see patients for having the valve deteriorated in 2 years, and now you just mentioned 6 months. Did you prove anything what went wrong so a tissue valve to the surgical valve to deteriorate in 6 months? Did you find something?
I think this is multifactorial, but of course, I think that it is important the operator, the surgery or interventional cardiology, to do his best at any time. This is, I think, the major issue. In the majority of cases, I think that something went wrong with the selection of the valve. I mean, in terms of the size of the valve. For me, for us, we cannot do TAVI without CT scan. How many of you of the surgery asked for a CT before, let's say, doing a replacement of the aortic valve? I don't think that so many. I am quite sure if you have in your hands, apart from your great experience, the echo, blah, blah, modalities, CT, in order to select the appropriate size of the valve, I am sure that we will have less dysfunctional aortic valves, or at least they will last a longer period of time.
Oh, now we move to the next case.
Yes. The second patient is a 54-year-old man with resistant edema, multiple hospitalization due to recurrent heart failure, and he is in NIHA class 3. He has exertion-related syncope and spasms, despite the fact that he had a pacemaker implanted 2 years ago, actually. His background included a mitral valve replacement in 1999 with a mean gradient now at about 7 millimeters mercury. He has RV dysfunction and cardiac cirrhosis, and this is the reason why he had the tricuspid valve replacement with bioprosthetic Carpentier-Edwards 33 millimeters and right atrium reconstruction on 2013. The pacemaker was implanted to the left ventricle 2 years ago, and his comorbidities included atrial fibrillation, treated hepatitis B, mild pulmonary hypertension, and he had banded esophageal varices that he didn't have any bleeding episodes since 8 years. His medication included all this medicine. This is his ECG. He didn't have orthostatic hypotension. Here we can see we implanted actually a pacemaker to the coronary sinus. And a few months ago, he had a coronary angiography. As we can see here, there's no problem with the coronary arteries. And here are the transthoracic echo images, ejection fraction 45 to 50%, and there is a mild PVL and intravalvular leak in his mechanical mitral valve with a mean gradient of 8, and a mild aortic regurgitation as well. We can see that the inferior vena cava is dilated, and also that the tricuspid valve is stenotic with a mean gradient about 9 millimeters mercury. As far as the dysfunction of a valve, such as the one the patient have, we can see that most of the times it's stenosis the main reason for dysfunction, as well as regurgitation. And sometimes the patient has both mixed valvulopathy, and the need for reintervention after valve replacement, the tricuspid valve replacement, is 0.2 after 5 years. And we see that death has, there are not too many patients who died after the procedure. Now we have a heart team again. I should mention that the patient was assessed by an hepatologist and his stable liver disease, and we also had already done a CT in order to make sure that the angle between the inferior and superior vena cava and the tricuspid valve annulus was okay for us in case of intervention, and also in order to make sure that the right coronary artery would not, and the coronary sinus would not be impinged in case we intervened. So, as it would be the third time that he would have an operation to his heart, we decided an interventional approach. As we already had some experience with MyValve, we decided to implant a MyValve 29 millimeters. His Carpentier-Edwards 33 millimeters Magna had a true ID of 28.5 millimeters, and it's important to know that it's a fracturable valve. So, as far as the procedure is concerned, we used the right femoral vein axis.
Large was the right atrium.
An ambulance left catheter and room wire to cross through the bioprosthetic dysfunction, bioprosthetic valve, and then advance a J wire to the left pulmonary artery. As Professor said, it's a huge right atrium. Then we exchange the catheter to a multi-purpose catheter, and we advance the catheter to the pulmonary artery. After that, exchange to an extra stiff, actually Landerquist guide wire. And then we can see how slow the inflation is, and that the balloon is attached to the previous valve, and as it's inflated, it becomes even more vertical, and it takes its right position in order to make the procedure actually a success. We used a MyValve 29 millimeters balloon expandable valve using a 14 French Python sheath and a navigator delivery system, and under rapid pacing, actually, the patient was. We didn't need a TOE during the procedure. So this is the hemodynamic result. And as far as the echo is concerned, we can see that the ejection fraction is quite the same, and the mean gradient of the tricuspid valve is now 3 millimeters mercury. It used to be 9, to be precise. So, in conclusion, we would like to point out the fact that the number of patients needing valve-in-valve implantations are going to be more and more in the future because of the life expectancy. And the patient selection is always of very great importance, and proper multimodality imaging is necessary in order to make sure that we use the right tools actually and the right device we select for each individual patient. Thank you very much for your attention.
For the heart,
thank you very much.
It was not, let's say, difficult what to decide. The patient has undergone 1 time for the mitral valve, twice for the tricuspid valve. So now there is no other choice apart from, let's say, doing valve-in-valve. We are happy. The patient is completely now asymptomatic, and he has discharged, because this was the case last Wednesday. The patient on Friday, 2 days after that, was discharged in very nice condition.
So we have no time to thank you very much. Excellent presentation. We have to move to Dr. Niños in second Department of Cardiology, Euro-Balkan Medical Center. Dr. Niños is a pioneer in the field of interventional cardiology, especially in the structural disease, and now is going to present the heart team action in practice. Blasis.
Thank you. Thank you, Mr. Chairman. I hope you can see me and hear me clearly. Can you see my slides?
Yes.
Thank you.
Yes.
So it's a great honor to, on behalf of our team, and you can see our team there. Actually, the team is bigger, but I just pointed out the leadership, like the people that are key in making decisions about our patients. And I'm going to present 3 quick cases to highlight how important it is for the heart team to convene and discuss all the important aspects of complex patients. And I took the liberty, and I hope Kostas Spargias is okay with that, to change the title a little bit. And the cases I'm going to show will highlight when interventional cardiology comes to the rescue of cardiac surgery. And it is a bit provocative, and I hope that Dr. Patakos will not be angry at me. He knows how much I like him and I respect him, but we do see that from time to time that difficult situations in cardiac surgery can now be bailed out by percutaneous techniques. So let's have a look at this. So this is a first case. This is a young patient that we treated recently. He has diabetes, hyperlipidemia, and he had a recent NSTEMI, 47 years old. He ended up in our hospital with severe LV dysfunction, severe functional mitral regurgitation. You can see he had suffered clearly an inferior, maybe posterior myocardial infarction, but also the anterior wall was hypokinetic, ejection fraction was 30%. And the plan was to do a bypass surgery on this patient with diffuse disease and potentially MV repair. But what happened is, upon anesthesia induction, he went into cardiac arrest. So the surgical team had to act on that, put him on ECMO, and without giving any cardioplegia, they were able to do a triple bypass on him with success. But they didn't open the heart, they didn't repair on the mitral valve, which is probably the right thing to do. And we ended up on the patient in ITU, unable to be extubated on non-invasive ventilation, requiring significant dose of inotropes as well as IV diuretics on constant pulmonary edema. So we decided to go for a rescue mitral clip procedure in order to stabilize the patient. And this is how the heart looked like. You can see that there's a lot of MR. You can see the ventricular pooling of both leaflets, severe MR, central jet, A2P2 area, all because of ventricular tenting posteriorly You can see that all. And of course, lack of coaptation. Unfortunately, I didn't have the images during surgery, but it was really a nightmare. So we decided to go for the mitral clip, and we ended up, this is an XTW, you can see it's open. We are checking the grippers, and the anterior gripper is the one with the marker here. And we check the perpendicularity, and then we dive into the ventricle. And it's actually quite easy to grasp the leaflets, even with coaptation gap. Having these big devices in the old days when we had the NT clip, the small clip, it was very, very difficult. But actually grasping is very straightforward, and we're able to close very carefully under echo guidance, securing the leaflets in there. You can see the smoke on the left atrium, spontaneous echo contrast, the immediate reduction, almost elimination of mitral regurgitation, which actually had an immediate hemodynamic effect on the patient. So the inotropic dose was reduced, the pressure dose was reduced, and patient had a very quick recovery. I'm just showing some pictures, and then the left to right shunt from the transseptal puncture. These are the hemodynamic effects on the left atrial pressure. You can see the V wave was about 45 and went immediately down to 30. But the most important thing is that the pressure waveform in the left atrium was truncated from a rather ventricularized waveform. It went to a more atrial waveform with an AAV. This is the patient at 1 month. Prior to discharge, the patient also received a defibrillator and ICD. You can see the LV is still to recover, but the patient has actually done exceptionally well. Within the first 2 days, he was able to be weaned off all the support and go to the ward and be mobilized. I will remind you all that this was a 47-year-old patient who's actually now able to, we're able to escalate all the heart failure therapy for him, and hoping that with the perfusion and the heart failure therapy, his ventricle will have some recovery in the future. I don't know if you want to discuss the case.
Blasis, can I ask something in this case?
Of course.
Because the topic of the issue is the role of heart team, is the decision of the heart team correct in these patients to go for surgery?
Well, the patient required revascularization, and it was a diffuse. Unfortunately, I didn't have access to the coronary angiography, but it was a diffuse 3-vessel disease on a diabetic patient that recently had an NSTEMI. So I would agree. I mean, for me, you know, putting 4 or 5 or 6 stents on a young patient on a diabetic young patient is not a great idea. So I'm very happy with bypass surgery as a revascularization modality. Now, the big question here is whether you go for, in my opinion, of course, and that's open to your criticism, if you go for bypass as well as mitral repair or not. Here, the surgeon, who's, you know, Adonis Pitsis is a very experienced surgeon, didn't have the opportunity to go for mitral repair. It was part of the initial plan, I think, because the patient crashed on the table prior to putting him on a bypass machine. He did the on-pump without cardioplegia, and probably that was the reason why the patient came out alive from this operation. But the revascularization was adequate, and then the mitral clip, there's a lot of evidence about the mitral clip in acute MR. We have participated in a couple of studies. There is a big registry, a REMI registry, that shows that it's a very safe procedure and is actually a very effective procedure. So the question to you is it right to do bypass and MV repair during an operation as the guidelines suggest? Or shall we do the revascularization and do a mitral clip or a TEER procedure in the second stage? I mean, that's a question that is always in my mind.
Yes, thank you. Dr. Patakos.
No, okay. Good evening, Vlasi. This is Stratis Patakos. You actually didn't make me feel worse, actually better. It's nice that you... I'm durable in those, so during the years I've become very durable. Question, given my brotherly relation with Adonis Pitsis, I can ask him, I wish he was online so I could directly, given the fact that the ejection fraction was 30 and now is 15, I'm sure that the patient crashed. I'm sure that what he did was the right decision for the moment. But just for the sake of our conversation, since the patient crashed, the situation was very difficult. You can see him now with ejection fraction 15, so he is not the best possible situation. I'm wondering if the deterioration happened the next few days, 1, 2. How many days later you did the mitral clip?
48 hours after the
48
operation.
hours. These 48 hours were very detrimental for the myocardium. What would be the, and of course we don't know because experience is with time. What about if at that time, since he was on bypass, he had put a mechanical valve with and then a balloon probably, and then probably with bad results. But the ejection, given the fact that the ejection fraction was 30, he did the bypass surgery. What about if he had proceeded and replacing the valve? Something tells me that he might have a little bit better result. What's your opinion?
I don't know. I'm quite nervous in the prospect of replacing a valve in such a bad ventricle. And of course, you know better than me, but what would be the price that we would have to pay if we had put the patient on bypass and we had administered cardioplegia during the index operation? So I think Andonis, Andonis referred the patient to us to do it. So I'm not talking behind his back, but clearly if he was here, he would be able to explain his thinking process. But clearly he didn't want to administer cardioplegia. He didn't want to open the left atrium and replace the valve, the mitral valve. And I don't know, I have a feeling that the mitral clip in these acute situations where the ventricle is really, really poor, but non-dilated, this is the most important thing, it's probably a good thing because it has a remodeling effect on the subvalvular mechanism as well as the annulus, and is a durable and very low intensity intervention. There is also a pop-off effect. You can see it doesn't eliminate the mitral regurgitation. There's a little bit of residual MR, but probably is good for this ventricle. Now, what is interesting is that the ejection fraction looks horrible. The patient looks great. And we do see that when we do mitral clip procedures in this sort of cases, because the cardiac output actually increases. And for me, there is a prospect because I believe that he had the best revascularization possible, having grafting instead of stenting. I think probably this patient will do well, but it's early days to say. Maybe I will be able in the future to show his late outcomes.
Now move to the second case.
Just one more
second
comment.
case.
Just one more comment. Costas. Hi, Vlasis.
Costas, yes.
Hello.
Hello. Hi. Great case and great save. I think the whole process of doing things here was very logical and very radical decisions. Just in the last slide, I think I saw some considerable aortic regurgitation. Was it my idea or not?
Mild.
Oh, no, mild. Okay, sorry.
Yeah.
Okay, I was tricked. Okay, let's go to the
Let's go
second
to the
case.
second.
Dr.
All right,
Patakos
so-
is next to me waiting for the next case.
Okay. See, I made a special introduction for Dr. Patakos because I have so much respect for him, so I'm really nervous. But anyway, I'll move on. So case 2 is a 75-year-old female patient. She had mitral repair from mitral regurgitation. In fact, this didn't happen in our center, so in all disclosure, I'm going to say that. It wasn't clarified why she had mitral repair, what was the mechanism of the initial mitral regurgitation. There is this phrase that for possible mitral prolapse, which really, I don't know, it was 3 years before. The patient had paroxysmal AF, 6 sinus syndrome, and then about a year before she received a pacemaker DDD because she had a sinus rhythm as a baseline rhythm with bouts of AF. No coronary disease, and now she presents with severe MR and TR and recurrent admissions for heart failure decompensation. So this is the mitral. Now, you will be able to see on the left picture that there is a semi-ring. So you don't see a ring in the anterior aspect of the valve. There's a lot of MR. There's stenting of the posterior leaflet. But you might be able to see that there is some color going between the ring and the native annulus. And hopefully this is better highlighted in this clip here. But you can see on the right picture, there's a gap between in systole, between a part of the ring and the native annulus. So there is a partial dehiscence of the ring that doesn't support the posterior leaflet, which is tented. Actually, is moving still, but it's quite deeply tented into the LV. The LV is actually quite nicely preserved. You can see the dehiscence probably at about 7 o'clock here, but it's not a rocking ring and it's not a paravalvular leak. So it's a para-ring leak as well as a transvalvular ring. So the leaflet is the main mechanism here. It's all tenting. On top of that, there's a lot of tricuspid regurgitation. Actually, tricuspid regurgitation looks horrible and it's coming from the posterior aspect of the valve. We really tried a lot to interrogate the leaflets with relation to the wire. The wire was in the posteroseptal commissure and it wasn't really impinging on the leaflets. It was more a functional mechanism. So the plan here, after a lot of discussion, was to actually go and repair the mitral, which was the key aspect, but also look into the prospect of repairing the tricuspid and do that in the same setting. And we did publish our experience recently, about a month ago, of 42 consecutive cases performing with a single tri-clip guide both valves. It's actually safe, very effective. And it doesn't take a lot of time because the tri-clip guide is ideally suited for the tricuspid valve, but also for the mitral valve because it allows you to gain height and it has double steering, so it is even better for the trajectory. And this paper is here just to show the feasibility of that, and I know Abbott is planning on getting an Omni guide, like a single guide for both valves. So this is the procedure. Because the posterior leaflet was very short, it was 11 millimeters only, 10 millimeters, sorry, we decided to go with a small clip NTW in the middle of the valve. And actually it was very easy to grasp because, you know, having the ability to grasp independently the leaflets helps a lot. And you can see that we really got the leaflets in the middle where it was supposed to be the problem. And what was striking is that the mitral regurgitation disappeared almost. And we were a little bit concerned if this ring dehiscence will actually cause some additional regurgitation, but all it was doing was not supporting the posterior leaflet. So by putting the clip in the right spot, we actually did the job. And here is the final result. There is mild residual mitral regurgitation. What is very interesting is look at the LA pressure before and after. So it was 61, the V wave with a mean of 29. It was completely truncated, so V wave of 17 with a mean of 8. So that is really very promising for the patient. So we then withdrew the guide back into the right atrium. And when we do that, we always observe the behavior of the septum. So you can see there's a bidirectional shunt because the tricuspid regurgitation jet is actually directed to the septum. You can see this broad jet coming from below. And but the patient was stable. It didn't desaturate. She didn't desaturate. So we then went with the next DW clip to the sweet spot. You can see that there is some prolapse of the posterior leaflet, very close to the wire, but we are just central, just anterior of the pacing wire. On the right picture, you can see the wire is in the commissure. We are able to grasp quite nicely there. You can see both leaflets coming in. And we had a marvelous result, really unexpected. I was thinking of just reducing the regurgitation. And it was quite interesting that we had a left to right shunt. So this bidirectional shunt completely eliminated after we decompressed the right atrium by putting this clip in. And these are the pressures of the right atrium before and after. It wasn't a very huge pressure, but still enough to create this bidirectional shunt on the septum. So again, patient did very well and got discharged. I don't know if you have any questions or any comments about this case.
Any comments? What is the cause of the tricuspid regurgitation? Is from the wire or the?
That's an excellent question. We think it's functional predominantly in that the wire wasn't actually, it hadn't destroyed the leaflet or wasn't impinging on any of the leaflets, but it was very close to the wire. So normally you would see the wire being in the posteroseptal area and typically an anteroseptal jet coming as the cases we showed this morning, but this was very close to the wire. So I have a feeling that it was somehow interfering, and the plan was to go close to the wire and grasp the anatomy in this area, and hopefully this will do the job, and as it did. We've been a bit lucky in this case. Normally we wouldn't have such a great result very close to a wire, but it's always very difficult to tell.
Okay. Any question? No. We can proceed to the the third case.
So the last case is a TAVI case, and I hope it's interesting. So this is a 72-year-old female. This lady had 4 years before, at the age of 68, aortic valve replacement, and she received a Percival size M, according to the documentation. But she went okay in the first couple of years, maybe 3 years, but in the last year she's going deeply into heart failure with a couple of rehospitalizations, but she's really very sick. Diabetes, hypertension, chronic renal failure, and on the echo there was some moderate plus perhaps aortic stenosis, maybe low flow, but there was also some aortic regurgitation, so signs of early degeneration of this perceval valve, which was really bizarre. And we tried to find out why, and when we did the CT scan, we found this. So there is this heart-shaped malformation of the frame of the perceval valve. We thought that this was due to underexpansion. Why it was underexpanded, it's very difficult to tell because there's no calcium adjacent in this area. So perhaps fibrosis, but still, it's very difficult to explain this. But clearly this creates a diameter in this area which is almost 12 millimeters. And that was the reason for early degeneration, I think, because of malcoaptation and pinwheeling effect, etc., etc. Now, Percival, you've all seen this valve and you've treated it. It's a supraannular valve. The posts are these wiggly metal frames and the leaflets are quite high. So we had a concern of the relationship of the leaflets to the coronary ostia. The coronary ostia wasn't too bad. I mean, the left was at 14 millimeters, the right it was, I think, 11. But having the leaflets in a supraannular position was a little bit tough. So we thought we had two challenges here. Of course, we had the discussion within the heart team, and because the patient was very sick and it was a second redo operation, it was decided to proceed with TAVI. But we had two challenges. The first is to open up the frame of the perceval valve in such a way that we will not risk of rupturing the annulus, for example. And the second challenge was to put a valve in such a way that we preserve the coronary ostia. And we decided to go ahead and do that with double coronary protection, active protection. So we put a guide catheter using both radials. We put a guide catheter with an extension and a stent in the left coronary. You can see this guidegilla and the stent in there. And we also used the coronary wire and the stent on the right side as well. And you can see that there is a lot of aortic regurgitation even by just taking the shot on the coronary here. And then we just tried to find a view from the CT scan that we could see this indentation. On the left, you can see the indentation of the perimeter, like the base of the perceval valve, this dent at about 3 o'clock. But we wanted to see that profile somehow. We crossed the valve very carefully to make sure that we didn't go underneath the posts. And we used an Atlas 20 millimeters wire. You can see perhaps this indentation, this double shadowing here on the frame, how the Atlas wire is pushing it out. We didn't have to go too high on the pressure. And then we used an accurate Neo2. Why we used an accurate Neo2? First, we have a big series now using a surgical valve-in-valve with accurate Neo2. We've presented it and it's about to be published. We believe that it's a very good platform for valve-in-valve because it's supraannular, so it gives you a bigger area. You can do commissural alignment quite easily, and you do have access, maintain your access to the coronaries. The other thing with this is we had very clear markers of where to go. So the plan was to get the marker of the accurate, actually it's an accurate prime, not a Neo2, the accurate prime to go to the top part of the bottom stent frame of the perceval valve there. And you can see how we went and we achieved commissural alignment with 1-1-1 and 2-1 configuration on the 3-cusp and cusp overlap view. And then we just moved down to the desired post position. There, we opened up the upper crowns, the arches, and then the frame. We did that under rapid pacing to make sure we don't have any migration. It stayed in the desired location. It opened quite nicely. And then we just checked on the coronaries. The left was open as well as the right. And on the aortography, we didn't have any PVL and we didn't have any gradient. So this is the gradient before. Surprisingly, the gradient wasn't huge. It was almost 20 before, and it was about 10 or 11 after. But the patient actually is doing very well. The patient picked up on her activities without any problems, and she's doing better. So I will speak my conclusion. So the heart team approach is mandatory for treating structural and valvular heart disease. Of course, heart surgery has been the bailout method for interventional procedures, and it still is for sure. But the advancement in percutaneous procedures now have increased the potential for bailout in surgical complications or surgical unmet needs. I wouldn't say complications, I would say that surgical procedures that now have to be treated without surgery. And of course, a well-rounded multidisciplinary discussion prior to any management of this patient is mandatory. So thank you very, very much for your attention, and I'm very happy to discuss and answer to any questions.
Thank you very much, Dr. Nignos. Excellent work. Congratulations. We don't have time. Thank you very much.
Thank you.
You can come to close the remarks.
Καλησπέρα και από μένα. Για να κλείσει ο κύριος Σπάριας, εγώ θα πω πάντα μόνο 2 λέξεις. Ευχαριστίες για όσους συμμετείχαν. Είδαμε πολύ θετικά δεδομένα στην ηλεκτρονική συμμετοχή. Σίγουρα Σάββατο βράδυ δεν είναι η καλύτερη στιγμή για παρουσίες, αλλά γενικά το συνέδριο μπόρεσε να πραγματοποιήσει τους σκοπούς του, να έχει πολλούς συναδέλφους online. Να πω ότι στον Κώστα το Σπάρια, που είναι η ψυχή αυτής της ιστορίας, τα συγχαρητήρια. Έπρεπε να το αρχίσουμε με αυτό, στο εμπορικό τμήμα του Υγεία, μια μεγάλη αυτή, όσοι μπήκαν σε αυτή την αίθουσα, αυτή η αίθουσα έχει αυτό την direction, κοιτάζει προς τα δω, ότι βάλαν αυτό το πάνελ και αυτή την πραγματικά μεγαλοπρεπή οθόνη ήταν ένα επίτευγμα και έπρεπε να μεταφέρετε τις ευχαριστίες μας, παρακαλώ, σε όλη την... Έτσι, θα προχωρήσουμε όπως προχωρούμε. Οι διακαθηριακές βαλβίδες βοηθούν τον ασθενή, οπότε το μόνο που θα διαφωνήσω είναι ότι η καρδιοχειρουργική δεν έχει να χάσει από αυτά, έχει να συνεργαστεί, γιατί μένουν παλαιότεροι καρδιοχειρουργοί, στους οποίους ανήκω, έκαναν αυτό που έπρεπε να κάνουν. Η νεότερη γενιά είναι ήδη με το ένα πόδι στην κλασική καρδιοχειρουργική και το άλλο πόδι πάλι στο Transcatheter, οπότε η καρδιοχειρουργική έχει μόνο να ωφεληθεί. Και έχει να ωφεληθεί για ένα λόγο, γιατί πάνω από αυτό, γιατί πάνω απ' όλα ωφελείται ο ασθενής. Και όταν ωφελείται ο ασθενής, δεν έχει τη σημασία αν ωφελείται η καρδιοχειρουργική ή η καρδιολογία. Ευχαριστίες σε όλους λοιπόν και θα δώσω τον λόγο στον φίλτατο Κώστα Σπάρια.
Κύριε Παδεκέ, σας ευχαριστώ πολύ. Όπως είδατε και αυτή τη χρονιά είχαμε ένα πολύ ενδιαφέρον συνέδριο, 13ο στη σειρά, με πραγματικά μεγάλη συμμετοχή με όλους τους συναδέλφους του χώρου, από τον ελληνικό χώρο, αλλά και key figures από το εξωτερικό. Και ομολογώ ότι για μία ακόμα φορά το επίπεδο το επιστημονικό των παρουσιάσεων των ομιλιών ήταν εξαιρετικό. Τα περιστατικά τα οποία δείχθηκαν κάθε χρόνο βλέπουμε στο συνέδριό μας ότι γίνονται και πιο πολύπλοκα και πιο advanced. Οι συνάδελφοί μας αποκτάνε περισσότερο εμπειρία και βλέπουμε και συζητήσεις που γίνονται είναι πολύ πιο προχωρημένες καθώς περνάνε τα χρόνια. Και να ευχαριστήσω και εγώ όλους τους συναδέλφους που συμμετείχαν. Πάνω απ' όλα όμως θα πρέπει να ευχαριστήσουμε το team, το hard team και τους συναδέλφους, οι οποίοι ήταν πίσω από αυτή τη διοργάνωση και φροντίσαν για τα πάντα. Με πρώτο και καλύτερο τον κύριο Σταθογιάννη, ο οποίος ήταν η ψυχή του προγράμματος και της οργάνωσης φέτος, αλλά και τον κύριο Χρυσοχέρη που ήταν στο digital preparation όλων των live in a box cases που δείξαμε. Και με αυτά λοιπόν να κλείσουμε και το φετινό συνέδριο, να είμαστε όλοι καλά, να ξαναβρεθούμε του χρόνου τέτοια εποχή. Κύριε Βάρδα, και το δικό σας σχόλιο για το closing remark.
Καταρχάς σας πω συγχαρητήρια για το τμήμα που έχετε φτιάξει. Θέλω απλώς να πω δύο μικρά points. Ότι αυτό που κάνετε τώρα σε αυτά τα 8 χρόνια που είμαι στο υγεία και το καταλαβαίνω καλύτερα, είναι και επιστημονικό και στρατηγικό. Έτσι. Ήρθατε νωρίς στο υγεία, είδατε από την αρχή την καινοτομία, την προαναγγείλατε ουσιαστικά, δικαιωθήκατε, γίνατε ο δάσκαλος ουσιαστικά σε όλη την Ελλάδα και όχι μόνο. Στρατηγικά όμως, αυτά τα νοσοκομεία όπως είναι το νοσοκομείο Υγεία, που είναι το νοσοκομείο αιχμής στην επιστήμη και στην καινοτομία, χρειάζονται τέτοιες προσωπικότητες, χρειάζονται τέτοιες καινοτομίες. Αυτό είναι το βασικό που μένει στα δικά μου τα μάτια, εκτός από το τεράστιο επιστημονικό έργο. Θα έρθουν άλλοι, θα έρθουν και άλλα νοσοκομεία να μάθουν, θα δικαιώσουν, αλλά το παν είναι ο προάγγελος και ο άγγελος, είναι η καινοτομία, το οποίο εσείς αυτή τη στιγμή εξυπηρετείτε. Και βέβαια βλέπω και κάτι άλλο, ότι ό,τι κάνετε, το κάνετε πολύ καλά. Κάνετε αυτά τα courses κάθε μήνα. Κάνετε αυτό εδώ τώρα. Συγχαρητήρια, το λέω από την καρδιά μου.
Να είστε καλά. Σας ευχαριστούμε όλους.